Okay, so it's the second regional adolescent health Indaba, the RAHi in short. We have invited over 300 young people from across the country, all the 10 provinces represented, but we also have others from around the region. We have South Africa, we have Namibia, we have Tanzania, Uganda, Kenya.
And we shall put it together, that we work together, that this Indaba should not only happen in Lusaka. Let's have this Indaba in all the 9 provincial centers, so that the youths of Zambia who are out there must also hear these voices, must participate physically, must speak physically. And I have promised that in the next year's budget, I'll put a budget like for that. Honorable Minister, on behalf of all the young people and indeed on my own behalf, we would like to say a huge thank you and a youth thank you for finding time off your busy schedule to officiate this event. This indeed shows that you are committed to this cause. We really appreciate it.
This event is very important. This year's theme is focusing on closing the tap on new HIV infection.
For now, I'm happy that part of this program, this Indaba, persons with disabilities have not been left behind. They are also in attendance as in participating. So I'm happy.
You already pointed out that we have a number of partners, key partners in the room, some of the donors. Like we have PEPFAR, that's in attendance. We have UNAIDS, we have UNESCO, we have UNFPA. They are all in the room and ready to listen to the young people. HIVOS is also in the room. We have SAT Zambia in the room. We have CHAS that have also supported the event. So we have all these partners in the room that are eager to listen to the young people. This event is meant to provide an opportunity for young people to actually speak out, to present to the stakeholders and everybody else challenges they're facing, but also develop innovative solutions to the challenges they face on a daily basis.
First of all, I'm looking forward to seeing things change for the youth in Zambia under the program.
Just to state also, Honorable, that PEPFAR is actually one of the major supporting partners for this event. So they came in very, very helpful.
Okay, is that so? So next year, I told them we must not only do this in Lusaka. I want us to do this in all the 9 provinces. And I said we'll budget for them, and I hope you will be you will partner with us, not just for Lusaka, but the other 9 provinces.
Our push is to ensure that we enhance prevention, and we need partners to work with us. But we need young people to lead this process of closing the tap. Closing the tap of new HIV infection practically means enhancing HIV prevention interventions. That is important. And the reason why it's more important is because we can't continue mopping the floor while the tap is running. Okay? Like we can't continue treating those that are getting infected while we continue admitting more and more new infections, especially considering the fact that we're using borrowed mops in all these particular interventions. The ARVs, most of the ARVs we have are based on donor support. So we need to put in place interventions that can be driven by the young people, by the communities in order to address this particular challenge.
Studying on PrEP has really changed my life, such that when I completed college, I decided to be a PrEP mentor.
And for that, we're saying PrEP is going to enable the youths to have an HIV-free generation for today and for the future. With that, we say Zambia ends in AIDS by 2030. Voila!
Okay, so it's the second regional adolescent health Indaba, the RAHi in short.
What's the one way that you can use to describe the past 2 days? One word.
Awesome.
Awesome.
Gorgeous.
Gorgeous.
Extraordinary.
Extraordinary. Amazing.
Wow.
Educative. Special. Fantastic. it's been unbelievable.
Hi everyone, my name is Atumelo Musole and I have just attended the Regional Youth Indaba in Lusaka. It has been an amazing experience because this Regional Youth Indaba is looking at how we as young people can come together and be the drivers of the force. We are coming together as young people to discuss how HIV prevention can be created through innovation, youth engagement, as well as leadership. And I have learned so many amazing things and I would love for you to follow Zambia Youth Platform.
Hey everyone, my name is Edith Namsamba, coming from Onzayuna. I'm so happy to be part and parcel of the amazing young people coming from different walks of life just to come and attend this Indaba. So one thing that I was really excited about is seeing the inclusion of the differently abled young people coming to attend and coming to be abreast on issues pertaining HIV and AIDS.
So my name is Tapazila Banda. I am a law student at Mulungushi University. I'm so excited to be part of the Youth Indaba that is taking place today. Actually, it has been taking place for the past 2 days in Lusaka at Mika Hotel. The most thing I loved about this conference is how that youths were able to unite, and it was not just maybe Zambia, Western Province thing, it was a whole nation thing. And I love that. Not just that, how free we were able to discuss our issues, because, you know, as youths, people usually say we are not united. But I felt that sense of unity and that sense of impact actually happening. The theme has actually been closing the gap of the new HIV infections through meaningful youth engagement, leadership, and innovation. For me, go and become a meaningful youth.
What's the one way that you can use to describe the past 2 days? One word. Awesome.
Gorgeous.
Gorgeous.
1 2 1 2. Umezima hiyo nyingine? 1 2 1 2 1 2. Oh, yeah, ndio hiyo. 1 2 1 2.
What's the one way that you can use to describe the past 2 days? One word. Awesome.
Gorgeous.
Gorgeous. Extraordinary. Amazing. Educative. Special. Fantastic. Wow. Unbelievable. To me, it's been unbelievable.
Hi everyone, my name is Atumelo Musole and I have just attended the Regional Youth Indaba in Lusaka. It has been an amazing experience because this Regional Youth Indaba is looking at how we as young people can come together and be the drivers of the force. We are coming together as young people to discuss how HIV prevention can be created through innovation, youth engagement, as well as leadership. And I have learned so many amazing things and I would love for you to follow Zambia Youth Platform.
Hey everyone, my name is Edith Namsamba, coming from Onzayuna. I'm so happy to be part and parcel of the amazing young people coming from different walks of life just to come and attend this Indaba. So one thing that I was really excited about is seeing the inclusion of the differently abled young people coming to attend and coming to be abreast on issues pertaining HIV and AIDS.
So my name is Tapazila Banda. I am a law student at Mulungushi University. I'm so excited to be part of the Youth Indaba that is taking place today. Actually, it has been taking place for the past 2 days in Lusaka at Mika Hotel. The most thing I loved about this conference is how that youths were able to unite, and it was not just maybe Zambia, Western Province thing. It was a whole nation thing. And I love that. Not just that, how free we were able to discuss our issues, because, you know, as youths, people usually say we are not united. But I felt that sense of unity and that sense of impact actually happening. Theme has actually been closing the gap of the new HIV infections through meaningful youth engagement, leadership, and innovation. For me, go and become a meaningful youth.
What's the one way that you can use to describe the past 2 days? One word. Awesome.
Gorgeous.
Gorgeous. Extraordinary. Amazing. Educative. Special. Fantastic. Wow. Unbelievable.
Okay, so it's the second regional adolescent health Indaba, the RAHi in short. We have invited over 300 young people from across the country, all the 10 provinces represented, but we also have others from around the region. We have South Africa, we have Namibia, we have Tanzania, Uganda, Kenya.
And we shall do it together, that we work together, that this Indaba should not only happen in Lusaka. Let's have this Indaba in all the 9 provincial centers, so that the youths of Zambia who are out there must also hear these voices, must participate physically, must speak physically. And I have promised that in the next year's budget, I'll put a budget line for that.
Honorable Minister, on behalf of all the young people and indeed on my own behalf, we would like to say a huge thank you and a youth thank you for finding time off your busy schedule to officiate this event. This indeed shows that you are committed to this cause. We really appreciate it.
So this event is very important. This year's theme is focusing on closing the tap on new HIV infection.
For now, I'm happy that part of this program, this Indaba, persons with disabilities have not been left behind. They are also in attendance as in participating. So I'm happy.
You already pointed out that we have a number of partners, key partners in the room, some of the donors. Like we have PEPFAR that's in attendance. We have UNAIDS, we have UNESCO, we have UNFPA. They are all in the room and ready to listen to the young people. HIVOS is also in the room. We have SAT Zambia in the room. We have CHAS that have also supported the event. So we have all these partners in the room that are eager to listen to the young people. This event is meant to provide an opportunity for young people to actually speak out, to present to the stakeholders and everybody else challenges they're facing, but also develop innovative solutions to the challenges they face on a daily basis.
First of all, I'm looking forward to seeing things change for the youth in Zambia under the Young program.
Just to state also, Honorable, that PEPFAR is actually one of the major supporting partners for this event. So they came on very, very helpful.
Okay, is that so? So next year, I told them we must not only do this in Lusaka. I want us to do this in all the 9 provinces. And I said we'll budget for them, and I hope you will be you will partner with us, not just for Lusaka, but the other 9 provinces.
Our push is to ensure that we enhance prevention, and we need partners to work with us. But we need young people to lead this process of closing the tap. Closing the tap of new HIV infection practically means enhancing HIV prevention interventions. That is important. And the reason why it's more important is because we can't continue mopping the floor while the tap is running. Okay? Like we can't continue treating those that are getting infected while we continue admitting more and more new infections. Especially considering the fact that we're using borrowed mops in all these particular interventions. The ARVs, most of the ARVs we have are based on donor support. So we need to put in place interventions that can be driven by the young people, by the communities in order to address this particular challenge.
Studying on PrEP has really changed my life, such that when I completed college, I decided to be a PrEP mentor as well.
And for that, we're saying PrEP is going to enable the youths to have an HIV-free generation for today and for the future. With that, we say Zambia ends in AIDS by 2030. Voila!
Okay, so this is the second regional adolescent health Indaba, the RAHi in short. We have invited over 300 young people from across the country, all the 10 provinces represented, but we also have others from around the region. We have South Africa, we have Namibia, we have Tanzania, Uganda, Kenya.
We shall put it together, that we work together, that this Indaba should not only happen in Lusaka. Let's have this Indaba in all the 9 provincial centers, so that the youths of Zambia who are out there must also hear these voices, must participate physically, must speak physically. And I have promised that in the next year's budget, I'll put a budget line for that.
Honorable Minister, on behalf of all the young people and indeed on my own behalf, we would like to say a huge thank you and a youth thank you for finding time off your busy schedule to officiate this event. This indeed shows that you are committed to this cause. We really appreciate it.
This event is very important. This year's theme is focusing on closing the tap on new HIV infection.
For now, I'm happy that part of this program, this Indaba, persons with disabilities have not been left behind. They are also in attendance as in participating. So I'm happy.
You already pointed out that we have a number of partners, key partners in the room, some of the donors. Like we have PEPFAR, that's in attendance. We have UNAIDS.
Hello everyone, my name is Malambo Sivu, Executive Director for the Zambian Youth Platform, the largest youth network in Zambia. I'm here to formally inform you that the Regional Adolescent Health Indaba is back, the RAHi 2023. Last year was amazing. This year, look out, it will be bigger and better. In an effort to make it bigger and better, we'll be starting with some pre-conference activities. In partnership with Ministry of Health, we shall be hosting provincial adolescent health Indabas in every province across the country. This is one of the largest events that is organized by the young people for the young people. Please come and be part of it to ensure that your voice is heard. Come and discuss your health challenges, as well as be part of the people that are finding solutions to all the challenges that are affecting the young people today. So do look out for official details on how you can be part of that. To be part of this event, please do ensure that you apply using the link on all our social media platforms. I also want to encourage you to ensure that you register for the ZYP membership, because all members, of course, they get priority treatment. Remember, the theme for this year is closing the tap of new HIV infections through meaningful youth engagement, leadership, and innovation. You want to join? You want to be part of the event? Please remember to apply using the link on our website and all our social media platforms. I'd like to take this opportunity to thank all the partners that have already come on board in order to support this year's Regional Adolescent Health Indaba. A huge thank you goes to the Ministry of Health, PEPFAR Zambia, the Churches Health Association of Zambia, GSH, and many others that I may not have mentioned now. And we are calling on the other partners that have not yet confirmed their support to please join us. Sivu, Executive Director for the Zambian Youth Platform, the largest youth network in Zambia. I'm here to formally inform you that the Regional Adolescent Health Indaba is back, the RAHi 2023. Last year was amazing. This year, look out, it will be bigger and better. In an effort to make it bigger and better, we'll be starting with some pre-conference activities. In partnership with Ministry of Health, we shall be hosting provincial adolescent health indabas in every province across the country. This is one of the largest events that is organized by the young people for the young people. Please come and be part of it to ensure that your voice is heard. Come and discuss your health challenges, as well as be part of the people that are finding solutions to all the challenges that are affecting the young people today. So do look out for official details on how you can be part of that. To be part of this event, please do ensure that you apply using the link on all our social media platforms. I also want to encourage you to ensure that you register for the ZYP membership, because all members, of course, they get priority treatment. Remember, the theme for this year is closing the tap of new HIV infections through meaningful youth engagement, leadership, and innovation. You want to join? You want to be part of the event? Please remember to apply using the link on our website and all our social media platforms. I'd like to take this opportunity to thank all the partners that have already come on board in order to support this year's Regional Adolescent Health Indaba. A huge thank you goes to the Ministry of Health, PEPFAR Zambia, the Churches Health Association of Zambia, GSH, and many others that I may not have mentioned now. And we are calling on the other partners that have not yet confirmed their support to please join us.
Okay, so it's the second Regional Adolescent Health Indaba, the RAHi in short. We have invited over 300 young people from across the country, all the 10 provinces represented, but we also have others from around the region. We have South Africa, we have Namibia, we have Tanzania, Uganda, Kenya.
We shall put it together, that we work together, that this Indaba should not only happen in Lusaka. Let's have this Indaba in all the 9 provincial centers, so that the youths of Zambia who are out there must also hear these voices, must participate physically, must speak physically. And I have promised that in the next year's budget, I'll put a budget like for that.
Honorable Minister, on behalf of all the young people and indeed on my own behalf, we would like to say a huge thank you and a huge thank you for finding time off your busy schedule to officiate this event. This indeed shows that you are committed to this cause. We really appreciate it.
This event is very important. This year's theme is focusing on closing the tap on new HIV infection.
For now, I'm happy that part of this program, this Indaba, persons with disabilities have not been left behind. They are also in attendance as in participating. So I'm happy.
You already pointed out that we have a number of partners, key partners in the room, some of the donors. Like we have PEPFAR that's in attendance. We have UNAIDS, we have UNESCO, we have UNFPA. They are all in the room and ready to listen to the young people. HIVOS is also in the room. We have SAT Zambia in the room. We have CHAS that have also supported the event. So we have all these partners in the room that are eager to listen to the young people. This event is meant to provide an opportunity for young people to actually speak out, to present to the stakeholders and everybody else challenges they're facing, but also develop innovative solutions to the challenges they face on a daily basis.
First of all, I'm looking forward to seeing things change for the youth in Zambia and the young people program.
Just to state also, Honorable, that PEPFAR is actually one of the major supporting partners for this event. So they came in very, very helpful.
Okay, is that so? So next year, I told them we must not only do this in Lusaka. I want us to do this in all the 9 provinces. And I said we'll budget for them, and I hope you will be you will partner with us, not just for Lusaka, but the other 9 provinces.
Our push is to ensure that we enhance prevention, and we need partners to work with us. But we need young people to lead this process of closing the tap. Closing the tap of new HIV infection practically means enhancing HIV prevention interventions. That is important. And the reason why it's more important is because we can't continue mopping the floor while the tap is running. Okay? Like we can't continue treating those that are getting infected while we continue admitting more and more new infections, especially considering the fact that we're using borrowed mops in all these particular interventions. The ARVs, most of the ARVs we have are based on donor support. So we need to put in place interventions that can be driven by the young people, by the communities in order to address this particular challenge.
Studying on PrEP has really changed my life, such that when I completed college, I decided to be a PrEP mentor.
And for that, we're saying PrEP is going to enable the youths to have an HIV-free generation for today and for the future. With that, we say Zambia ends in AIDS by 2030. Voila!
pamozi ndi mtima umo. Tiende pamozi ndi mtima umo. Vayuthi tiende, vayuthi tiende. Pamozi. Oh, vayuthi tiende, tiende. Tiende pamozi. Thank you so much.
Good morning, everyone. Yeah, good morning, everyone. How are you feeling today? Huh? Awesome.
You're
Perfect.
not sounding like youth. You're very, very low. Good morning. Good morning. Okay, that's a little bit better.
Thank you so much for being on time. Let's be together. Let's have some silence. So thank you so much for being on time and gracing this occasion. The third regional adolescent health Indaba. And we are excited to have you again today. We just have two promises for you. One is that you have a great time, and two is that you have a great time. So I am your MC for today. Jambo. Yeah, hakuna matata. Okay, perfect. So we have to just give a quick recap of yesterday. Oh, Copper Belt is a country, aye. Okay.
Anyone from the Copper Belt? Bakopala. Laka.
And the rest of Zambia, hi. Okay, perfect. So we have to recap the day yesterday. Could you tell us something
that stood out for you?
So,
anything you remember from yesterday's discussions? We had from you guys, anyone in the audience that could tell us anything that stood out or any information that they got to know yesterday that they did not know before.
Perfect. We have someone.
Okay, great.
Good morning, everyone. My name is Msamba from Lusaka, Zambia. So what stood out for me from the presentations we had yesterday was the presentation from, should be PEPFAR. And she mentioned to say they will be piloting the new PrEP product, which is the CAB PrEP. And for me, I think that is a very good move. And for us to start that as a country, it might help in reducing the new infections.
My name's Kachana Deborah. Deborah Kachana from the Copper Belt. So, my take from yesterday's discussion was what the Honorable Sylvia Masobo was saying. Where we get to express ourselves. And if it's decentralized, there's so many people who'd love to be a part of this. And I feel it's so great.
Perfect. You are getting a gift, my friend. I think somebody deserves a gift also. Oh, now everyone wants a gift. So this is what we're going to do.
No, but I also maybe before.
Okay. Just before you lift your hand, I think let's give something to Musamba and Deborah first. Yeah, decentralized, and make sure you go to the districts and show off also that you're here. First time, tell everyone. So get your phone right now. Search for the Zambia Youth Platform Facebook page, and like the live stream and share. And those of you who will not be able to get your give your input today, will read comments during the day, and you also get your insights from yesterday, and then you tell a friend who's the hashtags prevention is bear. We spell in Amusha prevention. I think it's on hashtag RAHi 2023. But you have okay. So we can have the last.
We can take a last from I
But
believe
I think one more. We can get one from this.
She's been raising her hand. I think she was one of the first people to raise her hand.
Thank you. I was the first person to raise my hand, but you didn't just see me. Okay, thank you. My name is Fungai Mchoko from especially went to it from the deaf community that they are being left behind because of communication barrier. Most people, we don't know sign language, so it's difficult to communicate with them and to share information with them because all like sign language. So what wide, we should be everyone should be able to communicate with anyone. Like here, most of us here, if we have or 50%, so I learned and it's got to repair their cases in the police, in the clinics. They are not getting the right. Some of so I think information should be spread everywhere and no one left behind. So we should learn
how some Zambian traditional leaders are being involved in the prevention of HIV and AIDS in the communities. I think that really has a great impact because those traditional leaders have an influence
a little bit more of recap tomorrow, but for now we'll end that session. So in the meantime, like my colleague said, please do go on the online platform ZYP and share, and we may have a surprise for you. Share and comment. And also, just around the room, we do have these QR codes. We have one for Meaningful Youth engagement survey. We did give a little bit of briefing yesterday. So also have another one on share your stories. And for those that would want to get updates yesterday, there's also another QR code. Just look out for it. I think it says updates, event updates. So scan that code and just find your pictures and just updates of how the event is going. So also I would like to mention the services outside. Zomani, would you like to share a little bit more information on that?
Of course, and so as you are scanning the QR codes, some of you are struggling, but yeah, we'll all get there. Remember that the Indaba is not just happening right here. There are amazing exhibition stands. If you go straight out where you're doing your registrations from, there's an exhibition. Nice organizations are exhibiting there, and then across the entrance, just
right. So also the exhibition booths in the
I put it here. Yeah, yeah. Yeah, yeah, yeah. I take the bowl. I take the bowl. I put it here. I put it here. Yeah, yeah. Yeah, yeah. Thank you.
Thank you so much. Thank you so much. La Copa La Laca. Okay, so now we're going to get into the session. And as we mentioned earlier, this is Pepper Zambia Meaningful Youth Engagement Session. Okay, so as I mentioned, I would like to welcome Thank you. So we're introducing the Meaningful Youth Engagement panel discussion. So this is hosted by the U.S. President's Emergency Plan for AIDS Relief, which is PEPFAR. And PEPFAR is the U.S. government's global effort to combat HIV and the largest commitment by any nation to address a single disease. So adolescents and young people, as we know, being one of PEPFAR's focus areas, PEPFAR's participation in the RAHi is a prime opportunity to hear from you as young people in Zambia to understand the best ways to engage youth with the goal of reducing new HIV infections that are linking those who are at risk to prevention methods and just providing HIV treatment to those living positive.
Thank you very much. So today's panel actually consists of PEPFAR focused PEPFAR partners that are focused on reducing HIV infections among adolescents and young people, and those that are focused on increasing access to information on HIV and services for the deaf communities. On this panel, we also have participants of the PEPFAR Condom Innovation Challenge, which was a challenge that was designed to solicit youth-led solutions that will help increase condom use among adolescents and young people. We also have on the panel members of the civil society that are representing pregnant and breastfeeding mothers and adolescent girls and young women. These members were part of the PEPFAR country operation plan COP process. And for those that don't know, let me just inform you that PEPFAR works with the government and civil society to come up with a plan, to design a plan. And this year we have designed a 2-year plan that sets out PEPFAR's strategy. And over the next 2 years, the United States government through PEPFAR has actually committed a total of $760 million. And this money has been set aside to support Zambia's national HIV and response and ending AIDS as a public health threat. I think we should get an applause for that. Woo! Are you sure? That is an upload towards the amount of money that has been set aside to end HIV AIDS. Can we do better?
Woo! Okay.
Thank you.
And earlier, there was an individual that spoke about the injectable PrEP that will be in country. So PEPFAR is going to actually procure about, is it 2,000 to 4,000 doses? That is the injectable PrEP. So that is just amazing. We're so excited about the COP23. So I think at this point, please help us welcome our panelists. And just as Miranda mentioned, these panelists are coming from CSOs. Also, just there was some initiatives that were implemented. And to welcome the first panelist, this is Karen Musonda from Condom Innovation Challenge. Karen, please come through. A big round of applause for Karen.
Okay, so the next person we're inviting to the panel is Muyunda Kaonga. And Muyunda Kaonga is also from the Condom Innovation Challenge.
A big round of applause. Let's welcome our panelists. Okay, the third panelist that would like to welcome is Dr. Maurice Musheke from CIDES USA, Checkup One. also under Dreams program. A big round of applause for Dr. Morris.
Also join me welcome Dave Allensby, who is a sign language channel from the sign language channel of Zambia. A round of applause, guys.
Okay, we also have our panelists from the CSO, Mwenya Chiti, the ED for the Executive Director for Pakama Africa. Please welcome Mwenya.
Please also welcome Natasha Nakanika from Zambian Youth Platform. So these two panelists were part of the COP process for 2023.
And just as Natasha and Mwenya, myself and Miranda, we were also privileged to be part of the COP23 process. So we were also delegates who were in Joburg to be part of the COP23 process. Okay, so thank you so much to our panelists. As they settle, let's just give them another round of applause, please.
Okay, so just to start the panel, our delegates, we will be asking a few questions to our panelists. And after this, maybe we'll have some time for a Q&A from the general public. So I'll just start with the COP delegates. We'll just like you to describe your experience participating in the COP planning process. What were your expectations and what were some key outcomes that you would like to share with us?
Okay. Thank you very much, Miranda. Like I was introduced, my name is Natasha Nakanika from the Zambian Youth Platform. So firstly, I would like to appreciate PEPFA for the opportunity of engaging the CSO delegates at the co-planning meeting. It was a very a great platform for us to learn and to share our experiences. So at the co-planning meeting, we were given an opportunity to participate in identifying issues or priorities that that we feel affect adolescents and young people. And these priorities, we were not just getting them from without. So upon appreciating the PEPFA team, I'd also like to appreciate the CSO constituency that selected me and all the young people that went to the co-planning meeting. Yes, so during the process, the young people and myself were not only just going there to attend, eat, and do anything. We were really involved in the process. The process was a really tough process, but we were involved day and night. We were not sleeping. We were making sure that all the priorities that were given for adolescents and young people are delivered. So during the same process, we would stay in touch with the constituency that took us to the Joburg planning process. So it was not just that we are going to the planning process and then we are going there as individuals and doing what we think is right. We'd communicate to the people that we're working with, even when we were back in country. So the process was not only physical, it was also virtual, where we'd meet with everyone from across the country and other stakeholders. I'll leave Mwenya to also add on.
Good morning, everyone. I said good morning. Do we have young people in the house? Good morning, ladies and gentlemen. That's more like it. Thank you. Just to add on what Natasha said, the COP23 process was very engaging, and we had me and her were privileged. Me, her, and Natasha and Miranda were privileged to be part of the delegates that were representing the youth in Zambia. So what we did there wasn't just like she said. What we presented there, it wasn't just based on what Moya is doing, what Natasha is doing, or what Miranda is doing, but rather voicing out the position of the young people in Zambia. Uh, Consultations were done prior to this, like she earlier alluded, and what came out also was that the most important part is that for the young people, we were given a platform to voice out and speak on behalf of the youth here in Zambia. So everything that we presented there was a success for us, and it's good. I'm happy to announce that our voices were heard, our cries were heard, our demands were heard, and we even had a chance to meet with other youth delegates from other countries. And from that, we even had a session where we got to interact and exchange notes with other young people from other African countries. Thank you.
Thank you so much from the CSO Youth Delegate. So since okay, no, please, a little bit energetic, please. Thank you so much. Okay, so since the Indaba is just not happening in this space, we have participants online that are commenting and sharing. We would like to hear a little bit of what they're saying and commenting online. Could we have something on screen? Okay, so since they're setting that up, I think I'd like to now pose this question to the participants of the Zambia Condom Innovation Challenge. And my question to you right now would be, why did you decide to participate in the Condom Innovation Challenge? Tell us about your solution and why you think it would appeal to young people. Karen, would you go first, please?
Thank you. Good morning, everyone. Okay, so my name is Karen Sonda, and I was part of the Condom Innovation Challenge. So to answer your question, Natasha, the reason why I decided to participate in the Condom Innovation Challenge is because I wanted to be part of the solution. I wanted to, I'm in health, I'm a third-year biomedical science student, and I wanted to create an impact in my career path. The other reason is that there's somebody who mentioned about the theme for this year. I wanted to be part of the solution in closing the tap on new HIV infections. The numbers are scaring and they're over the charts. So it was very much of relevance to me to be part of the Innovation Challenge and create a solution. And I'm happy to announce that we were among the 25 applicants that were selected out of 300 applications. And my team and I came out as the first prize winners. Thank you for that. So our experience was networking. The networking was amazing. We're engaged, and we were happy to be part of a space where we can discuss about challenges that we as adolescents and young adults are facing. Feel free. It is an initiative that is supposed to portray condoms as fun, vibrant, and a normal part of sexual responsibility without the fear of judgment. One thing, during our survey, we understood that 83% of our 83% of our audience informed us that the reason condoms are easy to access, but the reason that there are new HIV infections every now and then is because they are afraid of being judged. So our solution was to portray condoms as fun, vibrant, and a normal part of sexual responsibility. At the same time, we are trying to change the mindset of young adults and adolescents. We want to have condoms branded in a way that we as young adults and adolescents can relate to. Imagine if a pack of condoms can look like your favorite box of perfumes. It's something that you can relate to. Or your favorite can of Coca-Cola, or something that you as a young adult can actually relate to. So that's where our focus part is. At the same time, we want to advocate for the change of placement of condoms from points of sales to shelves. It's if we will feel like it's easy for young adults to queue that are waiting with you. So that was our solution. So we have the long-term solution is to change the mindset of young adults to be free when accessing condoms, because safety definitely has a new look. Thank you. Wow, isn't that interesting, guys? Who would want to receive a package wrapped nicely, delivered by one of these riders that we have in Lusaka and maybe other provinces? I think that's really interesting. I'd like to see more innovations coming from this RAHi, from young people, because it's for the young people and it should come from the young people. So this is awesome. So I'll move to the next question. Can you share some examples of how PEPFAR is currently engaging young people in the HIV response? That goes back to the COP delegates. I'll just give you 2 minutes to respond to this question. Yeah, so just share some examples on how PEPFAR has been involving young people in the COP process. I know you're among the young people that were involved, but just give a few examples. And if you could also advise on how PEPFAR Zambia can engage more young people in the response.
All right, thank you very much for that question. So, like I alluded earlier, I was saying that throughout the process, PEPA has been engaging adolescents and young people like myself, Mwenya, Miranda, and Natasha during the co-planning process meeting, where we would actively be involved in providing input and contributions throughout the co-planning process. So with the level of high pressure that this territory comes with, we would stay, like I mentioned earlier, we would stay in touch with people back home to make sure that we are able to give correct information, and then as we are advocating also would advocate for the right information. So during the co-planning meetings, we would not only have virtual or in-person meetings, we would have, like every time where Pepper would include us from the planning, from the day one of the inception. We went there and prepared the program. We went there to prepare what was like the priorities we're going to speak to when we go to Joburg. So we started from in-country preparations, as well as also when we went to Joburg, we were given a lot of opportunities. Like one I could speak to is when we were given an opportunity to meet the ambassador, Dr. John Kengerson. Sorry if I mispronounce. We were given a platform to advocate with the ambassador of the PEPFAR. So during that engagement, we had also various opportunities where we would sit with stakeholders from different countries, also hearing about their priorities, also from our own countries. We were not only with the paper team, we had a lot of people, a lot of stakeholders from different organizations. We had UNAIDS in the house, we had Global Fund in the house, we had CDC in the house. So it was like a big platform for us to advocate for the rights that we feel adolescents and young people are lagging behind, and then also just speak to what we need to see.
Okay, thank you so much, Natasha, for that response. I think this time I would like to hear from Deb.
And the question that I have is, what are some of the unique challenges and barriers that deaf adolescent girls and young women face in accessing HIV prevention and sexual health services? And how have you worked with PEPFAR to address some of these challenges?
So first of all, my name is Debbie Allenby, and I volunteer for an organisation called Sign Language Channel of Zambia. We're an NGO that supports deaf education here in Zambia. So some of the challenges that young deaf women and adolescents are facing is that many deaf children struggle to read well. Part of the problem is that we learn to read and write through spoken language, and a deaf child has never learnt, never heard spoken language if they've been born deaf. So that's a challenge, that a lot of HIV information is actually presented in a written format. It might be a poster, it might be a leaflet, or maybe it's in a verbal form through TV or radio. So that makes it very hard for someone who's deaf to actually access HIV information. A deaf person, their first language is sign language. And so if information is not presented in sign language, then it can be a real challenge. We've also found as well that at hospitals here in Zambia, there's not sign language interpreters. So that presents a problem. Many parents who have deaf children don't actually know sign language, so they struggle as well to be able to perhaps give sexual health information or HIV information to their children.
All right, thank you very much for that information. So we can see that people are online and they're participating and they're very attentive. I can already see a comment online from Kisulanji Sikanji, who says sign language interpreters are important. So our online participants, thank you very much. Keep commenting and keep participating, continue being attentive. So we'll move to the next question, and this is directed to Dr. Mashike. Could you please provide insights into the specific strategies, approaches of the DREAMS program that will employ to effectively engage deaf AGYW in the design, implementation, and evaluation of HIV prevention interventions?
Thank you very much. Before I talk about some of the interventions that we've planned to implement or that we are already implementing, let me just add on to what Debbie has mentioned in terms of the challenges and the barriers.
All right.
She's highlighted the challenge of communication. But beyond that, there's also stigma. The deaf experience stigma and discrimination. And for the deaf, they even carry what you might call the double burden of stigma. One, they are stigmatized on account of their disability. Then worse still, they are stigmatized when it comes to issues of sexual and reproductive health because of the misconception that a deaf person should not be sexually active because of their disability. Yeah. Then crucially, the deaf also experience abuse. Last year during the International Week of the Deaf, we had the experience of engaging with a number of the deaf adolescent and young women. And what we noted was that the deaf actually experience a lot of stigma, not just at community level, but also at household level, where they are treated as useless on account of their disability, where they are regarded as a burden. and that in a way affects their access to health, not just health services, but also other means of uh, of, uh, of looking after themselves, whether we're talking about engagement in productive economic activities. So as a project, what we've decided to do, as I indicated yesterday, that one of the big programs that we are implementing as Checkup One is the Dreams program. And this is a program that is driven by the adolescent girls and young women themselves. And I wish to indicate, for instance, that under Checkup One, we have over 400 adolescent girls and young women that are working on the program as mentors, as connectors, and also as coordinators. These are full-time staff working on the project. They lead the design, the planning, and the implementation of the activities in the 7 districts where we are implementing the intervention. But on account of our experience engaging and talking to the deaf, what we've planned now is to ensure that we also include those with sign language knowledge or expertise to work on our program as mentors. We feel by bringing those on board, that will help mitigate the challenge of communication. So that within the Dreams program, and by the way, in the Dream centers, we also provide sexual and reproductive health services. These include HIV testing, it includes family planning, it also includes provision of condoms, but also crucially, doing active referrals to the government health facilities. So we believe that by bringing the deaf on board, or those with experience in sign language, that will help improve access to sexual and reproductive health services among the deaf adolescents and young women. Thank you.
Thank you so much for that response, Doctor. And now, at this point, I would like to pose this question to Karen and Moyonda. Doctor mentioned that there's need to bring to the table partners. We need to collaborate in turn to mitigate some of these challenges. So my question, I would want to know, Karen and Moyonda, what could PEPFAR Zambia or any other partners alike, even in private sector or just the Ministry of Health, what could they do to help in order to scale up innovative solutions, even to include the deaf community and other communities that are vulnerable and marginalized?
All right, thanks very much for that great question. So basically, I was also one of the participants at the Condom Innovation Challenge, and we came up with a very, I come from a tech background myself, so I'm not very much in the area of, I'd say, maybe HIV to say. So there's need for collaborations, bringing in different stakeholders from diverse backgrounds. So in terms of of course, partnership, is that there's need basically to have more stakeholders team up and a team up basically. And this is some of the things that we actually learned during the Condom Innovation Challenge. For instance, I can talk about our solution that we came up, which is called Lilato. So Lilato basically is a gamification social community app that is designed to connect young people to basically enable them learn and share reliable information on HIV prevention products and services. So part of the solution that the platform offers is that we provide live chat counseling. So through live chat counseling, basically we can partner and collaborate with peer educators to actually come onto our platform and actually provide these live counseling. Because just from the survey here, I can say that most people are actually on their phones. You know, most people are always on their phones. And from the statistics is that we spend about 7 hours per day on our phone. So why not create solutions that reach young people? You know, young people are always on their phones basically. So we came up with basically our solution to say, you know, we can create a platform, me as someone from a tech background, and then we can partner in with people people that are actually in the provide these solutions to people that are actually in the in the space that provides education and awareness, and they can actually use the system. So basically, there's need basically for everyone, because this is like we are all involved in one, and there's need to bring in diverse people from different background and come up with innovation solutions for us to actually reduce basically issues of HIV and AIDS.
Okay, thank you very much. So you see, there's a call for more young people to participate in this. So if you are interested, you can see me or you can see him directly and he'll be able to assist you. Yeah, so I'll go to the next question, and this question is directed to you, Mwenya. I would like to find out, in your opinion, what are some of the most effective strategies or approaches for empowering and mobilizing young people to take an active role in the fight against HIV/AIDS? Natasha, if you have something to say afterwards, you can just give me a signal. But for now, I'll give it to Mwenya. Thank you.
Thank you so much for that question. So I would love to take it back home at the grassroots level. We're talking about mobilizing. We're talking about everybody playing a role in ensuring that we meet our targets. Ladies and gentlemen, my fellow young people, the youth rather, the most I feel the most effective way we can go about it is through community-led initiative or activities. This creates a platform where it starts from us as the young people. We initiate these programs, we take the lead. So I feel the bottom-up approach is the best way to start with. First and foremost, in our communities, where we're coming from, what are the challenges? What problems are we seeing out there? What are we doing about it? Are we comfortable? Are we okay with what we are seeing? That should be our first level of analysis. The second level is, what change do we want to see? The moment we realize what it is that we want to see, the difference we want to bring out in our communities, the next step is be the key player for that. Okay, and also I love to also write on the pointers that have been raised, like the initiatives we have so far. We have the Dreams Project. The Dreams Project is something that we can look at and see how far the progress they've made from the time the Dreams Project was initiated. Ladies and gentlemen, it's safe to say that through such initiations, through such innovations, activities, it will help us get to meet our targets. That's the 95, 95, 95 also. And also another thing that, I would like to bring out is the issue of if we take a leading role in sensitization, mobilization, and advocacy, we shall ensure that there'll be a reduction in stigma and discrimination, thereby also increasing our adherence statistics. We'll get, by so doing, again, it's also going to give us a target of ensuring that we get to virus suppression. So these are just some of the things that I feel we can really look into. And like we're saying, PEPFAR has given us a platform. They are supporting these programs, and from time to time they get to call out, send out proposals. So this is also another opportunity for us as young people to have our voices heard. Whatever activities, whatever innovations we can come up with, ladies and gentlemen, this is our time. This is our space. An opportunity has been given to us. It's about time we step up and take the lead. Thank you.
Thank you very much, Mwenya. That was very clear. And this is an opportunity that has been given to us as young people. This RAHi has brought young people from across the nation because we want to hear from young people. What are those innovative solutions that you have? What are those ideas that you have? What do you want to see in HIV programming? What is it that you want to see improve at the facilities? We want you to give us those solutions here. It is starting from here and it will go up. She is talking about the bottom up, and this is what bottom up is all about. So over to you, Natasha.
Thanks, Miranda. So as of now, we are going to, I will ask one question and then we'll get to Q&A session. But I'd also like to mention that we do have ushers in the house, and there are situations where questions are being asked and not all are responded to. So I would like all the people that have questions to raise their hand. Just raise your hand and an usher will come over and give you this. So please write down your question and who you are addressing that question to before we get to the question and answer session. But for now, I would like to pose this question to Dr. Msheke and Debbie. What role do you believe youth advocacy and leadership play in shaping effective HIV prevention and treatment strategies? How can young people be better supported in these roles in line with just comprising of all the communities that young people represent?
Thank you very much for that question. Let's look at our context. If you look at most of our structures, whether it's political structures, whether it's community structures, the composition of those structures is predominantly held by older people, whether it is older men or older women. So if we are talking about youth, as youth getting engaged in all the processes, I think the most important thing is we need to start thinking about how do we ensure that we penetrate these different structures that are involved in the design, the planning, and the implementation of different programs. When we talk about neighborhood health committees, just as an example, how many of our youths are actually members of those neighborhood health committees? You literally have to shake your head. If you talk about ward development committees, how many of our youths are actually members of those ward development committees? I think a crucial starting point is to ensure that you push the agenda of representation of the youth on all the different structures, whether political or non-political. And this is crucial within the context of decentralization. We heard from the Honorable Minister yesterday when she talked about health services or the district health offices now being devolved to the local authorities. So what it means is that power is now being devolved to the local structures. And this is where I think we need to start making our impact, because that's where resources are being channeled, whether you're talking about CDF resources, that's where decisions are now being made. So it's very important that as youth, we start identifying those influential local level structures and ensuring that there's representation by the youth. Thank you.
Okay, so I'm just going to ask a last question to Deb. I would just like to find out if I would like you to just give us some examples of how partners implementing HIV prevention and treatment programs can ensure that there is full engagement of the deaf young people and others with disabilities in these services.
It's really important the information is available in sign language. When a deaf person goes to a centre, maybe to be able to access HIV information, it would be best if there's someone that's deaf there, that's a deaf person is working there. That would be very important. For example, if someone tests HIV positive, that deaf person may not want to speak through an interpreter all the time. They might want to have a one-to-one conversation privately. So that's important that deaf people are employed either as mentors or trainers. We'd love ultimately to see doctors and nurses that are deaf. That is what is around in other countries. That would be amazing. And then a deaf person could go to a hospital, talk to a doctor about HIV and not have to use an interpreter. We think that videos can work well, sign language videos work well. So when we partnered together with PEPFAR, we won a small grants program in 2021. and we ran workshops in schools for deaf children. And we made 8 HIV videos with the support of PEPFAR, and they were all in sign language. The workshops were all in sign language. We had deaf trainers. We did role play, pictures, games, and the HIV awareness was really raised because of that project and the support of PEPFAR. So it's really important to make sure that any services that are provided for people, young people, that the deaf are included, and that deaf mentors are there to be able to support the deaf person that comes for those services.
Thank you so much, Deb. A round of applause for her, please. It is very important what she said to really, they say leave no one behind, right? And persons with disabilities are being left behind in many ways, especially in service provision and access. So at this point, we'll get into question and answer session. Do we have any questions in the house? So we'll take 2 in here and then we'll go online because we do have an online audience, and then we'll come back to the room. Okay.
Good morning, everyone. My name is Moses Soko. Once again, I'm the president of the Zambia Deaf Society, and myself, I'm a deaf person, and I'm the president of the Zambia Deaf Society. I've been following the discussion on the issues of sign language and deaf people, but what has caught my attention is the thought that health care services, for example, at the hospitals or health center, we need to have sign language interpreters. I want to beg that I do not agree, I beg to differ. Yesterday, remember, we had a discussion about inclusivity. What does inclusivity mean? Inclusivity means whenever there is an event or a program, any program, the person who is affected should be there, meaning the person who is attending to deaf people should be able to sign. That's what we want. So as deaf people, we need health workers or everyone, all the stakeholders to respect us, whether we are educated or we are not educated. Even if we are deaf, we ask everyone to respect our wish. And our wish is that if you sign, very well, and then I'm a deaf person, you'll be able to attend to me. But if you engage sign language interpreters in hospitals, that will make a lot of health workers to avoid sign language because they'll be depending on an interpreter who is available. But if there is no interpreter, that would encourage the health workers, like the doctors and the nurses, to learn sign language, that you'll be able to attend to a deaf person. So there is that confidentiality. As a deaf person, I want to be with a doctor, just the 2 of us in the room, not others. For example, what if I've got a sickness, maybe my private parts, there's a problem, the doctor wants to check my private parts, and then I have to address in the presence of an interpreter. So I think what we are advocating for as deaf people, as Zambia Deaf Society, our organization advocates for developing a Zambian sign language curriculum to be introduced in health schools, like nursing schools and medical schools, so that the health workers should be able to sign themselves. For example, if a woman is in labor, and then you call an interpreter to be interpreting, you say, push the baby, the head is almost coming, push. The interpreter is interpreting to my wife. How will that look? That doesn't look well. No. So I think respect to the deaf means confidentiality, and the best way to go is that having interpreters is a very good idea, but except in a health situation. Everywhere else, it's very good to have a sign language interpreter. Everywhere else, it's okay, but when it comes to health, it's a health workers to sign. Thank you so much. That's what I have to say.
Thank you very much. That was a wonderful contribution. I believe that was not a question. I can see a lot of uploads from persons with disability, and they are really happy with the representation that they have. So we're going to go to the next question. So this should be a question, and we're only giving you a minute in which you can ask your question. So we'll get the first question.
Thank you so much. My name is Axilia Swanda, the Dreams Ambassador from Lusaka Province. So my question goes to all the panelists. So I feel rather much
concern is being put on the deaf people. So what is being done for the blind people? Let's say, for example, in our dream centers, we have services like if you're teaching them how to use a condom. So do you also have those services that can like help them know how to use a condom or how to insert a condom? Yes, thank you.
Okay, so I guess that question is directed to you, Debbie. Okay.
I
So
think
that's for the
the
dream.
question was that a lot of focus has been around deaf. So how are we including other persons with disability in line with our service provision?
Thank you very much, Dr. Musheke.
Thank you very much. And Moses, thank you very much for that important point that you've raised. And I hope it will be part of the recommendations from this gathering so that the minister takes it up with his with her technocrats to see how best that can feed into the revision perhaps of the trainings of not just nurses but all the healthcare providers to ensure that they are actually competent when it comes to matters of sign language. Now, yesterday we were talking about inclusive programming. I know this morning we are talking about the deaf, but when we talk about inclusive programming, we are not just talking about the deaf, we are not just talking about the blind, we are not just talking about others that have other physical disabilities, but we are talking about ensuring that the programming is actually is all inclusive. In other words, the services that we are providing are actually targeting all the different subpopulation groups, regardless of the age, regardless of the sex, and also regardless of their physical status. So as we think about how we design and plan our interventions, we should always take into account that we have different segmented subpopulation groups, and all interventions should ensure that they represent those groups to ensure that no one is left behind in accessing sexual and reproductive health services. Thank you.
Thank you so much for that response, Dr. Msheke. So I think at this point we will take 3 questions and we'll see if we'll have time to take another round of questions after that. So hands, please. 3 more questions and then we'll check online if we have any questions.
Okay, so as Natasha is identifying the person to ask the next question, I think we can go to the one online because it's ready. So the question reads, by Youthi, my question goes to all the panel. What are you doing over prevention of HIV in intersex youth? Keeping in mind, intersex people have different biology. Okay, from everyone. So if we condomize, I guess that's what they were trying to say. They are unable to use them. So I don't know who can respond to that question from the panel.
Maybe for now as they are gathering their Miranda, maybe we can take 2 questions and that one will be the third so that he answers all the questions together.
Okay, good morning, everyone. My name is Tumsani Ngwenya from Zimbabwe. My question to the panelists will be, I think I missed the definition of what is meaningful youth engagement. And the other question will be, in a decision-making table, as young people or as youth, what are we? Are we the table? Are we the agenda? Or we are just participants? Are we equal stakeholders in the decision-making table? So this is a question that we want to understand as much as we are talking about meaningful youth engagement. Are we being fully engaged in the negotiation table? Thank you.
Thank you so much. I see the crowd is in agreement with that. So we'll take 1 question. I believe all the questions are directed to everyone on the panel. So please put your thoughts together.
Good morning, everyone. My name is Taonga Kamanga, Dreams Ambassador, Eastern Province. This is not a question, but a recommendation, and it goes to everyone because
I believe they are all provinces present in here. We're talking about issues of stigma and discrimination in here. I remember I attended the COP 2022 planning meeting. So my recommendation would be if we can come together as youths and have campaigns that are going to fight stigma in our various provinces, because the fight should start at individual level, family level, hospital level. So what are you doing as a province to ensure that we fight stigma? This has been coming up every year during the Indaba. But what strategies have we put in place? We are the ones to ensure that we keep the fight against stigma and discrimination. Thank you.
Okay, so because due to time, we have to wrap up. So I'll only take one question. Please let it be a question and not a recommendation or a suggestion. For now, we will still take recommendations.
Yeah, so I'm James Mwale, representing Unzayuna. So I have a question. Yesterday, the Minister of Health, in her speech, she said alcohol abuse and substance abuse is one of the leading causes of the spread of HIV. So I have a question to the panelists. What are you doing to ensure that there's a reduction in the alcohol abuse and substance abuse?
Thank you for that. Miranda, can these questions that have been asked be answered? I believe we have 3 questions.
Thank you. I'll take the first question on intersex. What are we doing with the intersex community? Just to highlight that, as you may be aware, PEPFAR funds different programs. So there are programs specifically focusing on adolescent girls and young women through the DREAMS program. There are programs focusing on adolescent boys and young men, for instance, through the Coaching Boys into Men program. But there are also programs that focus on key populations. I don't know how many of us have heard or aware of key populations. So these key populations, for instance, that are targeted under PEPFAR funding, of course, in line with the National AIDS Strategic Framework, includes reaching out to female sex workers, includes reaching out to men who have sex with men, includes reaching out to people who inject drugs, and it also includes reaching out to intersex. And their organizations, key population civil society organizations that are funded to support the mobilization and reach of these population groups with sexual and reproductive health services. So I think what is key is identifying which partners are implementing which programs to reach which particular subpopulation groups. I think that way then it address the question that has been raised in terms of what is it that is being done to reach, for instance, the intersex. Then there was also a question on meaningful youth engagement. What does that really entail? As you may be aware, when it comes to participation, there are 2 forms. There's what you might call active participation and passive participation. Passive participation is where decisions are being made by others and you are just being engaged, either to be informed or to be engaged in order to validate what has already been decided. But what is crucial in terms of meaningful engagement of the youth is where the youths are actually sitting at the table, being involved in decision making, being involved in the design, being involved in the implementation, and also being involved in the monitoring and the evaluation of those interventions. And that brings me back to the point that I raised earlier on, which is to what extent are we as the youth involved in the different decision-making structures. For instance, at community level, I gave an example of neighborhood health committees. I gave an example of ward development committees. We also have district development coordinating committees, provincial development coordinating committees. To what extent are we as youths actively involved in those structures, sitting around the table to deliberate and provide input on all matters or related to development, whether it is health or economic development. And for as long as we are not actively sitting around the table on these different structures that make decisions, then our participation will always be passive. Thank you.
So maybe you can just elaborate more on that, because I know in the audience we have young people who would like to participate in the neighborhood health committees, and they would like to also be involved in other platforms of decision making. So there are some questions here where young people would like to find out how they can be part of the neighborhood health committees, especially that there is no space for everyone. So those that are not directly involved would like to find out how they can be involved. And others would also like to find out how they can reach out to get involved in these processes. Maybe it could be other decision-making platforms that have to do with their health and things like that, the adolescent health programming. And they would also like to find out if there's any sensitization that is being given to adolescents out there on how they can get involved. Dr. Masheke, please.
That question made for me?
Yes, please.
Okay, thank you. So structures such as, the most important point is we need to identify and know these structures. That's the most important point, because you can't be part of a structure that you are not aware of. For instance, if you talk about neighborhood health committees, each neighborhood health committee is linked to a government health facility. The neighborhood health committee is basically an extension of the government health facility, because it creates dialogue between the communities and the healthcare providers. And I'm aware that in some health facilities, there are youth-friendly corners. So I think that would be a good starting point, where there are youth-friendly corners, to ensure that they're engaging with the different in charges of the health facilities, to ensure that there's representation of the youth or the adolescents in these neighborhood health committees, because that way then it will ensure that those youths or adolescents that are part of these neighborhood health committees are then used to reach out to other adolescents and youths in their respective communities. Ultimately, what is key also is we have youth-led organizations. We have organizations like ZYP. We have organizations like Coparos. Those are useful platforms, organizations that as youths we should get ourselves affiliated to, as a way of building and strengthening a coalition that ensures that we are actively engaged in all the processes, whether it's at community level, at district level, or at national level. Let's participate and ensure that we are members of these different youth-led organizations. And there's strength in the numbers. And once we are members of these organizations, that will definitely create a platform for our voices as youths, or your voices as youths, to be heard in all the processes of decision-making and program implementation. Thank you.
Okay, thank you very much. Natasha would like to respond to another question that was written down. And the question says, this question is for you, Natasha. What solutions or implementations did you guys come back with from Johannesburg during the COP process?
Okay, thank you very much for the question. So I would like to speak to two things, which is one, the age of access, because we all know that we have the age of consent, that anyone who's below the age of 16 is supposed to go with a guardian or parent to go and access HIV services. So we advocated during the co-planning meeting that we reduce or change the name for the age of consent to age of access, so that we allow adolescents and young people that want to access services. We all know that adolescents and young people are sexually active out there, and then who wants to go with the parents to the facility to go and access HIV testing or prevention services, because we all know that before you get a preventive measure or PrEP, you're supposed to test for HIV. So we advocated for that. We are still following up for that so that the age could still be reduced, because they've only changed, we have only changed the name and we haven't really changed the age. So we're still following up on that, which is like a positive response. And then the second point I'd like to speak to is Zambia was announced to be one of the countries to receive injectable PrEP. So we all know that we have oral PrEP, but during the co-planning process, Zambia was announced to be one of the countries that is going to be receiving injectable PrEP. So you don't have to take like PrEP every day, but you take it okay, so I was just confirming how many months. I didn't want to lie. So it's 2 months. So you go to the facility every after like 2 months to get your injectable PrEP, unlike you taking the oral PrEP every day. Thank you very much.
All right, so this has been very interesting. Would have loved to go further and ask more questions and have most of the panelists here respond to more questions. But because of time, we have to end here. For those that still have questions, please feel free to see me and I'll direct you to the person that you would like to ask the question to. For our online participants, thank you very much for the active participation. We acknowledge your participation, but unfortunately, we were given very little time that we could not engage you more. So just in closing, I'd just like to get some closing remarks from maybe 2 or 3 panelists. And this is going to be done in 30 seconds, please. Thank you.
Okay, thank you very much. So this goes out to each and every stakeholder in this space. As we are sitting here, we've heard that there are a lot of young people who are sitting on the table. So are we the menu? Are we the stakeholders? So I would like to request or suggest that during the stakeholders meetings, we are given a space where a lot of adolescents and young people are able to represent fellow young people, because it's going to be hard for us young people to ask for change when a lot of people in the room are big people. Like we have 100 big people and then we have only 2 young people representing the AYP. So it's going to be hard to advocate for change because we have big people defending each other, and then I'm alone with Mwenya. We're unable to defend each other. Okay, so on the last remark, I would like to say thank you to Pepper for engaging us during the co-planning meeting and also after the co-planning meeting, which is the post engagements. Thank you very much.
Yeah, just a quick run through. In my conclusion, I think I would also just love to highlight the fact that it's important for us in order to keep in mind with our meeting our targets, and we can only meet our target if we all move together as one. And this is also through integration of our service delivery programming, and also just the fact that as young people, let's take the lead, let's be innovative. As we've been said, a challenge has been thrown to us, so it's up to us now to take up the lead. Let's show them what we're capable of. Let's not just be used for tokenism purposes. Thank you.
My concluding comments are a huge thank you to PEPFAR for trusting Sign Language Channel of Zambia with a project to be able to reach deaf children. Our project only reached those in schools, and we saw the effect that those children came away with HIV awareness. They knew how to prevent it. They knew how it spread. We discussed stigma and discrimination. They got a good education on HIV. But that's just one place where we've reached youth. And we're reaching youths that perhaps have not become sexually active yet. So we would love to see that that project goes to different places and we reach deaf students in other provinces so that they can have that same education and this next generation can not be having HIV. Thank you.
In conclusion, I'd like to say there is strength in numbers, and there is strength in collaboration, and there's also strength in engagement. So all of us need to constantly engage beyond just this event that we are having today and tomorrow. After that, we need to constantly engage, and certainly success will be on the horizons. Thank you.
I would like to give thanks to PEPFAR for the opportunity that they gave us, even the things that they are doing even up to today. I would also like to thank Bongo Hive, Zambia Health Initiative, as well as End Zambia campaign in absentia for the opportunity as well. I think we can all agree that HIV-related issues are urgent and they are worth addressing now. And in that sense, usage of condoms is more of a marketing and branding issue. So I'd like to call upon partners as well as every one of us in this room that future initiatives with HIV-related issues should be aimed at changing the mindset rather than changing the accessibility of condoms. Remember to feel free because safety has a new look. Thank you.
Yeah. Yeah, so in terms of basically youth engagement is that we are also happy to inform you that CDC and PEPFAR actually reached out to us. They want us to co-create and pilot our solution in Eastern Province. So it shows that there's more and more of this, we are getting engaged in more and more of these solutions basically to co-create together. And then in terms of course, social barriers, breaking social barriers, there's need to create more innovation solutions basically to reach young people. Like imagine you're in your bedroom and then you're receiving live counseling, you know. So those are some of the spaces. Young people basically need more young people. So I'd like to say thank you to PEPFAR for inviting us to come here. Thank you.
Okay, thank you so much. A round of applause. You guys have been amazing. A round of applause for our amazing panelists. Can we do what do you call that? A kilo for our panelists. What kilo can we give our panelists? Parliament kilo. Okay. How'd you do it? Parliament kilo. Another one as they leave the stage for us. Thank you. You've been amazing. Parliament kilo. Parliament kilo. Amazing, amazing. Thank you so much for participating. You've been amazing. So at this point.
Thank you so much. I think let's give the panelists as they sit another round of applause. Perfect. And I'm just going to read a few comments from the people that are watching us online. Helen Keith Cosmas Manda says, engaging parents and helping them to be freely talking about sexual education with their children by giving them adequate information. Thank you so much for your comment, Helen. I have a gift for you. Malala Mujuta says, this program is really amazing. I'm really learning a lot of new information and getting a chance to interact with other people from in and out of Zambia. All in all, I can say, Zambia Kochalo. Thank you so much, Malala. I have a gift for you. And lastly, we have, oh, perfect. Lastly, we have Asa the Elephant. Hey, this program is really, really powerful and vivid to youths, adolescents, and parents as well. Advise all youths in Zambia that they should follow up exactly this page. Thank you so much, Asa the Elephant. Ah, what a name. I have a gift for you. You should come and see me after. Perfect. So before we get to our next panel on data trends, which will be presented by UNAIDS, I would like us to do an energizer, but this time it should be different. Our colleagues from
Zimbabwe, Kenya, anyone to teach us something new? We're tired of local energizers. Anyone from Zimbabwe, Kenya, Botswana?
Namibia, Eta.
Oh, okay. So we already have a kilo. I mean, an energizer from out of the country. So just in the meantime, just a reminder: please do scan the QR codes that are around the room when you can, just to get the events updates and just to respond to the survey as well. And if you feel during tea break or lunch it's going to be too much for you, you can just step out and access services outside or in the other room.
Thank you so much. And as we are getting ready for the next panel, we have so many questions, but you agree with me, if we want to exhaust all the questions, meaning ZYP would have to keep us here for a month, which is good, but I think we've got other things to do. So what we do with the questions is, please keep posting the questions online. Our very and send them to the ushers, and our very innovative tech team will be there to direct them to the people responsible. And above all, remember to comment, share, and we'll still be able to give you more goodies.
Okay, so our next session, we're going to have a presentation from
UNAIDS, and then it will be presented and moderated by the one and only awesome Max Omumba. Let's give him a round of applause as he comes across.
Thank you, Zumani. Thank you, Tasha. RAHi! RAHi! I want to see the energy. I want to feel the energy in the room. RAHi! RAHi! Yeah, that's the energy I want. My name is Max Omumba. I'm coming from Sitam Plus, and I'll be your moderator for this session. Indeed, data is evidence. Indeed, data is reality, and we can't do without data. And in this session where we are going into, I want us to critically think, critically analyze, and critically ask those critical questions, isn't it? The next presentation is going to be done by the UNAIDS. Of course, Tasha, which is good. At often energizer, I want to. Who can give us a perfect energizer? Or a good energizer? Yes, you can come through, you can come through. Should we all stand? For now, no? Okay. Yeah, I love the energy. Yeah. Yes.
So when I say homoe, we say hey, homoe. Homoe. Nikakamba wakabona kashiriti tishika. Hey. Let's try. Homoe. Hey. Homoe. Wakabona kashiriti. So we need the buzz. So we are going to stand to do hey. Hi. Energizer. Ready? Homoe! Do I need the mic? No. Homoe! Homoe!
Thank you very much for that energizer. Okay, so can we have our seats, please? Thank you. At least we have stretched a bit and we've talked a bit. I know we are running behind time, and the next session is very, very important. The next session is very, very important, that will need much of our participation in it. I don't want us to lose much time on this session because it's one of the sessions that I've always wanted to chair, something to do with data. So as I'll be introducing my panelists and we'll have a presentation from UNAIDS like I mentioned earlier, it would be good that we give them a round of applause as they come to the podium. So let us welcome Madam Caroline Olwindi from UNAIDS to come and the podium, please. We can have Mr. Mubanga Chumumbwa to come through, please. We can have Bettina Tandi Maluba. Bettina. We can also have Tatenda Songo. Tatenda, is Tatenda in the room? We can also have Nokupi Wamoyo to come through. Let us give him a round of applause, please. We have representation from Botswana, Zimbabwe, Namibia, Zambia, Kuchalo. Okay, we can also have Sibanda Tikere from Botswana to come through. Great. So with this session, it's about data. It's about evidence, isn't it? We are here to advocate for what? Change. We are here to advocate for policies, for programs, for interventions, for strategies. All that cannot happen without data. So we'll be looking at the presentation from UNAIDS. Basically is going to look at the current data on adolescent and youth trends in Eastern and Southern Africa region. And my colleagues who have joined Madam Caroline will have that discussion based on data. Of course, with you, the lovely participants of this Indaba. With not wasting much of your time, is the tech team ready? Not yet. As this data comes, let us also try to see what has worked well in other regions and what has not worked well. How can we strengthen each other's efforts, isn't it? We have different representation in the room. I've loved it that we have got Namibians in the place, Botswanans, Zimbabweans, Zambians, from all walks of life, discussing youth issues. Nothing for us without us, isn't it? RAHi! 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 Yes. Kuchalo zona. So, during this discussion, please bear with me. I'm always good on time. When I say it's 30 seconds, please keep it 30 seconds. Zamvekaka? When I say it's 1 minute, 1 minute. Yes, thank you very, very much. We're waiting for you. We can give a round of applause as she goes there for her. Okay, so with not wasting much of our time, let me give the mic to Madam Caroline Olwinde, who will enlighten us more on the data in terms of what has been happening in Eastern and Southern Africa. A round of applause, please.
All right, so thank you very much and a good morning to all of you. It's my pleasure to be here again since yesterday, and may I start by apologizing because this presentation should have been made yesterday, but due to other engagements, I wasn't able to stay on and make the presentation. Nevertheless, we are here, and I'm happy that it's not only a presentation, but it's going to be followed with a panel discussion. And like the person who has introduced me has mentioned, the presentation is to have a snapshot in terms of an update on the global HIV prevention, focusing on young people in Africa, specifically the region within which Zambia falls. And I'd like to start off with a question to all of us here. Do we believe that we have responsibility with regards to data? And what is that responsibility that we have? I hope the question is clear. You as an individual, do you have a role to play that contributes to the data, the Zambia data, that is used to measure progress with HIV prevention? Do you have a role? What's that role? Yes. Wow, the room is so quiet. It's data. Data
Am
is
I
quiet.
allowed to use Nyanja?
I don't understand Nyanja. Okay.
All right, thank you. My name is Helen Cosmas Manda from Petoke District, Eastern Province. Role ya menenili nayo to play muli like mweba funsila question. I have a role. Monga manenili I'm HIV positive. My role in order to reduce HIV is to take my medication, adhere to my medication, and then
Fantastic. Go on.
I have to adhere to my medication so that I maintain a suppressed viral load so that I cannot transmit to my partner or whoever I have sex with. And then
Wow. Mhm. She's on a roll. Uh-huh.
as an individual, I'll never have sex until I get married. Why? Because nifuno chita reduce my.
Thank you. Thank you. Thank you. I give you 150% score in answering the question. Well done. Do you want to go on still?
And also to educate my fellow peers.
Fantastic. Wonderful, wonderful. She's knowledgeable, she's confident, she knows what she needs to do, and she knows the role she plays in contributing to Zambia data, right? And from what she has explained, does she contribute positively towards moving towards our 95-95? Yes. Yesterday, you had the minister mention the first 95, right? And how we are not doing well. What did she say our first 95 is at? What percent was it? 85? 89 nationally? And for young people? I think the PEPFAR coordinator spoke to it. It's actually 73%. So it's young people that are dragging behind the national average of the first 95. And in that context, what's your responsibility at individual level to improve that 73% to go to 95%? That's a second question. Do you believe you have a role to move that first 95 from 73% to 95%? And what is that role? Yes? Getting tested. Thank you. Yeah? And so the last question. How many of us have received an HIV test this year? By a show of hands. You're just from doing one. Yeah? Those whose hands are down, when are you going to get, and how often should you get your test? After 3 months. So some of us have tested twice since the year began, right? Those who have not tested, why haven't you tested? Huh? No, I can't hear. They're abstaining. So you only test if you're having sex? So I'm challenging you. There's a tent out there, right? You have a role in each of the 95, 95, 95 for treatment, but also the 95, 95, 95 for prevention. Okay? Next slide. Who is moving them? Okay, yeah. So my presentation will be in 3 parts. The first part looks at where we are at as Zambia in terms of the HIV response based on the targets that have been set. And not only Zambia, but other countries in the Eastern and Southern Africa region. So a sense of the progress that we have made. And then we will remind ourselves of the strategies or the global commitments. Where really are we supposed to be moving? What are the targets that we're supposed to be achieving? And that really will be a reminder, because I believe in last year's Indaba, this was presented and discussed at length. And then lastly, we will look at what programmatic guidance tools are available, because at the end of the day, I could have continued with my Q&A and asked, where did you get your test? You know, do you get it at a health facility? Do you get it at the community level? What are the platforms that are available for young people to conveniently and willingly present to uptake these services? And it starts with HIV testing, but there's the whole array of what we are calling sexual reproductive health services, which includes HIV prevention. Is it easily accessible? Are you able to access these services, and where? Yeah. So a bit of what the programmatic guidance there is. So the first part, which is that slide that's there, where are new infections happening and where are we in the response? If you can go to the next slide, please. So as we know, Zambia has a mixed epidemic, and what we mean by that is that we require to focus not only on key populations, and I think the previous panelist elaborated quite well what we mean by key populations. It's sex workers, it's men who have sex with men, it's people who use drugs, it's transgender, it's intersex people. Those collectively form what we call key populations. So a mixed epidemic, and the first chart, the first pie chart you can see there, and this is global data, the distribution of new HIV infections by population group and by sex. So the first pie chart, you can see that even though 68% of new infections in the region are from the remaining population, which is the majority, there's a significant proportion that is contributed from the key populations and their sexual partners. For the numbers that there are, there's barely up to 500,000 total estimated key populations, but they contribute the difference between 68 and 100, 32% of the new infections. So it means the infection is really concentrated in that population, and we should make sure we design programs that ensure that protects them from getting HIV. And looking at the gender dynamics, or rather the sex dynamics, again, the pink, both the dark pink and the light pink, shows that the new infections are highest amongst which sex? I don't know if it can be seen. It can't be seen, right? So I have to speak through the slides. It's women. The pink ones are women. 33% new infections amongst women 25 to 49, and 32% amongst women 15 to 24, which is, I believe, largely the population that is seated here in the room today. Men also contributing, 24% amongst men 25 to 49, and 10% amongst men 15 to 24. So what you can appreciate there is that there are more new infections amongst young women aged 15 to 24 compared to the men. And the question is, why? Why is that the case, right? And so programs that are designed should be able to address those issues that are the why. And then the next slide, if you will move, just tries to compare progress over the last, not really the last 10 years, in the period 2010 to 2020. And there we can appreciate the net change or the aggregate change in terms of new infections across different countries. And where is Zambia? You won't be able to see. But the more, when you fall on the red side, it's an indication of not very good progress in terms of the rate of reducing new HIV infections. And Zambia is on the side that is that is not doing well, actually. It's yellow, but yellow means it's tending towards red. Yeah. And then the countries that are in the green are the ones who have done well. It's actually the negative. So it means 2010, the number of new infections that were there, the rates have reduced significantly. And so they're in the green zone. It means there's a lot of work that still needs to be done in Zambia, as we heard yesterday, as we will hear today, and as we will continue to hear tomorrow. It's good to come here and discuss and see what the picture looks like. But at the end of the day, the responsibility lies on, there's collective responsibility, but there's also individual responsibility. And I think the minister spoke so passionately towards that. She spoke about sex, she's talked about alcohol use, and she also talked about accessing these testing and treatment services. So just note that as Zambia, we are in the yellow that's tending towards red, which means the rate at which we are reducing new HIV infections in the last 10 years has not been good. We need to do better. So our programs need to be targeted in a way that we're actually reaping the impact. At the end of the day, all these messages that we are sending out needs to translate into one less new infection in the population or for every individual. The next slide again shows variation in the annual number of new infections amongst, now this specifically looks at AGYW across sub-Saharan Africa. And this is based on the 2022 data. So I saw Ms. Katongo walking. It's based on the, yes, 2023 estimates. And where is Zambia again? 9,460 new infections in young women, not young women and men, young women 15 to 24 last year. Yeah? What was it in 2021? It was 11,000. So we have reduced slightly to 9,460, but not as at the rate at which we should. And we were discussing earlier with Belia seated there. If you compare with other countries in the region that are more populous, meaning there's more people in those countries than there are here in Zambia. How many people are there in Zambia? 19 million, right? What proportion of that is young people? 60 to 70%. Largely, it's a young nation, yeah? And then we are having 9,460 new infections. We had 9,460 new infections last year. Look at Zimbabwe. Zimbabwe only had, and there's people from Zimbabwe here, right? Let me see, show of hands. Okay. You had 3,752 new infections in 2022. And what's the population of Zimbabwe? How many Zimbabweans are there? And what proportion is young people? Yeah. How many million Zimbabweans are there? Your? Huh? 1.5 million. Uh-huh. 66.7%. So you can see that there's more infections in Zambia than in Zimbabwe just by comparing those statistics, right? Then we look at Kenya. There's a Kenyan in the room other than myself. Mambo. Hey, good to see you. Shonge badai. So Kenya is 5,722 new infections. And do you know how many Kenyans there are? There's 50 million Kenyans, against 60 to 70% of Kenyans are young people. So why is it, what is unique about Zambia that there's more new infections amongst young women aged 15 to 24 compared to the neighboring countries? It's the same things that Minister was speaking about. Yes, your hand is up. What is it? And I like what a panelist said in closing, that a condom may be made available to you, but it's your mindset to want to use that condom, right? Yeah, so you wanted to say something.
My name is Valepi Banda, and the problem that I can see is mostly appearing in Zambia is not only the mindset towards condom use, but there is the slogan, Tiopa Mimba, not HIV, which translates that I'm only afraid of pregnancy, but I'm not afraid of HIV because ARVs have been made available.
Do you agree? So how many of us believe that? No, that it's okay to get HIV because there's ARVs. What is the problem is pregnancy. There's a lot of you, even in this room. I hope not in this room, at least, right? So even as we are in this room, how much time do I have? Because I can go on 8 minutes, 5 minutes, okay. All right, so I need to move faster. Sorry, I'm getting carried away. But the question there, the thing that we need to put at the back of our heads is that we are not doing well. There's more new infections compared to other countries in the region based on our population, right? And so we need to do something about it. I'll skip that and go to if you can go to the slide on the global strategy. On and on, yeah. Next, and next. Yeah. So we have appreciated how we are faring in terms of new infections in Zambia specifically, because that's the thing that we want to tackle. In terms of treatment, the numbers, who know their status? Again, we heard it from the minister yesterday. 98% are on treatment, 96% are virally suppressed. So we have done well with the second and third 90, but we are not doing well with the first 90. And what's the expectation then? What are the commitments that we have made globally? What does the global AIDS strategy say? Next. Again, this is by way of reminder. Next. Yes. So it sets out 3 strategic priority areas, which if we had time, we would have gone into as well. Priority number 1 is maximize equitable and equal access to HIV services and solutions for everybody, everywhere, yeah? Including all the young people in the urban and in the rural settings. And are there any people from the rural areas in the room? Or is it people from cities only? Yeah? And I've heard again within the discussions that we haven't quite reached a critical mass of young people in the rural areas. I was happy with the pronouncement by the minister yesterday that the Indabas are going district. As partners, we will support that. And not only for the Indaba to hold, and perhaps it takes a different thinking of how we are going to conduct the Indabas. The Indaba needs to translate into increased service access for every young person in the urban and in the rural setting. So we are available to support to ensure that the Indaba actually translates into improving the data as we are seeing it right now. So maximize services. The second one is the issues that are preventing people from accessing the services. So break down the barriers to achieving HIV outcomes. What are these barriers? And they are contextual. Yeah. The Global AIDS Strategy will speak about punitive laws, stigma and discrimination. Again, we had it in the previous panel. And gender-based violence. Those are the things that are in the way of accessing services and that are fueling new HIV infections. Again, how can we address those? And of course, the third strategic priority is ensuring that there are resources, adequate resources, not only through donors, but also our own governments. Again, we heard that there's decentralization that is going on. And I liked what the other panelists said. You want to be engaged. You need to know the structures for engagement, the requirements for you to be on the table to engage, and you're engaging for self, but also for the other people that are like yourself. So find out about those neighborhood health committees, find out about your community development funds, because power and resources are now going to the district level, the district councils. How is it that you can tap into that as leaders of young people in this room to ensure that services are actually reaching majority of young people? So resourcing is key. Next slide shows the targets for each of those strategic priorities. So for the second priority around removing the barriers, we've heard of the 10-10-10. Have we heard of the 10-10-10? I'm sure it was discussed last time. There are targets that have been set globally to reduce laws that are in the way, and I think this includes the issue around age of consent and age of access to services that is in the way to accessing services. The second 10 is around stigma and discrimination. Again, we need to put interventions and programs that ensure, including in the healthcare setting and in the community, that facilitate for services to be taken. And then the last one is around gender equality and reducing gender-based violence. Those are the targets. And then we have 695 targets around the services. For HIV prevention, it is 95% use of combination prevention. We are excited about injectable PrEP, but there are other components to prevention. And PrEP in itself cannot work on its own. It has to be used in combination with other prevention interventions. Condoms, PrEP, VMMC, and other interventions that are available. Next. Wow, one more minute. So I'll just speak to the guidance that is available. If you can go to the slide that has guidance tools. Just go on. And that will be my last slide because I only have 1 minute. So documents and tools have been made available to be able to implement what we call precision HIV prevention. Not everybody is at the same level of risk. So we have to program in a way that we are reaching people with a package of services depending on their level of risk. And risk is also dependent on behavior, and it changes across age. When you're 10 years old and when you're 24 years old, your level of risk is different, right? And so the package of services that you should be able to access would be different. And we have put out tools and guidance, the next slide, that will facilitate for that. We spent the last 2 months working with the Ministry of Health and the NAC, putting together a proposal, what we call a funding request for programs to reduce new infections amongst young people in the years 2024 to 2026. And so within that proposal, there are packages of services that have been defined to reach 71 out of the 116 districts. And there'll be intensified programs within 48 of the districts. I don't know if people from the Adolescent Health in the Ministry of Health are here, but this guidance has been used and applied in the process of packaging the funding request to the Global Fund. And so as much as possible, the ministry will endeavor to ensure that a package of service appropriate to you as a young person will be provided to you at the platform that is easiest for you to access the services. And there are several platforms. There are platforms within the education setting, universities and schools, and there are packages that are also relevant within the community, where the community platforms to access the services are. I'd like to stop there and just know that as the UN and as other partners, we are available to make sure that the programs for young people actually work and that new infections, we move from the 9,460 we saw in 2022 to what's the target in our national strategic framework? Is it 50% reduction? 50% reduction. So hopefully when at the end of 2023, we will move from 9,000 to about 5,000 new infections for young people, and perhaps even take it to zero by 2025. I thank you for your time. No.
Already this conversation is getting heated, yeah? I believe people are having a lot of questions, isn't it? RAHi? RAHi? Zambia at 1%. Wow, it's so amazing to see that only a single digit change. We should be worried as young people, isn't it? If Zimbabwe is doing it, if Botswana is doing it, where are we failing? I want those critical questions to come out during this discussion, isn't it? We have seen the data. 9,000, is it something that we can accept as young people? No. We have partners, we have MOH, we have a lot of interventions, but where are we failing? I'll throw this ball to the panelists. Please, I'm giving you a minute to respond to the presentation we have seen. Starting from Mr. Mubanga, what is your key takeaway? Where do you think we are failing as a nation, and what interventions, what solutions are you bringing to the table before we take it to the public? Thank you.
Thank you so much for the presentation. I think the discussions have been around meaningful participation of young people, and also how best can we reduce the new HIV among the adolescent and young people. So first of all, it's to do with the mindsets. I think this conversation should come back again to see how best are we changing our minds. Our minds is the best solution before you decide to have that sex, before you decide to abuse alcohol so that you have less conscious. Our minds should tell us, our conscious to tell us from, that's where it begins from. Then from there, I think we need, as young people, to take not only meaningful participation, I think to take things personal in terms of getting our hands into whatever is happening. For instance, we are taking of, we have the adolescents. I don't know how many people knows that we have adolescent focal point persons in districts at facility level. How many young people do know about this? I think those are the things that we need to start from. Once we know the structures which are there, it will be easy to know where and how and when can I engage at any particular time. Then in terms of intervention, again, we need to get back to know which interventions are happening. There is a lot of interventions, but as young people, have we taken interest and see which intervention will suit for me or which intervention will suit for the other young person? I think that's where we are going to address the new HIV infection. Then the last point is also bringing in our leadership. I appreciate ZNYP and all the partners who have brought these young people together, but it has to go beyond. So from here, what are we taking to our fellow young people out there? Or it will end here. We have been trying to have meaningful participation, to have young people on the table who have been given the platform. But have we utilized this platform? I think this is something that young people, we need to challenge ourselves to say, and beyond the minister yesterday, she gave us another platform to the district. So what are we going to do about that? I think we need to take things very seriously and very cautious. There is a lot what has been done. There's a lot. I remember when I was a teenager at your age, I remember a young person, I'll remember to say these things were not there, to say the truth. Even when the HIV started, I think these things were not there. But we have been given these platforms. What are we doing as young people? Are we just coming here, we sit, it ends there? Or are we challenging ourselves to say, can I go back and make sure I make an impact to the young people who is not in this room? Thank you.
Thank you very much, Mr. Mavanga. We can pass on the mic to our colleague. Talking of strategies, we need to learn what has worked well and what has not worked well in our neighboring countries, isn't it? My colleague, come on board. Share with us from Zimbabwe, if I'm not mistaken, yeah? Yes. What has really worked well for you in Zimbabwe that you feel we should learn from you?
Okay. Thank you so much for the presentation. So maybe learning from Zimbabwe, what has worked. So in programming for adolescents and young people, particularly looking at the HIV response, we need to come up with innovative ideas on how best can we catch the young people in spaces that matter to them. So innovative platforms like learning from Zimbabwe and the organization that I represent, which is Youth Advocates. We are piloting mobile health initiatives for adolescents and young people, whereby we are saying it's very rare to see a young person visiting a health facility just to receive information. So to cover that gap or to curb that challenge, mHealth is a platform that can be used or that can be taken advantage of to say the cell phones that we have as young people, I assume each and every one of us here, we've got a cell phone at our hands. How best can we utilize those gadgets to get information, critical health information that can help us make informed decisions at the end of the day? So mHealth is one platform that can be adopted to reach out to adolescents and young people with regards to HIV and SRH programming. And then moving on, yes, young people now have the information. We now go to the issues of access. Do we have environments or service delivery points that actually promote service uptake for adolescents and young people? So there is also need of strengthening the youth-friendly service provision, whereby we are saying we do not need youth-friendly corners, but the whole facility itself should be youth-friendly to cater for the needs and concerns for adolescents and young people. And then moving on again, I like the way you talked about data in your first presentation. So what is it that adolescents and young people are doing to generate the data that is needed? We need to be capacitated. We need to be given the platforms to actually collect, analyze, and present the data itself to spaces that matter the most. So issues of youth-led researches or youth innovative hubs where young people are capacitated to collect the data. After collecting the data, what does that data mean to them? Analyze it, and then when the data has been analyzed, we are given platforms like the regional health Indabas to disseminate the data and interact with critical service providers so that we can be able to address in one room the young people themselves and the stakeholders and the service providers to see how best can we curb the challenges that adolescents and young people come across with. And then lastly, issues of laws. We have so many laws that guide and govern the SRH service provision within East and Southern Africa. But are those laws really working on ground? Especially looking at issues of access. When you're looking at universal health coverage, each and every person has the right to access a service. But now when it comes to issues of saying, let's say the health facilities are not conducive enough, we've got issues of age that also come as an impediment in terms of accessing services, which then means we are going back, we won't be able to reach the 95-95 targets at the end of the day. Thank you.
Wow. Young people being involved in youth-led researches. How many have the capacity to do a research as young people? By the raise of hands. Already, that's an intervention that we can really explore. M-Health is something that I've learned that Zimbabwe is really initiating to reach out to the masses of young people to ensure that their data is more on the accurate side. We move on to Botswana. We have seen good statistics. We've seen a reduction in your new HIV infection. Similarly to what our colleague from Zimbabwe is from saying, what do you think the gap was, and how do you feel, or how do you see Botswana in the next maybe 3 or 4 years in terms of a new HIV infection, and mostly, how have you managed to have that reduction trend in Botswana?
Thank you so much. My name is Sibanda from Botswana, representing Bofa Clinic. Yes, where do I see Botswana in the coming next years? I see the numbers of a new infection are very low or reducing. When we talk about youth meaningful engagement, as I'm here representing the youth, yes, what should be done? She was talking about good numbers of statistics. When you talk about statistics or data, you're talking about evidence. What are they doing? Are they taking this data to the youth? Are they showing this youth this evidence? She was also talking about the strategic of the global AIDS fund. When they do these strategies, do they involve youth? Do they bring youth abroad? Yes.
Youth involvement is something that is brought up. How many knew of the 9,000 plus new infections before this Indaba? How many knew of the figure? By the raise of hands? But after the Indaba, after this presentation, how many know? A lot. So meaning data is not given to us, is it? It isn't.
Yes. Closing it up as the umbrella of organizations, or if I can say you are the wallet or the motherboard of organizations which are down, they are implementing this project that you have placed on your strategies. What do? Do you capacitate them about the data that they are collecting on the ground? Are you sure that the data they are collecting on the ground is accurate? A lot is done on the ground. Evidence is there, but there's something which we are missing. We have to capacitate these service providers so that they get to collect or uproot which is the correct data. We might, let's say we are not good. Zambia is not doing good, but it's doing good. If we capacitate them on data collection and data analysis, we will see good results.
Wow, quite interesting. Let's move on to Tatenda. Yeah, a round of applause, a round of applause. Tatenda, we have had quite a good number of strains happening in Zimbabwe. Under a minute, what would be your contribution towards this discussion in terms of interventions that has worked in Zimbabwe in terms of reduction of new HIV infections, mostly in young girls and young women?
So I think putting young people at the center of program design has been really effective and a game changer. We have seen how programs like the Dreams have been putting adolescent girls at the center of programming. For Zimbabwe, what has worked is the integration of program design that is human-centered, where the hopes and aspirations of adolescents, girls, and young women are at the center of design. We note that young people are not homogeneous. Young people are diverse. They've got different issues. They've got different geographical barriers that they experience. An adolescent girl in rural area might more likely fall into a child marriage as a result of poverty, unlike in an urban setup where they have got opportunity to pursue education. We have seen with the coming in of COVID, what we traditionally thought we were doing well was literally changed. We saw an increase in child marriages. We saw an increase in households poverty. We saw children, especially adolescent girls, not returning to school. We have lost a lot of gains in terms of our progress in the HIV response. We are still to get the data on whether there was an increase or decrease of new HIV infections during the COVID period. But what we have seen is that what is more effective is when the HIV response is driven by young people, we are better able to respond to their specific needs. We are better able to respond based on what is happening at national, local, and regional levels. This is very important. I'll give a final example of what it means when we talk about human design approaches to implementing program for adolescent girls. Your question was specific to adolescent girls. We have seen in Zimbabwe that engagement of adolescent girls is a key strategy to HIV response by educating them is a powerful tool. When you educate girls, you educate communities, you empower generations. When education is at the forefront of the response to HIV, it means that we are giving adolescent girls and young people a better chance to fight for their own lives, to fight for their rights, to end child marriages by using their own capacities, their own skills based on the education they are acquiring. And this is very important in the HIV response. Thank you.
Thank you very much, Tatenda. A round of applause. Of course, data is something that is really, really important in our programming. Most of it all, when we look at the trends, we had COVID. He has mentioned they have to collect data to see how much COVID contributed. Was there an increase or reduction in HIV infection? Apart from that, we have people living with disabilities not left behind. Let us hear from Bettina what her response is towards this discussion.
Hello, everyone. In case you forget my name, I've already been introduced. My name is Bettina Maluma. I'm a board member of ZYP. So first of all, let me just talk a little bit about what disability really means. There are different categories of persons with disabilities. But disability to us as deaf people, we believe what we advocate for is that when it comes to disability issues, we are not involved. The focus is on other disabilities, for example, those that are visually impaired or physical impairment. But when it comes to us deaf people, we are left out. For example, when it comes to the statistics that UN has presented on HIV, from different countries, in those statistics, how many deaf people are there, are part of those statistics? So you find that here in Zambia, the HIV rate is high, but amongst those statistics, how many deaf people are there? How many deaf people have access to go to VCT, for example? There are programs on TV, maybe an advert or an announcement about HIV medication and so forth, but there's no sign language. And then a lot of deaf people, they've not been to school. How will they read and write to have information? A lot of deaf people who come from, poor backgrounds, poor families, they don't even have a television to speak of. They don't have education. So do those statistics include deaf people? How do they have access to information about ARVs? Or if they go to VCT, how will the counselor explain to them, or the health worker, how will the health worker explain the prescription to say we take this one pill every morning or every evening? How? So you find that deaf people, the HIV rate might even be higher amongst the deaf because they don't even go to for VCT in the first place. They don't go to VCT because whatever programs are there, even on TV, there are a lot of awareness programs on TV, social media, everywhere, even physically going in the community, but there's no sign language. Zimbabwe have, they mentioned that they have an app, a mobile phone application, probably using English, or maybe for those who are hearing, how will a deaf person access? Deaf person, most of them cannot read, they depend on sign language. So talking about Zambia, when it comes to deaf women, the challenges that you've spoken about is even higher. For example, we do not have, sometimes you find that maybe a sign language interpreter is not there. So so the number 9,400 and something, that number, you find that deaf people are not part of those statistics. How many deaf people have got HIV? How many have tested for VCT? How many are on ARVs? How many have their viral load reduced? They're not there because they're left out. So for us as deaf people, we're heading these statistics for the first time. So yes, we can talk about persons with disabilities, but even in the picture of persons with disabilities, deaf people are still left out. Other disabilities, they have information, but not the deaf. Thank you.
A round of applause for my panelists. Quite exciting data coming out, isn't it? I believe we have a lot of burning questions, do we? But you know what I had mentioned earlier before I started, that I'm a man of my what? Time. I know we've got so many questions. Please post those questions on our forum, the ZYP Facebook platform. Please post all those questions there and they'll be addressed as we have a lined up packed presentation today. But in my conclusion, I would want to say that the evidence that has been brought up, the data that has been brought up, really needs we, the young people, to participate mostly in understanding how do we interpret this data. We heard from our colleague from Petauke how she contributes to having that data reduced. But how are we contributing to that data? Secondly, interventions. What are we going to do? How are we going to utilize the digital technology we are in now? We are in the e-world, but is it everyone who has a smartphone? No. But how are we even going to reach someone who has got that small phone with information? It's at this point in time, I would love to close the session for now, as the next session again, which is coming, is more important in terms of data, mental health, isn't it? Mental health is something that is really, really among the young people. And with this session, one thing I've loved about the data that has been presented to us, it is to have an eye opener. Please post those questions on our Facebook platform and we'll have them responded as soon as possible. Once again, my name is Maxwell Mumba, who has been moderating this session. I thank you. As they go to sit, let's give him a round of applause. Okay, we have an announcement from UNAIDS.
I just wanted to make, it's a very important announcement. I don't know how many people have heard about the UNAIDS PCP board. It's a governing board for UNAIDS, which has got different member states, which sits on most of the issues that that affects young people and that affects the young women and all the key population as well. So I just wanted to say that in Africa, we have two countries which are sitting there. And the good part is these two countries or two organizations, they represent the young people and they are very vibrant. So I feel like it's important that if you feel there are certain things that you need to connect with. So one is from Uganda, and also one is from Zambia as an organization. So let's take up and also try to engage these young people because they're representing Africa. They're not only representing the countries, but they're representing Africa. And some of these issues are key issues that are being brought up, and this needs to be addressed as well. Thank you.
So I know you've closed, but just two short points. What Bettina has raised is really important, and I think it's food for thought for the Ministry of Health, for us cooperating partners, persons with disability. And thank you for putting that challenge to us, Bettina. Of the 9,460, how many are persons or adolescents and young women that are with disability? I think that's a challenge that's on the table for us to address. The second point in concluding, the district Indabas. I'd like to make an appeal for those to be data driven so that we are looking at data, we're looking by district, what's the progress we have made, why is that progress like that, what are the priorities in terms of interventions for us to close the gaps if there will be gaps. So a data-driven approach to the district Indabas next year, and the minister said we need to start planning now. Thank you.
Thank you, Caroline. Wow. Go ahead.
Thank you so much. Thank you so much, Madam UNH, for the comment. We hope that next year when you have the district, I'm not sure if this year when you had the provincial Indabas, if deaf people were involved. And maybe you can ask that moving forward, whenever a deaf person visits a health center, they should do record, and so that we can make part of statistics. They have to record that, okay, the person who came to test for VCT has also this disability, is also deaf. I think that will help to integrate the statistics of deaf people in the statistics. That's just another comment. Thank you.
Thank you so much. Another round of applause to our expert panel. Indeed, as we remember to make the districts Indabas data-driven, I also have another task for you. So as Frank and Sarah from Strong Minds are coming to give us a mental health presentation, and do one thing. If you've got an idea of an innovative way in which young people can be engaged in this fight, please comment, and there are a number of giveaways for you, and more importantly, you will be given a chance to be more famous. You will take a photo with the musicians and celebrities that we have, and then ZYP will create a poster for you. So let's give a round of applause to Frank and Sarah from Strong Minds as they give us a presentation on mental health.
Hey everyone, good morning. It's nearly afternoon. This is my colleague Sharon, but to me, I know you're all waiting probably for lunch or for tea break. You're tired. So we're going to give Sharon a bit of energy. So we're going to do what we call a pasha. So everyone stand up. Yep, yep, yep. And Swahili speakers from Kenya already know what this is. So everyone, we want to get warm. So we clap our hands and we go pasha. Pasha, 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 pasha. Okay, cool. So I know some people like chumvi, which is salt. So let's put some salt into our pasha. But we know diabetes is real, huh? So let's blow off the salt. Not too much salt. Now you've made it cold, so pasha again. Pasha, 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 pasha. Now who likes pili pili? Chili. Yeah, the East Africans love it. I don't know if Zambians love chili. Ugandans don't. Let's put chili in. But for those people that it's too much, blow it off. Now it's cold again, pasha. And then in 1 second, we're going to give Sharon a big choma, 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 choma. Wow, well done. Sit down. Thank you. Cool. So this is my Sharon. You can sit down. Thank you. Great. So if I ask you, wait a second, everyone. Let's be together. If I ask you to put your hand up, if you can name 3 organizations that work in HIV or sexual health, put your hand up. 3. Name 3 in your country. I'm not going to ask you for the answers, just in your head. Put your hand up. Okay, lots of hands. How about 5 organizations? There's so many, even in this room, I can see. Okay, put your hands down. Now, can you name 2 organizations working in mental health in your country? Okay, there's about 3 or 4. Cool. So, thank you very much. So we can see a huge difference. We're working with an organization called Strong Minds. It's been around for 10 years, and it is there to support, treat the most neglected non-communicable disease in the world, which is called depression. Maybe I can ask my slide person to keep sliding us along. We're going to go because we've got so little time. We just want to move. Hello. Lovely. So, Strong Minds, 1 in 4 people in our continent are affected by depression. And yet, when we go into the countries, many people say, depression or mental health, it's a Western thing. It's for Mzungus or Mlungus. It's those Americans and those British people. Is that right? Not at all. Strong Minds has found that, especially amongst adolescent girls and women, as many as 1 in 4 are affected by depression. Why? There is so much stigma. If I say to Zambians the word Chainama, what do we think? Do we think that's a good thing? But why? It's a hospital. If I say to you UTH, do you go, ooh, no. But if something about Chainama, which is for people not from Zambia, it's our #1 mental health institution, there's a very negative thought. Am I right? Okay. So we're dealing with a lot of stigma and issues in our country. Yes, please, my legend. Cool. So how the Ministry of Health, the government of Zambia, if I asked you to put a percentage in how much they spend on mental health, so they give 100% to the Ministry of Health, what percentage goes on mental health? What do we think?
Maybe 9.
Legend, 9%. What do we think, ma'am? 2%. It's 0.3%. Yeah. That's a statistic, a fact. Isn't that unbelievable? And you know what? Let's be together. 97% of that 0.3%, it goes to the hospitals. Chainama, Ndola. So if I'm in a small community in Chipata, yeah? I'm an Ongoni, so I'm from that side. do we have any hope of receiving quality services? It's very difficult, huh? Right. So do we understand why mental health is really important? Do we understand why the need is here in our countries? Is it only in Zambia? Is our Botswana and Zimbabwean saying, hey, it's just a Zambia problem? No, cool. So what do? We've partnered with many organizations, and we're here at the invitation of our legends from CIDES and USAID and Dreams. We can see there's even some superstars, yes, in us. So I'm going to pass it over to my Sharon, who will talk about what we do and how we do it. Thank you.
Thank you, Frank. Hello. Hi, everyone. Hi. So I'm Sharon Birunji. I'm Ugandan, but I'm working in Zambia now. I'm being Zambianized. I'm from Copper Belt. I'm Natasha now. Yeah. Yes. So so I'll briefly talk about our intervention. So with Strong Minds, we treat depression using interpersonal psychotherapy for groups. So it's a therapy model that was approved, and it is WHO approved model. Interpersonal psychotherapy. So just a brief outline. So it is evidence based. Our therapy is evidence based because it is WHO approved. I'm sorry, I think I'm rushing. Yeah, so it is WHO approved model. There is evidence that it works. Like Frank mentioned, we have used IPTG in Uganda. Uganda started in 2000, the early 2000s, using IPTG. And then with Strong Minds, we started in Uganda in 2014. So in Zambia, we have been working since 2019, and we have worked in most of the compounds in Lusaka. Some people know us actually around here. People from Dreams, you know us very well. So it is evidence-based and it works well. So the picture there is one of our groups. Volume? Okay, sorry. So we how IPTG works, it's group therapy model. So we put people together. Mostly we work with women and adolescents, and mainly young girls, adolescents, youths. So we put them together, to 8 to 12 women or adolescents. After they've been screened for depression, and those who have depressions, they are put together to go through 8-week therapy model for treatment of depression. So so depression is we treat it using IPTG, like I mentioned. It is time bound. It's not some of the treatment models that we know that will go on for a year or months. It is time bound. So it's 8-week therapy model, once in a week for 1.5 hours of a session. So it is replicable. We can easily be trained. We just a 5-day training for lay community workers. Sometimes we work with some of the former clients after they have gone through therapy model. Even we work in the central province with the community health workers. So IPTG focus on relationship building. So there are 4 main triggers of depression. We will not go into the details, but we will focus on building a relationship, how to look and find solutions on your own, supporting each other, and putting people together so that they can have that social bound, the social working together and supporting each other so that we can solve our problems. It's different from the traditional one-on-one counseling that we know, because one-on-one, the client looks at the therapist or the counselor to help them find solutions. But with IPTG, people work together in a group to support each other and to find solutions on how to improve on their lives and how to get out of depression. So IPTG has been modified to work for adolescents. So as we can see here, we have some visual aids that we use for adolescents. We look at, because we want to help them to understand their moods and how they are feeling. So we help them using the emoji cards. Most of us with smartphones, you know, the emoji cards. So we have the emoji cards so that they can express how they feel, because even with adolescents, sometimes it's hard to express how you feel. If you're feeling sad or angry or upset, sometimes it's hard to come out and express how you feel. So we help them using emoji cards so that they can share their mood, and we can relate the mood to the event and to the interpersonal relationship of the client so that they can improve on their mental health. So yeah, so that we work in schools, we work in communities, we work in the rural areas. So IPTG is literally replicable. It can work in all settings. It can work in all areas. Yes. So so our results, Frank will talk about the results.
Let's clap for our Sharon. Isn't she the best? Whoop-whoop. So we've treated over 230,000 people with depression in the last 10 years, and 80% at least at the end of the 8 sessions no longer have any symptoms of depression. Isn't that amazing? Did we use drugs? Did we need to go to Ministry of Health facilities? Did we have to get everyone to come to us in our offices? Nope. It was all done at the doorstep. So we diagnose at the doorstep and treat under a tree. We say, you know, wherever you are. Because if you're depressed, do you want to even go outside your house? Do you want to talk to your brother or sister? No, that's the issue. And by the way, I find adolescents, you guys get it because you're legends. You know about mental health. Yeah. And so we know what we need to be doing is advocating to our fellow mom and dad and leaders, because many of them are also suffering in silence. So what we've done in partnership with Siders and Dreams is, this is absolutely amazing, by the way, guys. Before, Strong Minds staff went in and did the group session. Not anymore. We now train you guys, the youth leaders, to go and do the treatment itself. Isn't that amazing? And it's happening across Zambia right now, in Copperbelt, Southern, Lusaka. And do you know what? 2 years ago, people told me and Sharon, it will never work. No, no, no. You can't do that. We just said, give us a chance. Let's try. And we've got some amazing results. This is not our results. This is your results. Some of the people who are sat in this room leading these programs, and we are so proud. Cool. I think we can go to the next slide. Listen, we also know we don't just treat one person. When we treat one person, we treat the whole family. A depressed mom, does she want to send her child to school? Does she want to eat her meal? She doesn't look after herself. So we treat the whole family. That's what we do. I'm going to need my Shan to come and check you. Next, how are you? So I think we know this. These guys know all of this stuff. Like, no more slides. It's boring. Yeah. So anyway, look, we've kept it 10 minutes. They told us 15. That's how we roll. But I want to thank you so much. Let's keep advocating for mental health. How can we talk about HIV if we don't talk about mental health? Can a person with depression, are they easily able to take their ARVs? They are struggling. They tell us this, right? So anyway, I'm so proud of everything we do. Let's keep being advocates, and thank you for your time. Thank you for inviting us to this incredible event. Woohoo!
Thank you so much, Frank. Thank you, everyone.
All right, thank you so much for that incredible session on mental health. And I believe mental health is very important. So right about now, we're just going to go into presentations. But before we do that, as we have heard, mental health is very important. So I'm thinking by this time, most of you, the energy levels are going down. So let's just do a little bit of an energizer. Can you all stand up? A quick one. So we like do like one at a time. Okay, so I'm assuming we are from different countries, right? So we just want you to just show us your dance skills from different countries. So what we are going to do is, I think you know the song. So if I say, my people, then you go, Igwe, Igwe. So if I say Zambia want to dance, then you show us how you dance in Zambia. If I say Zimbabwe want to dance, then you show us how you do it in Zimbabwe. If we say Botswana want to dance, then you show us how you do it in Botswana, right? Okay, so we need all the energy that we can get so that we can see, maybe we can get a prize for someone who really dances very well. So you're just going to do it very fast, okay? All right, did we get the instructions? Okay, so let's begin. My people. The energy, guys. My people. Zambia wants to dance. You say dance, oh, dance. So the people from Zambia, can we see your dance skills? Okay? All right, let's begin again. Okay, so we can actually have one person who can run very quick from Zambia and just show us some dance moves. Represent your country very well. Don't disappoint them. Okay. Okay, let's roll. My people, Igwe, Igwe, my people,
Igwe, Igwe.
Zambia wants to dance, dance, oh, dance, oh. Zambia wants to dance, dance, oh.
Come on, Igwe.
Dance, oh. Zambia wants to dance, dance, oh. Dance, oh, my people, Igwe, Igwe, my people. Zimbabwe, don't disappoint me. People, Zimbabwe wants to dance, dance, oh, dance, oh. Zimbabwe wants to dance, dance, oh, dance, oh. My people, Igwe, Igwe. Botswana, where are you? Igwe, Igwe, my people. So we don't have anyone from Botswana. Hi, guys. All right, thank you so much. Thank you so much. Botswana, hi, I'm very disappointed. Okay, thank you very much. So right about now, we are going to have presentations. So on this one, this is on closing the tape to new HIV infections. And I think right across the region, it's a discussion that we've been having to say that we are realizing that most new infections are among young people. So we are going to have a presentations from that. I'm going to call Chowa Kasengele from Ministry of Health, Lubasi Suwan Health, as well as Katongo Silwes from National AIDS Council to give us their presentations.
So good morning, everyone. As has been introduced, my name is Lubasi. I am coming from the Ministry of Health headquarters, and I'm representing Dr. Tina Chisenga, who should have been here to make this presentation, but because of other conflicting programs, she's had to reassign. So I am here doing this presentation on her behalf. So that shows just that's my presentation, and those are the data sources of some of the information that I'm going to share with you. And that is the presentation outline. I hope you're able to appreciate the presentation. I hope it will project better. Yeah, there we are. So that is my presentation outline. So to start with, I'm just going to give you an overview of the HIV situation, and then we'll drill down to the adolescent picture of the HIV situation, as it were. So the goal of the HIV present, next slide, please. Next slide. Yeah. So the goal of the HIV program is to, of course, reach epidemic control, as we all know, by 2030. And I'm sure that is not just for Zambia, but all the countries that are here presented. So that is what we want to do. We want to close the tap by 2030. And for us as a country, ours is to reduce the new infections that currently stand at 28,000 to at least 15 or even less by 2026. Next slide, please. So the graphs there show the prevalence as well as compared to where we are in terms of the 95, 95, 95. And of course, I'm not sure you're able to see clearly given the way the figures look, but I'm going to say it here so you'll be able to follow through. So that is prevalence by age. So if you look at the graphs there, the one on the far left shows the HIV prevalence by age, and that is the latest data we have from the Zambia 2021. So in the age that is of our interest, the 15 to 24, then the prevalence currently stands at 2.8%. And then 2.8%, that is for the 15 to 24. And then the 25 to 44, we are at 13.8. And for the 45 to 59, we're at 25.1%. And the above 6 is about 10. So if you see from the prevalence, it shows that we have amongst the adolescents a lower HIV prevalence. But then the challenge that we have still in the same is because we still have a challenge in terms of testing, case finding among the adolescents. So that is where the issue is. Next slide, please. Next slide. Yeah. So now in terms of the new cases, as in the incidents, so we have, well, overall, we have like 0.3%, but then the women still show a higher rate of new infections. So even in the 15 to 24, the rate of new infections is still more higher among the females than the males. And of course, we know some of the reasons. It's because mostly the females are the ones that find their way to the health facilities compared to the male counterparts. So that is one of the contributing factors. And so by age, next slide, please. If you look at the new infections by age and sex, so there we still have women having the 2/3 of the new infections. But then according to, if you disaggregate by age, you see that the young people and children account for almost 50% of the new infections that we see. Next slide, please. So now drilling down to us, the adolescents, or to you, the adolescents, you will find that as the country where we are, the HIV infections account to about 38% of the new infections in Zambia. And of that, it's 78% of the females. And then the males account for 22. So that is where we are in terms of adolescent health and new HIV infections. Overall, we're at 38%. So that is the situation there. Next slide, please. So now, remember I talked about the issue of testing in my other slides, the issue of case finding among adolescents, like we are really not testing enough, or adolescents are not really testing or accessing HIV testing services, as it were. So the graphs there show testing trends from 2018 up to about 2022. So generally, the picture that is there is that, of course, there's been a reduction generally in testing numbers, but of course, it's even fewer adolescents know their HIV status. So that is how the situation is. So 2018, 2019, 2020, up to 2022, we still see a reduction, a gradual reduction in the adolescents that are accessing HIV testing services. And then next slide, please. Yeah. So when it comes to the number of people or adolescents that are HIV positive, and then if you compare that to those that have been studied on ART, you still see that there's a variance. And also then that also ultimately affects the viral load suppression, because we see that amongst adolescents, the retention to care is not very good. So that is how the picture looks like in terms of ART and viral load suppression. Next slide, please. And for prevention interventions such as PEP, and I think oh yeah. So PrEP uptake in adolescents has increased, and we've seen that the female adolescents actually are accessing PrEP services, of course, which is a good sign there. So those figures in the graph, though very small that you cannot see from where you are, but it indicates a gradual increase in that female adolescents that have been accessing PrEP services. Next slide, please. And then there's also the PEP, which is different from the PrEP. So this one is PEP, which is post-exposure prophylaxis. So this is for survivors of sexual-based, gender-based, or whatever violence. And so this one, the numbers are not as good, and most victims of sexual abuse don't actually access, especially the adolescents in this case that we're discussing, don't really access the post-exposure prophylaxis. Next slide. And then this one shows us STI trends. And this one is also worrying us as a ministry because from what we see, the picture is that over the years that we're looking at, over the years, there's been an increase, of course, generally in the general population, but zeroing in on adolescents, STIs, there's been an increase in the number of sexually transmitted infections amongst the adolescents. So what is highlighted there is data from 2021 and 2022. And so you find that, yeah, there is an increase in the number of STIs. And the other graph on the far right just shows those that are found with STIs versus those that access treatment. So even then, those numbers are very few. You find that there's plenty of adolescents having STIs, but very few of them still accessing treatment, which is not a good thing because we know if you're going to go to a facility and you're tested or you have an STI, chances are you might also have HIV. So that is also another area that is worrying. Next slide, please. And then this one, I think just before now, we had a presentation talking about depression and all that. So that slide there talks about poor mental health, increasing the risk of behaviors that can cause HIV transmission. And in the graphs there, we have 2021 and 2022 data showing the proportion of adolescents that were treated with depression. So the numbers are quite significant as well. Next slide, please. So now, what you see there is the groups. I'll just go through the groups of, just to give a highlight of some of the adolescents that are, or which adolescent groups are more susceptible or at a higher risk of HIV acquisition, according to the data that we have. So the first one that you see there is the street youths. Of course, we know just by virtue of them being on the streets, they're exposed to a whole lot of things out there. So of course, there's transactional sex that goes on the streets. There's the need to eat, so then people trade sex for food. And of course, there's also probably levels of ignorance amongst our adolescents on the streets in terms of issues of STIs and HIV, and then drug abuse. And of course, they are homeless by the virtue of them being on the streets. So then that predisposes them to a whole lot of risks. Next slide, please. Then the other group that is also vulnerable is our colleagues that are living with disabilities. And I think in the last session, our colleague there also echoed the needs that adolescents that have living with disabilities don't feel included in most of the interventions that we're implementing. So even from our assessment as ministry, we've also noted that persons with disabilities also are at increased risk of acquiring HIV because of issues of poverty and all those things, issues of gender-based violence by virtue of where they might find themselves to live, and also limited access to education also poses as a risk to them acquiring HIV, as well as just lack of information and resources that are needed to facilitate for safer sex, for example, like she had outlined in the other panel discussion that we had. Some of the information is not really friendly to our persons probably that are deaf, that have challenges with hearing, or those that cannot see. So most of our materials, they are not able to access that. Next slide, please. And so the other one is what we call child-headed households. So these are homes where the one that is the father or the mother figure of the house is an adolescent. So those are what we call child-headed households. So these members of these households, of course, are going to be economically vulnerable just by virtue of an adolescent heading a household, because from many fronts, economically, they might not have the resources to be able to take care of the younger ones, of course, and then that will predispose them to engage in high-risk behaviors, transactional sex, drugs, and all those dangerous ways of living. And then the other group also is out of school and boarding school youths who are also economically vulnerable, and most likely they're going to engage, or they do engage in transactional sex that also predisposes them to HIV. Next slide. So having said all that, so we summed up our areas of concern, and we thought we could zero in some of those as we come up with our interventions towards the adolescent and young people going forward. So our area of concern, of course, is one of which I mentioned earlier, the issue of high STIs among our adolescents, and also the rife transactional sex, intergenerational sex, and then also the issue of early sexual debut. That is also another area of concern, as well as low perceived risk to HIV infection. As was said, some adolescents, some of us think that, well, I might not have. We don't know how predisposed or how our situations or the lifestyle that we live predisposes us to HIV. So we think I'm not affected and so on, but that is also another area of concern. And of course, inadequate comprehensive knowledge on HIV and HIV prevention. So those are some of the areas that we see as gaps amongst our adolescents and the adolescent HIV programming. Next slide, please. So based on all of those that I've said, the challenges and the issues that we found, in going forward, we have come up with just some of the interventions or approaches that we think might help to reduce, or rather to cut down on some of the risks, so to enable us, achieve our aim, our goal of reducing the increasing HIV infections amongst our adolescents. So what we want to do is that we want to maximize on existing opportunities, existing systems, what we already have in place. So for example, I'm sure most of us have heard of the Adolescent Surge program that has been going on in the various provinces. So that we want to maximize. At some point, I think it had gone quiet, but probably we think we could revamp that, where we target most of our resources to the adolescent HIV programming, that is prevention, messaging, and all those issues associated with that. And then we also want to also scale up on our adolescent surge dashboard. So that's a dashboard that just gives us information, real-time data on some of the statistics that we might have on the adolescent surge activities. And then also come up with accelerated childhood treatment tools. So this one needs to be revisited and also to be implemented. And then what we want to do also as new initiatives is to focus on prevention. So that is what keeping those of us that are HIV negative to still continue being negative. So if you go to a facility or you go to whatever testing facility and you have yourself tested, you are diagnosed to be HIV negative. So what we want to do now is, we've already seen that we are a risky population. So previously, what would happen is you go to a facility, then they'll tell you, oh, you're HIV negative. Okay, you could come back after 3 months and have yourself tested, or 6 months time and have yourself tested. But now what we want to do, not only for the adolescents, but for the general population as well. Yes, this person has tested, they're negative, then what do we do to help them? So at that point, we'll make sure that instead of just mentioning to say, okay, if you're interested, there's these services, we'll make sure that we ensure that you access, if it's PrEP that you want, or if it's VMMC, you need to go to VMMC or any other HIV prevention intervention. So that is what we also want to strengthen. So that is what we are calling the status neutral approach, keeping the negatives and negative. So how are we going to do that? We plan on having gender or population specific case finding initiatives. So in this case for the adolescents, it's going to be, of course, population specific initiatives, and also enhancing HIV prevention interventions, increasing access to comprehensive adolescent services, as well as, remember I mentioned earlier that in terms of treatment and retention, adolescents, most of the adolescents on treatment tend to fall off at some point. So we want to come up with models, differentiated models that are going to ensure retention into care. So instead of perhaps you going to a clinic to go and get your refills, we're going to come up with models. Of course, some of them are already existing for the older population, but we're thinking maybe even the adolescents could tap in, or we could tailor something that is adolescent friendly. So instead of having to go to a facility, you can go to some other place, the community, get your refills, not just for a month, maybe for a longer time, so you don't have to go to the facility all the time. So those are some of the initiatives that we want to come up with. Next slide, please. And so that slide just shows our priority or our focus areas, and those we've summarized into KEPT. So the K being the knowledge enhancement, and the E being equitable in access, and then the P is for population sensitive, and then the T is in total package. So knowledge enhancing, equitable in access, population sensitive, and total in package. So of course the K, as you know, knowledge, we're going to provide comprehensive, age-appropriate, gender and population-sensitive SBC, as in social behavioral change messaging. So we want to also strengthen on that one, as well as IEC materials into local languages, and also those with special needs in terms of persons living with disabilities. That is for the messaging. And also capitalize on social media platforms. And then in terms of the KEPT, which is equitable in access, maximizing the DSD models, that the ones I just mentioned earlier for your drug requisitions and refills, and also to enhance the triple care model, promote minimum package of care. And then for the P, we're also going to, that is population sensitive. So under that one, I'm sure we all are aware of the dreams. So we're going to strengthen the dreams. And also the boys have been left behind in most of the interventions. So we also want to enhance interventions for the boys as well as the men. And also interventions for specific groups of the vulnerables, the OVCs, persons with disabilities, and the child-led households, the ones I talked about. And the last one being the T, the total in package. This one will be a whole package. There will be integrated care. There will be, of course, the ABCD, which has died. I'm not sure how many of us even know there was something called the ABCD, the abstinence, the being faithful, the condomize, and so on. And then we also want to revamp the youth-friendly spaces. I think somebody mentioned in the morning that why should it, in one of the presentations, why should it be a youth-friendly space? They want to have the entire facility. So that is also in our plan. And then also the status neutral approach, the one I earlier alluded to, where we want to keep our negative clients negative and link them to the appropriate prevention interventions. And of course, mental health and psychosocial support. And finally, to incorporate sexual and reproductive health. So those are some of the interventions that we as a ministry plan to look at, and of course, not just discuss, but implement, so that at the end of the day, all of us as adolescents that are sitting here will be able to live healthier and better lives. Thank you very much for your attention.
Okay, thank you so much for that lovely presentation. This just goes to say how important data is in our programming, so that we can actually focus on where the most need is. So going forward with our program, we are going to have another presentation. Going to be giving out gifts to those who are going to be retweeting and sharing what's going to be happening here. So if you have your phone, it's your time to use it. You might never know what you might get. So please, let's just use our phones and share with our friends and our families. All right, so just taking 2 questions for the presentation that we've read now. Anyone with a question? Just 2. Yes.
Thank you very much. My name is Event from Northern Province. And in the presentation, ma'am, you mentioned about the differentiated services that the Ministry of Health has designed in order to meet the targets of the adolescents in our communities. And basically, this has been discussed for so long. And in most of the meetings for adolescents, it's been mentioned out, but how further do you want to implement it? Because we are looking at the target we are supposed to reach at 2030. And right now, these services are not implemented and adequate as they are supposed to be in our communities. So I just want to hear if she can shed more light on how they are going to take this.
Okay, thank you for that question. So we are taking just another one and then she can just respond to both questions. So if you have any more questions, you can write them down and then we'll pick up the papers and I'm sure at the end we'll just get responses.
Thank you so much. In one of your presentations, the earlier one while you're starting, there's something that was mentioned on the key area concerns, early exposure to sex. So I don't know what you mean. I don't know if it's the information that is being given. Is it being given at an early age, or please shed more light? Thank you.
Okay, anyone with a burning one last one. So because of gender, just taking a guy.
Oh, my name is Joseph P. from Gatete District representing Eastern Province. My question goes to the Ministry of Health. I'd like to know what modalities or the interventions which they want to have, especially with regard to addressing the issue of reducing HIV infections, especially engaging the traditional leaders. So how is the Ministry of Health trying by all means that they engage the Ministry of Health as far as reducing the HIV infections is concerned?
Okay, thank you very much for those questions. So those who are online, we are also encouraging you to keep the questions. And then at the end of the session, we'll try to get as much answers as we can. So for now, we just let you respond to those 3 questions. And don't forget about the challenge. Keep posting, retweet, and share with your friends as well.
Thank you very much for those questions. I'm grateful for the questions. It shows that you were paying attention. So I'll start with the one for the DSD models. So the DSD model of service delivery in terms of ART has been around for some time, you're right. It's been implemented. And I think the gap that has been there is for the adolescents, maybe to see how it then gets enhanced or to provide. So what we mean by DSD, first of all, DSD stands for differentiated service delivery. So that is an approach that we use to reach out to certain people that are on treatment. So instead of you having to go to a facility, those that want to go, it's okay, they could go. But then there's other ways of maybe you could get drugs by maybe finding maybe a certain sport in the community, organized sports where you can go and collect your treatment, your medication, your refills, and then also you make up probably a group of 6 of you so that one goes, so you don't have to go to the facility every month, but you go there perhaps after a certain period of time, 3 months or things like that. So those are just some of the ways that the differentiated service delivery models helps to make sure that people don't, to make it easier for you to get your drugs. So those models have been there. They're slightly, maybe 2 or 3 years into implementation, but as you know, as you start something new, you always have to learn lessons as you go. There's always challenges here and there. But for now, for the adult population, it's working very well. For the adolescents, it's supposed to be actually for everyone, not just for the for the adults. But that is where I think we'd have to engage more with people that do adolescent programming and see how best the adolescents can also tap those. Because if then you are able to tap into those models to make it easier, and remember the information that I shared earlier to say for the adolescents, the information indicates that you are dropping off of treatment compared to the other population groups. So if we could then tap into those DSD models as adolescents, I think probably to be able to achieve what we want to achieve. So I think the gap there would be to engage with the people that do adolescent programming and see how best, or maybe to actually engage the youths, the adolescents themselves, and see what would work for them in terms of them having to access these drugs from another place other than the health facility. So it is work in progress, but yes, your point is noted, and we shall of course strengthen that gap that is there. I hope your question is answered. And then for the other two, the other two, I think my colleague would take it up. There was two, one for sexual debut, I think, and then in the traditional leadership.
No, so thank you so much for the questions. I'll try and help my colleague in trying to respond to the questions that have been posed. The first one was regarding early sexual debut. So in terms of how this actually affects somebody either acquiring HIV or transmitting it, positioning the youth to acquiring HIV, early sexual debut. If somebody starts engaging in sexual activities at a very young age, say 12 or 13 years, by the time they'll be 18 or 20, they would have slept with so many number of people. And it's the frequency of you having those sexual interactions and with so many people that actually puts you at a higher risk of actually acquiring HIV. So that's what was meant for about early sexual debut. The other notion on early sexual debut is it keeps you at a longer, can you say duration of exposure to what we call the human papilloma virus. This is a virus that actually enhances your chances of catching the cervical cancer. Cervical cancer is also linked to HIV AIDS or maybe a drop in somebody's CD4 count. So this is why government tends to discourage people from starting to engage in sexual activities at a young age. All of these are linked. I think it will even be linked to mental health. If you are dumped by this person that you were infatuated with and you gave it your all, it's easy for this young person to actually get mentally unstable. In terms of engaging with the traditional leadership, I'm speaking from an aspect of the National HIV/AIDS STI/TB Council. By virtue of our being in existence, we coordinate the multi-sector response. And that word, the multi-sector, it gives us a chance to engage with everybody and anybody, be it in public, private, even leadership. So we do have means through the CCM. We tend to engage different, they call them constituencies. There are some for the youth, there are some for the leaders, there are some even for traditional healers. Everybody has to come to the table to discuss issues of HIV and AIDS. I'll be preempting my short presentation. There's just one slide presentation where all of these things will be made clear, but I just wanted people to be aware that it's a matter of engaging everybody. It's either you're affected or infected, and for me, I've added the last one, or both. So we'll explain a little bit more on that. I hope the questions are a little bit clear, or the answers are a little bit clear. Thank you.
Okay, thank you so much for those responses. So we're also going to get a presentation from Choa Kasengele from Ministry of Health.
The facilitation skill I've been taught, I have to look at my laptop. But you told me to upload on your laptop. Ngando, let me have my laptop. I can start reading from there. It's you people to read from there. Let me have my laptop. Viva adolescents. Imwe chumwela. Viva adolescents. Viva young people. Remember, this is your time and your day. You need to be very happy. Yesterday, I saw how happy you were because you were familiar with the two songs which were sung. I'm always happy when I see my young people dancing because I believe you're shaking off your problems. Yes. So you need to be happy. No one should dampen your spirits. Don't allow it. But still respect elders. So try to put my presentation in slideshow. So I'm from Ministry of Health. I'm Mrs. Choatembo Kasengele, the Chief Nursing Officer, Adolescent Health. And I'll look at the way we do our work. I'll talk at the way we deliver our adolescent and young people. AYP stands for adolescent and young people. Our work, we make sure that we cater for adolescents who are in and out of school, including those with disabilities. And we deliver life skills and health education promotion, the former CSA, with support from line ministries and partners. We also conduct outreach activities in schools and communities. We don't only do our static activities at health facilities. We reach out to our young people in the schools and communities. In schools, in collaboration with Ministry of Education, we have formed what we call school clubs, where information is given to our people. And we have also responded in making sure that it's high time in trying to make sure that we have universal health coverage, leaving no one behind. This time around, we'll start our outreaches in boarding houses. Most of you here can agree that there's something pathetic happening in those boarding houses. And some young people, they take it for granted because of the too much freedom, peer pressure, they indulge in a lot of activities, risking their lives. Also, we've realized that adolescents and young people in orphanages are also at greater risk, especially issues of sodomy. So we are responding to that as adolescent health unit. That's why you may see that as a unit, our perception on how we look at things is different. So we are making sure that boarding houses and orphanages, which have now come out to be hotspots, they are catered for. We protect the young people. But we are not saying that as guardians and parents, you fold your arms. No, you still need to inculcate good morals to your relatives, to your children, to your dependents as you release them. And how do we respond to the health problems which affects adolescent and young people? Our work is enshrined in the National Adolescent Health Strategy running from 2022 to 2026, where we are focusing on demand creation and awareness. We use this mostly our peer educators, our adolescent focal point persons, and other health workers to make sure that demand creation and awareness of the services we provide is availed to the adolescents and young people. We have also encouraged our health workers that they should also put billboards at the health facilities to market the services which are provided in the adolescent-friendly spaces. The other area we look at is service delivery. And for us to deliver a service, we need to have competent, caring, and clean health workers, of which our peer educators, they still fall in those brackets. So our service delivery, we make sure that we provide that to our adolescents. Leadership and governance, this is where we coordinate a lot with other partners in making sure that our programming is well taken of. And monitoring and evaluation is very important for us to know where we are coming from and where we are ending, and it's from this where you can even depict certain research questions. It's very important in the era we are to make sure that we have a lot of research papers. And in adolescent, we haven't had a lot of research papers, and yet we can write a lot of these research papers. On linkages, as an adolescent health unit, we encourage our adolescent focal point persons. When an adolescent comes to the facility, there's a tool we use which we call the heads approach. In that heads approach, when they interview this adolescent and they realize that this adolescent or young person needs linkage, we link them for vocational trainings, CDF, or other youth empowerment programs. I know of Triple AZ who have tried to go around some parts of Zambia in reminding people on how they can access funds as young people. We want, when our peer educators graduate at 24 years, they should go out there with a skill. So our key principles in our Bible, which is the Adolescent Health Strategy, is to make sure that the services we provide our adolescents are accessible at all times. There are people who are, a health worker can be available, but not accessible. But so, but we want accessibility to be there. And the services we provide, they should be acceptable. At no given time, should a health worker coerce you to get a service you don't want. And we make sure that the service we provide are age appropriate. 10 to 14, 15 to 19, 20 to 24. We don't give all size fits it all. No, we are very mindful. And we make sure that there is equity. That's why in our programming, we've brought our colleagues with disabilities closer to us. We once developed IEC materials, we translated them into sign language, and with partners like Mary Stops, who still went further to develop some of the IEC materials, and we intend even to continue. And the other principle is to make sure that the care we provide is very effective. We need to be responsive, provide that care in a quality manner and in a friendly manner. If you find health workers who are not like that, you can report them to the in charge or the adolescent focal point person. That's why we have strived so hard to make sure that the focal points are of your age, so that mulela and the language yapa adolescent time. Then these are our focus areas. We have got 6 focus areas we look at. We don't just work. We respond to sexual reproductive health, meaning even preconception. We care for adolescents who haven't conceived. Preconception means you have not even attained your menarche, your puberty. Remember, we are saying 10 to 24. Also, those who fall pregnant, we provide antenatal care, labor and delivery, postnatal care, family planning. The other areas we look at is HIV, AIDS, STIs, TB, and we know that the HIV prevalence among young people is very high. The other focus area is sexual and gender-based violence. Non-communicable diseases, we have mental health, nutrition, and physical activity. Then we also focus on drug and substance use, and also adolescents with special needs. PWDS means persons with disabilities, adolescents who are in orphanages, boarding houses, refugee camps, correction facilities, and those on the streets. We shouldn't leave anyone behind. We need to provide support to everyone. I'll just share with you quickly some of the selected key performance indicators. For positivity, I only talk about the adolescents. We have data for 2021, 2022 based on our what we call DHIS2, real-time data. You find that in 2021, the highest province with HIV positivity was Copper Belt. So Copper Belt, you need to pull your socks up. Then in 2022, the highest was Lusaka. And we know Lusaka and Copper Belt, they compete a lot. We should try to understand what goes on in this. Even when you look at maternal mortality, you find it to be Copper Belt to Lusaka, Copper Belt to Lusaka. So we need to sit down. Then for adolescents who access contraceptives, in 2021, the most adolescents who access contraceptive came from Northern Province. No, Northwestern Province, almost at 50%. Though in 2022, again, they are the ones, again, who had a lot of contraception accessed. This is very good. Northwestern Province, keep it up. Teenage pregnancy. This is one aspect which frightens me. When a girl child becomes pregnant, it's true, there's a second chance when you have the return policy things, but it's not easy because you have to figure out who will take care of your baby. The stigma, discrimination, whatever problems, the best is, if you are sexually active, colleagues, start using a contraception. Or the best is, start practicing secondary abstinence. I think it's better for you. Let's do that. So you find that in 2021, the highest was Eastern Province, Kwatu, Kumawa, Turifukalisan. Even in 2022, and it shows that there's a lot of child marriage in our province. I'm from Eastern Province, I'm with Tembo. Me, I just say there's pandemic of teenage pregnancy in Eastern. Clients who were diagnosed with depression, of the so many problems, Northwestern was highest in 2021, whilst Central, 2021 it was Central, it was highest, 2022 Northwestern. SGBV. Most of the adolescents and young people who are sexually abused are persons with disabilities. Colleagues, let's devise programs which can help these colleagues, especially the blind. How can they protect themselves, especially if they are alone? Me, at times I say, why can't we teach them survival skills? If it's pulling, let them pull. If it's biting, let them bite. If it's beating, let them beat to protect themselves. Because how can a blind person identify the perpetrator? So colleagues who are here and the young people, let's think of programs which can help our friends be protected. If you're not affected, you may be affected indirectly as well, because it's happening to your brother or sister. For STIs, where there's STI, the probability of you being HIV positive is very high. It's surprisingly to see that Muchinga had a high prevalence of STIs in 2021 and Western Province in 2022. We need to up our game. Those diagnosed, I think I've done this, just to bring you to speed, we've got our national adolescent technical working group meetings, a composition where we invite our line ministries, the CEOs, the EDs, or head of mission. Why we want high level at national level is for people to make informed decision immediately. Not when I ask Max will say, no, let me go and ask my boss. We don't want that. Then at times we have the provincial adolescent focal point persons, and we are going to have 10 young people, inclusive those with disabilities. We already selected these during our annual review meeting, but we'll be rotating them. For you outside Lusaka, it will be very difficult and expensive to bring you over. You'll be represented by your colleagues in Lusaka. And that is the composition at district level. And we have community-led responses where we have what we call Adaptive Leadership Zambia. In Adaptive Leadership Zambia, we ride on existing government structures, and we are capable and we are able to reach out to any stakeholder, be it a traditional leader, regional leader, the sex workers themselves, the truck drivers. We are able to reach out to anyone. So we are doing that community-led response, and the same with CBOs. We are doing this in response, trying to respond to the reduction of new HIV infections among the young people. And we are very grateful for the managers who may be here, and those who may not be here, and all the members of the ALZ. Keep it up. Tualumba.
Okay, thank you very much. So I have a little something for people who are going to be participating in the Q&A. So if you have your questions, please just take them down, just note them down, and don't forget to like the Facebook page, don't forget to tweet, don't forget to share. So we are going to have one last mini presentation. If you have your question, please take it down.
Good afternoon, everyone. Oh, the mayor is here. Okay, all right, that's fine.
Okay, so in the meantime, colleagues, please, if you have your phone, I'm saying this for the last time, if you have your phone, please do not forget to like, retweet, and share. And if you have a question from the presentation, please take it down, because we've got a little bit of something that we want to give to a few people. So if you have a question, please take it down and note it down. You might just get yourself something, okay?
Maybe I may take this chance, as she was saying. So yesterday I saw people dancing. And then I was thinking, are these adolescents, or maybe it's me who's not yet so old?
Okay, so colleagues, just an announcement. We have been joined by His Worship, the Mayor of Mansa, Njiko. So he'll be entering in soon. Can you please just acknowledge the Mayor of Mansa as he comes in? His Worship, the Mayor of Mansa, has joined us. Please, let's just acknowledge him. All right, thank you so much, Your Worship, for joining us this afternoon. Ma'am, you can continue with your presentation.
So thank you so much. I find that I'm the one now that has to do the protocols. Good afternoon, His Worship the Mayor, and all government directors that may be present, cooperating partners. Good afternoon. May I simply say, ladies and gentlemen, and the adolescents. So yes, I'm going to take you through a very short presentation. So if I may just have your attention, please. The presentation is as short as I am. Thank you. So yes, I was saying yesterday I saw people dancing, but I was dressed formally, so I couldn't join. when they said they're dancing to a song that's, oh, adolescents, but I said this is the music I used to listen to when I was in university, so it made me feel good, like, oh, I'm not yet that old. Okay, so my name is Katongo Siluizia. I'm currently with the National HIV/AIDS STI TB Council of Zambia. I currently serve as the Research, Monitoring and Evaluation Coordinator. So next slide, please. Okay, so I think I will not bore the audience with the statistics. A number of things have been spoken to, but I just wanted to give this very short context into what we'll be talking about. So my speech or my presentation is more about what we are currently doing for what is called the NACIF. This is the National AIDS Strategic Framework. So we've talked about the estimated number of people that are currently living with HIV and AIDS in Zambia. That's about 1.5 million. I think we can skip this part. We can go to the next slide. I've decided to skip this page because the statistics as at yesterday, a number of them will be old, if I may say that. You heard the Director General speak to the number of 33,000 new HIV infections. So now that will be the official figure that we'll be working with in terms of the estimates. There's what we call HIV annual estimates using a software called Spectrum. And I'm happy because this is a regional meeting. So those of us from Botswana and Zimbabwe, when we get back, we can engage Ministry of Health people. They will tell you that they also have these statistics. And 31st of May is the deadline for all the countries to actually say these statistics are okay. We can now use them. So the figure that was mentioned yesterday, the 3,000, those are the new annual infections of HIV as at last year. This was from the survey. Zambia has been spoken about, but I think by Luwasi. So we can go to the next, so I can have a few more minutes for the NACIF. Next slide, please. Okay, so again, that's a very colorful picture that we all strive to. Hello, are we going to end AIDS by 2030? It's this side that's saying yes. Are we going to end AIDS by 2030? Okay, so I think from this Indaba, what I'm getting is there's a collective effort, but there's also the individual effort. So all of us have to answer that question, either audibly or inside our hearts. Next slide, please. Yes, so this has been squeezed, but this is the key slide that I was hoping to speak to. I think I have to draw a little bit closer because I do not have my, or if the audience will allow me just to move close. So if we can look to the right, to the end, the blue, the small blue tab, it says we have to end AIDS as an epidemic by 2030. That's where we are starting from. And how are we going to do that? Some of the things that have been highlighted in gray is we have strategies. An example is the fast track strategy. We also have the political declarations. I think we've seen the mayor here. He's also showing the political will. We also have regional and sub-regional agreements to which each country has to subscribe to. You know, there's a border between Botswana and Zambia and Zambia and Zimbabwe, but those borders really, they're not physical. So people move from one country to another. So we have to have strategies that speak to what is happening in the region. We also have strategies, for instance, the PEPFAR strategies. You saw PEPFAR was here yesterday. We also have WHO strategies, and we also have other strategies such as the Vision 2030. Now, once we get all of those, they also feed into the next aspect, which is also talking about objectives, for instance. This, remember, is the NACIF, the National AIDS Strategic Framework. This is the document that guides what everybody else does if you're going to end AIDS by 2030. So some of the things that you look at, you say reducing risk. Madam Kasengele was speaking about how we're going to help our colleagues, our friends, for instance, who are disabled. I don't have arms, I don't have legs, or I may have arms, I don't have legs, and somebody has come to rep me. How best can we help our friends say, you can do this to actually help yourself? You can use your mouth, you can use your hand. So we are going to reduce risk, a number of activities. You also reduce the likelihood of transmission. If you are HIV positive, how can we reduce the transmission rate from you to somebody else? For me, as a person who works with statistics, and I get 33,000 new infections, last year we were talking about 34,800 and something, I asked myself, what is it that people that are HIV positive are not doing to pass on the the HIV to those that are negative? It's a two-way thing. And what is it that those that are negative are not doing to acquire the virus from those that are positive? So we have to work together to reduce on the transmission. There's also reduced morbidity and mortality. When I was growing up, it was very common to see somebody suffer from AIDS. So recently there was a study that was done in Uganda, and it was found that amongst the adolescents and young people like yourselves, because most of them haven't seen how devastating HIV and AIDS can be, there's that thing. Some of the data that we are collecting, for instance, in community-led monitoring, are showing that adolescents and young people are more scared to get pregnant compared to getting HIV, because treatment is free and treatment is there. They are more scared. So in the morning, they run to the pharmacy and they get the morning after pill, but they will not bother about PrEP, for instance. So those are some of the things. But do we really have to go back to the point where we saw people dying every day for people to know that actually HIV and AIDS is here with us? No. So from there are other issues that talk about, for instance, the 95, 95, 95. I think I will not really bother so much about that because the minister herself really spoke to this. 95% of those that have HIV have to know, because it's only when you know that you can actually be placed on treatment. 95% of those that know are placed on treatment, and 95% of those that are placed on treatment actually gets to be virally suppressed. So that's where we need to get to know. So again, the question is coming. How many of us have tested for HIV in the last 3 months? By show of hands. Okay. As a researcher, I'll not upload. So as researchers, we just ask questions. It's like I come to your home and I say, do you have a mosquito net? And you say yes. Do you sleep under a mosquito net? You actually say yes. But maybe if I come in the evening, I'll find that you've used that mosquito net to cover your mangoes to protect them from theft, or you've used them as a wedding dress or as a fishing net, or that is what actually happens. So when I ask you here, because it's a recall question, you will say yes. But really, this is where you get to ask yourself. It's the entry point to HIV service care and service provision. So from there, we will move on to what is being called high impact interventions. So you talk about SBCC. I think Lubasi and Madam Kasengele spoke about ABC. For us, even the minister, she said when we were growing up, there were a lot of adverts. They gave us options. Even up to date science and everything else has shown that the only sure way of somebody not getting wet is by staying indoors. If it's raining, not so, you remain indoors. That's just abstinence. But when you talk about that, most people tend to think, that's boring. Okay, so if you choose not to abstain, there were all those messages of being faithful, using a condom consistently and correctly. Most of you in here are in university. You have those mini marriages, if you can call them mini marriages. So after a week, people say, no, we are stable, we know each other. So no more condom. After 1 semester, the relationship ends, they get another person, they become stable, and so on and so forth. So those high impact interventions, SBCC. There's also voluntary male medical circumcision. Hello? I will not ask by show of hands how many people have been circumcised, but you are encouraged to do so. By show of hands, how many people have been vaccinated against the human papilloma virus? How many ladies? How many females? Just a few. So those are the interventions that government has placed in place. The nurse will tell you, hello? At some point, this may prove very, very useful. Remember, you are here as a group, but you're also here as an individual. This is what also leads to the mental health aspect. We can be dancing to the songs of Hamoba or Taitu, but when you're actually hit by this block, then you get to sit and you watch everybody else dance all the way and you are left behind. We do not want that. So voluntary male medical circumcision, please get circumcised for the sake of your partner. You help them not to develop cervical cancer. I'll soon be wrapping up. And then there are other issues, for instance, EMTCT. Botswana, how many people are from Botswana by show of hands? Botswana, please? Okay. So Botswana is one of the countries that was recently put on the list by World Health Organization as having attained elimination of mother-to-child transmission of HIV. They have eliminated the transmission of HIV from a pregnant mother to an unborn child. How cool is that? I think for me, I can use that term cool. Here in Zambia, we are still struggling. Children are still seroconverting before they end the 2-year period of breastfeeding. What is it that we are not doing as Zambia that our friends in Botswana are doing? So meetings like this, we get to learn. Also, maybe finally, one more thing that I can speak about here is ART and a PrEP. Also, STI screening. STIs. That is one of the names in the title for the institution that I work for, National HIV/AIDS STI TB Council. If somebody has an STI, chances of them also being tested positive for HIV are quite high, actually. But we normally don't take to talk about that. We don't talk about PrEP or take PrEP and all of that. No one gets to talk about things like somebody can end up having STIs. And STIs will affect not just you, they also affect maybe even the children that you have. You've heard of those congenital syphilis? You end up having children that are blind because you didn't want to get screened for an STI. So all of those aspects. By the way, I think there's a new controversial contribution by Dr. Chitembo from WHO. He says certain STIs, you can acquire them even if you use a condom. So it's always good to actually be screened for STI so that you know, you get the care that you need and then you move forward. There's also the aspect of involving key and vulnerable populations. I think that was talked about yesterday by Dr. Musheke. This morning, there was also the talk about our friends who are living with disabilities. There's also talk about involving different populations. It's coming out as young boys and young men who are recently, in the past, left out. And then in the end, there in blue, we have a number of things such as leadership. I think in the past, we've shown how well our leaders have engaged themselves in dealing with issues of HIV and AIDS. The minister herself was here. And one of the commitments that she said, next year, we want to see ourselves at KK International Conference Center. Is that not leadership? We also see a young mayor coming here to be with you. So even when you're saying the language or when he has to go back to the house to represent us, he will ably represent the needs and the aspirations as well as the sentiments of the young people. So all in all, I just want to speak to that last line that is at the bottom that says synergies with the development sectors, other line ministries and all of that. Somebody earlier had posed the question about how do you engage traditional leaders, for instance. How easy is it to go to Eastern Province where Madam Kasengere comes from and say things like Chidielano? How many have heard of Chidielano? Yes, only to Chidielano. Okay. So this, you correct me if I'm, this is where people get to exchange sexual partners. I think in essence, sexual partners. So it's a party like the way we were dancing yesterday, and then you can match up with anybody of your choice. So whether they've come with their husband or their wife, when you go to that function, hello. So now with practices such as that, how do we then get to end HIV and AIDS before 2030? So this calls for engagement with the traditional leaders because it's their culture. If you tell them not to do that, they'll tell you, who are you to come and tell us not to do that? So maybe you need a person like myself, a Bemba, to casually engage with them and say, even if can you please stop this nonsense? But also in Northwestern Province, there's also what they have at, they have, and it's actually similar, but they also get to exchange things like teaching a young lady how to handle a man in bed when they come out of age, when they come of age at 12 or 13. Obviously, somebody wants to go and practice. So, but those are things that are embedded in people's culture. And maybe these things perpetuate gender-based violence. How are we going to break all of those things? It calls for talking, sitting around the table like this and engaging them and trying to make them see the ill effects of all of those aspects. Otherwise, just telling them to say stop, it's almost as if you are hurting their ego. You know, we've been doing this for hundreds of years. Who are you to come and tell us to do this? But for me, the key, it's you who are seated here, the young people. You are the key. What you do affects your future. It also affects whether you'll be here or not in the next 10 years. So please, please, even as you engage, don't feel that you are invincible. We need you. Zambia needs you. The region needs you. The world needs you. After all, if you're not here, how are you going to go Kuchalo? You will not go Kuchalo. So please, I think herein ends my presentations. If there are any questions from here, thank you.
All right. Thank you so much for that presentation. So we've also been joined by Namsa Patrick Mpundu, who is the Shainda Ward Councillor and also the Speaker of the 3rd SADC Youth Parliament. So if you're here, please just wave so that the people can see you. All right. Thank you so much. All right, just an announcement. So we are actually having a challenge on Facebook. So it's Zambian Youth Platform on Facebook. So if you have your phone, there's a challenge there and there's a giveaway prize. So it's actually a poll which is happening. So the person with the most likes in terms of their comment gets to walk away with a secret prize. So if you have your phone, please go on Facebook on Zambian Youth Platform. And then there's a challenge which is going on there. So the person with the most likes on their comment gets to walk away with a giveaway prize. Okay, so for those who have questions, I see we already have hand, but I'm also going to try to make sure that the others who are at the back. Okay, so I'll just take one question. One. Okay, so the lady in red, just make it short. Please let it be a question, just a quick one.
Hello, everyone. So my question is directed to the panel. What have we done differently before the strategy? What is different that you've been doing for the past 1 year, 5 months that is going to help in reducing the HIV cases? Thank you.
Okay, so I think they got the question. The question was on what have you been doing differently?
Thank you so much for your question. What we need to start talking about
such as the NASIF, translated, you could translate like reproduced in a format that our friends who are living with disabilities can actually access. It will not be the whole document that will be put in Braille, for instance, but we'll pick the salient features of that document and then we'll put it in Braille. So those are some of the things that we are seeing as being some of the ways that we'll do different to try and see how best we can engage everybody. And I think if you may also bear as witness, conversations, as Mrs. Kasengele said, that I had to have are actually happening. We had a conversation again about 6 months ago with the help of TAUC and NZP Plus, and a different groupings were brought for these discussions to actually go forward. So the more we talk about these issues, the easier it will be to deal with them, and then we'll break those barriers. Thank you.
The last one I forgot to mention, we are going to coach boys into men. We want responsible boys. When you see a kagelo, want you to see a sister. You protect that girl. So we are going to have your own sex at the right time when you are going to get married. You'll be having it 24/7. But at the moment, let that girl child finish school. We are also going to coach girls into women. We want normancy to come back. We don't want to say, it's not helping us. I saw my friend there using sign language, though I didn't understand what was saying. It seems he wanted to say something.
So we have a burning question from the crowd, just one. So we'll allow him to speak.
What I want to add, first of all, thanks so much for everything that is being said. When you mentioned Braille, that you translate the document into Braille, we also want to also mention that translation to sign language is also important for the deaf. For example, if you see at the back, we've got those pop-ups. They've got signs, if you can see their images. We worked with Maristops International. So that's an example. Maybe at your free time, you can just walk to those pop-ups and see how we can do it. So because the sign language, in case you didn't know, is not English. Sign language is a language on its own. It has got its own grammar, its own rules, its own vocabulary. So meaning when a document is in English, it has to be changed to sign language grammar. So I just want to also to emphasize that also when we talk about translating to Braille, we should never forget sign language. And that's why we're also encouraging people, a lot of people, to learn sign language. That will be, so translating in sign language materials also help people to learn signs. So I'm praying that that committee you mentioned, you said there are 10 youths in the technical committee, something. Is there a deaf person there? So I'm asking that, can I be part of that committee as the president of the Zambia Deaf Society?
Okay, thank you. I noticed that we still have hands in the house, so we're just going to take 3. Please make your question as brief as possible. So we have one at the back there. They have been raising their hand for a long time. Please make sure they also get the back, right at the back.
Thank you very much. My question is based on, we've been mentioning on the key population, and in the presentation of Ma'am from the Ministry of Health, she has mentioned of sodomy, and of which I really like the points that you are mentioning to address that case in the community. But in some of the presentation that have been given, I'm seeing as if we are trying to focus on the LGBT to really amplify it a bit. So I just want us to be clear on how best we are addressing the LGBT in our communities, because I had that as a very highlight point in our most of presentation that have been given.
Okay, and colleagues, please just make it brief. A brief question, okay?
Hello, my name is Kelvin Mononga. So I have a question. I've actually realized that family planning has been a major contributing factor to the rise of HIV in adolescents, especially from the age of 15 to 16. So my appeal is that is it possible that we can have policies whereby every young person who wants to access family planning, they should also access PrEP, because the fact is that provided that someone has accessed family planning, that simply means they're having unprotected sex out there with everyone. Thank you.
Okay. So for the next person who is going to speak, if you ask a brief question, we'll give you something. A brief question, not an explanation.
My name is Mary from Chadiza District, Eastern Province. And my question is, I would like to know the organization that sponsors young people who get pregnant, especially girls at a young age. They give them about 500 kwacha, and that is leading to high numbers of teenage pregnancies in Eastern Province because young girls are getting pregnant so that they can receive that 500 kwacha as kanga chepe.
Okay, thank you so much for the questions. So the question here was, you want to know the organization that gives money. Okay, at least that was a question which was brief. So we just allowed them to respond.
I think most of the questions will be answered by the chief nursing officer. But again, as I said, my colleagues or my cousins, traditional cousins from, how do you do a cost benefit analysis of me getting pregnant and I'm given a 500 kwacha to go back to school? I think I need to visit the chief. Is it in Kosiama?
Thank you so much for your questions. When I talked about sodomy, my girl, we've realized that we've dwelt so much on a girl child. We've neglected the boy child. And it's the boy child is sodomized. MSM nowadays is from the big man to a small child. Woman to small boy, we used to call them blesser or blessee. I don't know how we'll be calling these people who do men MSM to the young boys. And if you notice, especially those boys who are on the streets selling things, and in Ikapiri, I saw Piri yesterday being awarded the maleness in Ikapiri. We need to have programs for such boys where they can protect themselves. So we are not advancing what you were suggesting, no. We just want to make sure that the boy child is also protected. Inena kwata abana omwaume n'omwana kashi wansi nali batemwa DL. Can I say I will have Katebe, then no, yes, I will have Katebe, then Ed and Chirufia. Since they are boys, it's okay. No. They are all my children. Then on those of the 10, by the way, we are very mindful as an adolescent health unit. I've got my friend there, that's when I've seen her. Mabel, how are you? Of the 10, we have 5 female, 5 male. The first on the list was who, Annie? Who was on the list for the 5-10 ladies during the annual review meeting? The annual review meeting we had in Sofwa, Sampa. She's disabled. She can't see. She's blind, for lack of a better word. Then for the guys, we picked 5. So the person we picked with a disability is Ian. Ian is physically challenged. He moves on a wheelchair. So we're very inclusive. Then for PrEP and family planning, our workers, health workers, is to provide a service. And we make sure that we integrate. Remember, we've been crying for age of consent. And most of you have labeled our health workers not to be friendly because they didn't provide you a service because you are below 16. But if we realize that you are sexually active, we'll still provide you the service. Then for the 500, it's very sad to misuse that innovation. I think that partner should stop and find better ways of doing it. It's like to say, it's okay to have HIV. I'll go and have PrEP. Like the story I received a week ago, which is saddening. Students at UNZA, the University of Zambia, in the clinics on Monday, they line up in OPD to come and collect PEP because they didn't protect themselves. Which is better, PEP or PrEP, if you know you're sexually active? So we have got a lot of work to do. All of you here, I consider you to be peer educators. You are trained in one or the other. Let's reach out to these people. To our mayor, representing other mayors in Zambia, what we need at community level, if we can have adolescent friendly spaces at community level, because where in our facilities, those structures were built a long time ago, and there's no space to expand it to. And when our partner beautifies a space, you find other people are intelligent and clever, they'll grab that space from us. So we want through CDF and other empowerments, if we can have these friendly spaces. You can't have a hospital. What we can provide is a friendly space where you can meet with your friends. You and I are busy people. The way we were brought up, the way we are socialized is different. I may find it to be very uncomfortable to talk about sexuality. But if we have these peer educators in the space, they can teach their fellow friends. Even those structures at community levels which are idle, give us those spaces. Let's turn them into adolescent-friendly spaces. So this is what I wanted to say, just so that.
So thank you so much. Maybe, I think in my presentation, there was that very key, a board, blue colored, that talked about key populations. I'll ask a question. How many of us have heard of Bluetooth? Bluetooth? Not the Bluetooth on the phone. Yeah, so Bluetooth is one of the ways that our friends, for instance, who inject drugs. Yesterday, the Honorable Minister spoke about alcohol abuse. So that's one of the other areas that we're also looking at in terms of putting in the NASIF. There was a presentation that was done yesterday, a number of mental disorders that are reported, for instance, at Chainama, are attributable to alcohol abuse in Zambia. I'm not sure about other countries. So as opposed to looking at just those who inject drugs, I was coming to the injecting of drugs. So because the drugs are so expensive, people form groups. They form groups, then they buy that drug, then one person ingests or injects that drug. When the person gets high, they get needles, draw the person's blood, and then they re-inject themselves. That is what they call Bluetooth. So as a National HIV/AIDS STI/TB Council, we say, if we have to reduce or if we have to end AIDS by 2030, we remember we're talking about reduction of transmission, reduction of acquisition. This is where we are engaging these people we are calling key populations. There's something that they are doing that you and I may seem to be like, oh, but it's something that will affect all of us as a public health threat, including the people that Madam Kasengile was talking about. If people are engaging as male and female, what is it that they can do to protect themselves from acquiring or transmitting HIV so that the rest of the population is also protected? In the health sector, our focus is public health. All other issues are dealt with by other arms of government. Your focus is public health. Whoever comes to a facility, whether they're a criminal, we will provide the service, and thereafter other things will follow. So that is the aspect at which we are looking at these things.
The last one. This one I can stand. I'll stand as a midwife. Forgive me, Chair. It disheartens me as a midwife as a mother to see this beautiful young girl, giving it to him through the anus to maintain virginity. That is wrong, girls. Stop it. The problem when you fall pregnant, okay, I'm saying it disheartens me as a midwife and as a mother to hear that the girls now are giving the boys through the anus. They're having anal sex to maintain the vagina for virginity. So that dilaba namasi bakamingisha mukale munganda bakalanda ati awe nikana chisungu kanshi fintu nishfyali onaika. The badness with using your anus, girls, with pregnancy and pressure, what happens? The anal sphincter, with that, you lose sensitivity. So what will happen? You start competing for diapers. Iyabalwele ba stroke na iwe mutampe uta compete. At one time, we even ran out of stock of diapers. Let's stop it. Why do we like doing these things for men? Chibema insertions, vaginal insertions, it's you to please a man. Why can't a man also use able drugs to entice you? Why should you stoop so low? All the time want to do it for a man. So please, girls, those who are using your anuses for sex, stop it. There's a condition which we call obstetric fistula. The way Katongo is seated, she won't even realize that stool has come out. It will just come out. Even urine, it will just come out. And you are going to experience self-stigma at first to start with, the depression we are talking about, and other things will set in. So please, girls, do it for yourselves. Don't do it for the boys. Morobolo mwenda nabo. Tekwa batebo eba kamyupa. Tabala fyalwa aba kamyupa. Bachidumuleba wadi. Concentrate with school. Concentrate with school, girls. Umwana kashi, sorry. It hurts me. I'm sorry. Sibu may be different from Katongo. Katongo will be providing to me as a mother monthly money. Sibu, it depends what type of a wife is going to marry. I won't even be seeing the money. That's why umwana kashinga upwa tafuma munganda. They remain at home. That's why we support our mothers monthly. But guy kula bakwati, now I've got a wife and a family. Bala baba baletere pachalo who brought them on earth. So girls, and it feels good. It feels good to press those 4 buttons. So concentrate with schoolwork. Thank you.
Okay, thank you so much. So another big round of applause to our lovely panelists as they take their seats. So I'll just call someone to just give us a few announcements as we proceed with our program. Thank you for being interactive and for engaging within this discussion that we're having.
Let's clap for Titi. I think that was amazing. And to our panelists, thank you so much for the evidence you've presented and everything else you have taught us. I can testify that we are all smarter now than when we got here. And I think I'll just read a few comments from Facebook. Sorry. Imate Bruno Nyambe says, where are we failing? There's an ongoing fight against stigma. People can't come out of their shells to known and unknown fears. This has served as an existing barrier. A need for more safe spaces and clear, well-rounded discussions such as this one is surely the way towards achieving our objectives and meeting our goals in space. This is amazing. Imate, see me for a giveaway. And also we have another comment from Regina Chitakwa who says, I learned that whatever program we have in our organizations, we need to have the sign language interpreters so that even the people with disability will be involved and get more information and learn also. Regina, please come and see us for another giveaway. What next do we have, Natasha?
Thank you so much for being a lovely audience. Are we hungry? Are we hungry? The voices are not loud enough, so I think maybe we can stay for another hour, right? Just one more hour. We can go at 15. Okay, so now before we go for lunch, we do have a little bit of entertainment just to jive and vibe a little bit, shake off. You've been sitting for a very long time. So we just have a little bit of entertainment. But before we go or we have our artists perform for us, is there something that you'd want to share with our audience? I don't know, is there maybe from you, the audience, is there something that is burning that you'd like to just make remarks on? Anything you'd want to maybe inform our partners that have been here in front? Any from our audience? Okay, I see hands.
Hey, hello everyone. Sorry, I don't want to waste much of your time. I've had the interesting discussion, our two mothers that were on the panel, talking about girls, having an anal sex to maintain their so-called virginity, and then use of drugs. Those were very good points and very educative. But then, have we ever tried ourselves to know why girls are doing that? Why girls are getting involved in such vices like drugs and anal sex for money. What is the reason? A lot of girls, especially young girls and even young boys as well, they also have different challenges and problems that they go through. And in Zambia, we don't have therapies, to give them therapies or counseling, for example, services to help the youth, so that they make informed decisions. We don't have that. So if every day we educate them and give them therapy, they can stop such vices. So we have to know the root of the problem. Instead of just encouraging girls to solve that, but we have to know the root of the problem and address that root. Maybe they need counseling therapy or they need psychosocial therapy. So that's what we need to do. And then also we need to try to help, we need to try to help to solve the problem. If we want to change things, otherwise we'll just add more problems here in Zambia. So I think we have to invest more in mental health. To me, I think mental health is key. Thank you.
Thank you. Indeed, we have to invest more in mental health. Yes.
Good afternoon, everyone. The discussion up to yesterday, and today is very nice. But my concern is Ministry of Health, for example, and other partners like NAC and so forth. When they give the presentation, they leave instead of staying here with us to hear from the youth. We have a lot of burning issues as youth, and the comments that are coming here are amazing. It would be nice if they are all present, the minister is here, or the partners are here throughout, so that they hear our views. Because now it's like we're just talking to ourselves. They give the presentations and then they leave. How will they know what we're talking about as youth? So I'm asking that, is it possible the organizers can invite the Honorable Minister to stay with us tomorrow?
Thank you so much. I think the colleagues from the Ministry of Health and NAC have heard that young people are happy that you come and give the presentations, but they would be more than happy if you were to be present, especially tomorrow, because they have a position paper to present.
Okay. Okay. Good afternoon, guys. Okay. Okay, I just wanted. I thank the supporters and every organ that is supporting this meeting. We thank you. Okay, but my concern is all this the supporters that were here yesterday, they are not here, and they give speeches, but how will they hear to us when they are not here? So we are begging, spreading. If you can just ask our mother maybe to come back tomorrow.
Minister of Health. Okay, so we'll take one remark. We really have to. I know we do. I know we have a lot to share, but we also want to. Okay, should we stay back for questions or we go and eat? Okay, so I know we still have the afternoon session, but I'll just take one more and then we'll have entertainment. And then in the afternoon, I promise in the afternoon I'll get your remarks.
Can I just come in front if it's okay? Hello, everybody. I want to be in front because I want everybody to hear me. So can I please just have your attention? First and foremost, this is a recommendation that is going to Madam Katongo, where you talked about women having to be taught about taking care of a man at an early age. So yesterday when we have a discussion, okay, thank you. So yesterday when we're having a discussion with some parents, they talked about not actually changing our culture because that is our unique identity. It is something beauty that we have. So rather we can just have some changes to that. Yes. And then something else, youths by youths, we like, I think it's high time that we stop having these indabas. Be talking about the same things over and over and over again. I think I'm just too much over this. It's high time that we have the next time we have an Indaba, we just have a review of actually what we talked about last year. We can say, is this working or is this not working? And something else, people, that we need to realize right now is that we are the leaders of today, tomorrow, and the future. Let me tell you, the man that you've seen right there, he's going to retire someday, or anything that might happen, God forbid. And it's high time that if we want to be the future leaders of that day, we have to start acting now. It is high time. Thank you. Guys, it is very much important that if we see that something is affecting us and we know the solution and we bring it on the table, it is not taken care of. If needs be, we need to take it by force because we are the ones that are experiencing the problems and we know the best solutions to them. So we need to start acting now because, again, all the government officials that are here for us. And we should be the priorities because we are the leaders of today, tomorrow, and the future. Thank you.
Thank you so much, my friend. I think you deserve a gift. Thank you so much. And I think what my key takeaways from the people that have spoken is, firstly, we are the leaders of tomorrow, and there's so much we must do today in order to have more impactful engagement in the future. And more importantly, that young people are happy that our partners and sponsors, and especially those from the Ministry of Health, NAC, and other key organizations, are happy that they come and give us presentations. But more importantly, ma'am, they also want to see you tomorrow because they have a position paper to present, and they would be more than glad, and the Indaba would reach its full meaning when they see that the partners and sponsors and implementers are here tomorrow. I think let's clap to that. Thank you so much. And now, since you had your tea break, you were a bit full, so we want you to be hungry again so that we can quickly go for lunch. So we are going to dance now, such Mumbelenjala. And then let's give a round of applause to our artists that are coming to perform for us this afternoon. That's why it's Vabuela Sumto Tamushe. Let's clap for them again. So he'll come tomorrow. Okay, but who do you think is coming now? Huh? If you actually get it right, I'll give you 2 gifts. Roberto, another one? Okay, okay, okay. Last answer, last answer. Yes, shout. Sorry. Okay, let's clap our hands for.
Yeah. Yeah. How's everybody doing today? You know, we're back again. Are you guys feeling all right? Are you feeling all right? All right, let's go, let's go. To the left, let's go. To the right, one more time. To the left, to the right, one more time. To the left, to the right, to the left, to the right. I need everybody's help. To the right, to the left, to the right. One more time. Left, right, and shut it down. How's everybody doing? Are you as hungry as I am? Very hungry, huh? I know in Zimbabwe you say sadza, right? Here we say shima. Those from Kenya you say ugali, but here we say shima. So guys, before I perform my next song, I just wanted to share something with you because it's important, just as you are important, right? I believe the future is right here with us today. Because all of you that are here, I have a feeling everything we are discussing here will be impactful in our communities one day. As a public figure, I wanted to touch on something called discrimination. If someone like me today walked into a store and I went to buy a condom, do you know how much news that would make? It would be everywhere, right? Roberto was seen buying a condom, right? And that is what we need to fight. Imagine it. Each one of you guys have got a role to play, and your presence at this health Indaba is very cardinal, it's very important. Let's speak to our friends. It should be something that is easy for you. Prevention should be easy, not the after effects, right? It is easier for you to go in a store, buy a condom for whatever it is that you want to do, than start taking medication for years and years and years to come. So we need to have a mindset shift that we tell our brothers and sisters to do the right thing, right? And that's what we're here for, right? So since we say that, can we party? Seeing so many beautiful faces, I got a song called Beautiful. I want to sing it for you guys. In case you don't know it, I'm gonna teach you the song. How many know a song called Beautiful? How many? How many don't know the song? Okay, for those of you that don't know it, I'm gonna teach it to you. I'm gonna teach it. Listen. Beautiful, beautiful. You are beautiful. Wonderful, wonderful. Kunkala na iwe, ona nena chinja because of you, mama. Kunkala na iwe, ona nena chinja. I think you guys are not even hungry, you can sing. So let's do it. Are you guys ready? All right, selector, let's go. It's a beautiful day, right? Super beautiful day. Are we ready for it? Please turn up the volume. We're ready to party. Let's go. And everybody say what? Hey. Thank you so much, guys. I hope you're having a great day. Make some noise. Are you excited to see another great artist come through? So that when we go to party, hold on, we're going to take pictures outside. Don't worry. So that when we go and have our lunch, it's exciting, right? I want everybody to say tie two. Say tie two. Say tie two. Ladies and gentlemen, Zambia's greatest legend is here today as well. Make some noise for tie two.
It's a quantity loving, that is a quantity true love. Mutima wako chekondi chako, chabene ni mafuna lavi. Eka ni kukuombe, nikukonde mutila ya benisiwa. Natutika ya mchesana, ifamene ni mafuna lavi. Eka ni kukuombe, nikukonde mutila ya benisiwa. That's it. Evampele, Bamafuna, Kupesa Seconde Sevanga Campe. This is true love. Oh, this is true love. For my pena vale bemwai. Bamakala beka moyo wabo onse. Sekote Bamafuna yai. Pena bema futa mete masisiyana. Munga mumana, wamene sunga yumelabe. Tia chikonde changa baliweo, tia mutima wanga baliweo. Mutima wanga chikondi chamene ni mafuna, eka ni kukonde, nikukonde mutila ya benisiwa. Natetika ya mchezana, nifamene ni mafuna, eka ni kukonde, nikukonde mutila ya benisiwa. Mutima wako chikondi chamene ni mafuna la. Eka ni kukonde, nikukonde mutila ya benisiwa. Natetika ya mchezana, famene ni mafuna la. Eka ni kukonde, nikukonde mutila ya benisiwa. Pena bakate pesa chikondi, siva masiva poseta nacho. Koma kukongeleza beba titabanzabo, koma kukopela pamene baona kumbali, ati mwabaona batabatita baso, pepe na ise, tiye seko. Bama ebala ate chikondi, tiye nokala pale babele, kupeza vintu vote tabeka, kupeza kose koyenda beka. Munga mumana, wamene sunga yumela. Leka nikukonde, mawa chikondi chako, chavene ni mafuna. Leka nikukonde, nikukonde mutila ya benisiwa. Natetika ya mchezana, nifamene ni mafuna. Leka nikukonde, nikukonde mutila ya benisiwa. Mutima wako chikondi chamene ni mafuna. Leka nikukonde, nikukonde mutila ya benisiwa. Natetika ya mchezana, nifamene ni mafuna. Leka nikukonde, nikukonde mutila ya benisiwa. Leka kamba nikukonde mutila ya benisiwa. senekamba njila inakoma njila yamene umane pasa chose tekakala pase kukamba ukaniuza pamene ofonda kulepe chetu tena chene pasa chimwemwe mungakose vane malenga muntu wena kaze kala okotwela chifukwa chaine sanga indile mailo ine temufela baby wamene yakukonda na mutima wake wose na moyo wake yangapase paliweo. Oh baby, this is real love. Mutima chekondi kati chamene ne mafuna eka nikukuambi nikukonde muchila kamedisiba datetika ya mochesana nifamene ne mafuna eka nikukuambi nikukonde muchila kamedisiba mutima wako chekondi chamene ne mafuna that's it nikukonde muchila kamedisiba datetika ya mochesana nifamene ne mafuna eka nikukuambi nikukonde muchila kamedisiba mutima wako chekondi chamene ne mafunda deka nikukuambi nikukonde muchila kamedisiba datetika ya mochesana nifamene ne mafunda deka nikukuambi nikukonde muchila kamedisiba. Thank you very much.
Wow. Sure, thanks.
Hello? Okay. So my people from Zimbabwe and Botswana say it is not fair. We don't know this song. We don't know how why you
Okay.
so but she was dancing to the song.
You want us to play Ja Praise? Huh?
I'm a piano. DJ, can we play I'm a piano? Iwe, eh, eh, eh. Come on, Iwe. Iwe. Come on, come on, come on. Okay, 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 okay. Thank you so much. All right, guys. All right. So I have someone here who was saying, you know, they should dance to our song. They're in our country, so they should. As when you go to Rome, you do what? But I think they did that justice. They danced very well, right? Give them a round of applause, guys. So, how did you think they vibed? How do you think they? Can anyone outdo what they did? I want someone to show me from the crowd. If you think they didn't do justice to the song or to the dance, can someone in the crowd just come through and show us how it's done? So they were amazing. They were amazing. They did great. Who? Okay, so I'm hearing names somewhere here. Okay, no, before that one comes through, let them take a seat. I think they're tired. But you get some caps. My colleague will bring them to you. You get some caps. We have some bags. Thank you so much. You guys were great. You guys were great. You were amazing. Please come through if you're still outside our ashes. Please help us mobilize everyone that's outside to come through. But now I'm back at Shanyapo. Achanyapo. Who are we? Who's going to outdo what they did? Lasti. Who's Lasti? Lasti Ima. Isakuno iwe. Come here. Come kuno. Lasti. Yeah. Where are you from, my friend? Ako Paralaka. Okay, Lasti. Peleko echiruim.
Is your name Lasti? Huh? Trust.
I'm so sorry.
Okay. What song do you want? Papa.
The DJ, not Kwata Baba. One new. Oh, so it's a new song, but I don't know if our DJ. Celeb City, do we have that? Okay, so the DJ is helping us to look for the song. So in case we don't have that one, which other song can we play for you? Which other song? Nanga Kaya. Support system in the Support system in the house.
Let's give them another round of applause. You have really represented Copper Belt.
But no, now I agree. Copper Belt is another nation. Chalo Chimbi. All right.
Thank you so much. It's another country, but it happens in Lusaka. Eh? Okay, so we still have a lot of people outside. If you're outside, you're supposed to be here right now because we are about to start the afternoon session. And those of you that came to dance, we remember you. Your gifts are with us. Yeah, you can just come and see us. Okay, no, we won't forget you, don't worry. And also, so we are still streaming. Remember to share, comment, and you might still go away with something. The day is still young. At this point, I'm going to call the youth from Mopani Mine. So they're coming to give us a poem, and these are young people that are supported by the USAID Access to Markets for Health project that is being implemented by the Johnson Health Initiative in Zambia. So let's give a round of applause to the young people from Mopani Mine. It's the same people. Marvin, you've already done, so you can. Let's give them another round of applause.
It is just magically. It is just so essentially. When I think, when I sit, I dream, which makes me a dreamer. The power of a dream is something you can't realize until you live it. As I speak, the sky is purple pink, and the birds outside flies and chirp. Their chirp tells a story. It's a story about a youth, vibrant, colorful, pessimistic, and innovative. The youth are a key population as far as the HIV infection and treatment is concerned. Before you decide not to engage the youth in the fight against the HIV, try asking the HIV victim the power of life and treatment. Yes, the HIV patient. Not a stranger to us. It comes as love with the letters for Ranger.
But you
have the time.
part of every second you have to make a difference about this.
Your life and the product of your choices and the proportionality of your actions.
The power for new HIV infection. That you may need in a better way. I believe this from young person. They need to classify most of the person HIV affected.
The active participation of every youth in the later prevention strategies such as A.
Abstinence.
Refraining from premarital sexual intercourse is 100% guarantee of not getting HIV, STI infection.
Be faithful.
Maintaining a faithful relationship with the long-term partner.
Compromise. Don't use drugs. Education. pessimistic.
We close the tap for the new HIV infection. I am in control. You are in control. We are in control. Together we can close taps for new HIV infection. We don't win. Don't run, win. Abstinence.
People party.
So, good afternoon, everyone. So, where we are coming from, there is a certain way we used to appreciate our fellow adolescents. So, allow me to go upon my screen so that we can show you. So, the first one, we are going to give it to the organizers, the ZYP. So, it's Chiria Soan. Kopa ya kilo. Zona zona ba ZYP. Na kabiri. Zona ba ZYP. Okay, so ichilombe chama adolescents bonse na mayouth abali munwani. Kopa ya kilo. Zona ba youth na kabiri. Zona ba youth. Then lastly, kwanso kotwaya tatula ba abstinence ani. So twakwata chi abstinence kilo. Abstinence kilo. Fimo poke na kabiri. Fimo poke makaye bwangu.
Atapena baba.
We might as well just change the program to let them run it. Aye. Let's give them another round of applause. The Republic of Copper Belts. Hey, you should be quiet now. You've presented Mwaja Mungalezi Manjai. Okay, so I want to give a t-shirt to, I want to give a prize to someone. Yeah, I want you to keep quiet. I'm gonna chase him, convey my gift. No, you will get your gifts. You will get your gift, don't worry.
Okay, so I think at this point we'll get into our next session. And at this point, I would like to welcome to the stage Dr. Miti, who will introduce the team that are going to make a presentation. So can we have Project Yes that is going to make a presentation for this particular session? Dr. Miti, please come through. A round of applause.
Thank you very much, everyone. And regards from the Copper Belt once again. My name is Sam Miti. I'm a pediatrician and I'm also a researcher. And today I'm just going to ask that the team from Arthur Davison Children's Hospital comes forward. I'll leave it to them to proceed. Thank you.
Good afternoon. Allow me to recognize the presence of the mayor, invited guests, our parents that are here to support us, adolescents, and my fellow young people, distinguished ladies and gentlemen, all protocols observed. My name is Walusungu Mlenga from Arthur Davison's Children's Hospital, Project Yes. And of course, I am not alone.
I'm here with my fellow youth task force members. We're here today to promote health equity for youth living with HIV. Although Zambia has attained 95 paper HIV control targets, with 96% of all people living with HIV virally suppressed, adolescents and young people are still lagging behind in achieving viral suppression and experience stigma and discrimination, and the number of new infections is high among adolescents. Currently, Arthur Davidson Student Hospital has a support group for youths living with HIV and Projects Yes, meaning youths engaging for success. Projects Yes is a peer mentorship program which with peer mentors are paid, trained young adults living with HIV that led on one-on-one and group meetings with adolescents. Projects Yes youth peer mentors were trained for 2 weeks on professional development and how to interact with adolescents using the materials provided. Youth peer mentors connected with adolescents and young adults living with HIV by discussing shared struggles, modeling positive health behaviors, and establishing judgment-free environments. Youth peer mentors experience powerful personal transformations in HIV-related health behaviors, conceptions of self, and plans for the future. Many expressed now seeing themselves as community leaders, game changers, ambassadors, and not just alone in this world. They described newfound commitments to reaching personal and professional goals. Projects Yes increase viral suppression and adherence and reduce self-stigma. At the beginning of the study, half of the youth reported feelings of worthlessness, shame, and blame because they're living with HIV. Projects Yes was able to reduce this by half. In 2020, CDC named Projects Yes as an evidence-based intervention, and today it is still the only CDC evidence-based intervention that was developed, tested for youth living with HIV in sub-Saharan Africa. Sadly, around that time, Projects Yes ended, COVID also struck, and there was no scale up. This, in short, meant that other young people who can greatly benefit from an intervention such as Projects Yes have not been able to. Thank you. Now, allow me to invite one of my colleagues just to share the personal experience they had and also their testimonies.
Good afternoon, everyone. Good afternoon, everyone. I'm here to share my story. Don't mind me having the paper, just for guidance. My name is Namatama Stwala, age 19. I was born HIV positive, but discovered when I was 12. I took a year having those drugs, minus me knowing why I take the drug, till I was 13, when I was told by Dr. Miti why I take the drugs. I was shattered, of which I stopped mingling with my friends and families. I preferred being alone because I thought I'm going to get them infected. I was confused and left out, of which the only thing I was thinking was killing myself. At some point, I even stopped staying with the sharp objects because the only thing in my head was killing myself and murder. My viral load at that point was very bad, of which when I'm told to take the drugs, I will throw or hide them somewhere else. I came across and I started getting sick often till my grandparents talked to the clinician and counselors at ADH who introduced me to this group called Project Yes. Project Yes helped me, not only me, but my fellow adolescent learn about HIV and understand what it is. Not only that, they also taught me that being HIV positive is not the end of the world, but you can also do what other people can do. Apart from that, I was also given a mentor called Trisha who taught me how to take the drugs on my own and also take those drugs at the correct time. After some months later, I went for review and my viral load was undetectable, of which I'm still holding the undetectable part. And the good part is that I've achieved the U is equals to U target. All thanks to Project TS. And now I'm able to cancel and encourage my friends fight stigma and discrimination. All thanks to Project TS. Thank you. I'll pass on to my fellow colleague as she explains her journey.
Good afternoon once again. Thank you for giving us the opportunity to share our story and the journey with Project TS and how Project TS really helped us in the most time that we needed it. Hopefully, my story will help a fellow youth out there. My name is Anamushi Susiko Namakando. I started my treatment in 2015. Before I started my treatment, my family members knew about my status but did not take me to the hospital to initiate me on art. They mocked me by asking how I was doing, and yet I thought they cared. Whew.
During that time, I never grew a hair. I had seasonal body sores, and my family members would ask if I was put on TB drugs or Septrin. At that time, I never understood anything until I grew older. I came to know more about HIV and I broke down into self stigma. I felt guilty and shame that I'm living with HIV to all my family and my friends. I lived in multiple households because my family members continued to deny me because of my status. They continued to deny me because of my status. They were not comfortable staying with me, so I moved to Ndola. But still, I was never myself because where I wanted to go, I was denied because of my status. Still, stigma continued. Eventually, my precious uncle accepted me and he advised me to start my treatment, which was in 2015. In 2017, I met Sister D at NTH, who introduced me to a project called Project TS. Before Project TS, I never knew the importance of taking drugs. I would take drugs at any time. Project TS enabled me to have someone to talk to who was a peer mentor, who was never in a white uniform that I would fear because she was a fellow youth. I was so comfortable to express myself, especially in the one-on-one meetings. I talked to my mentor about my experience before I was initiated on art. And in the group meetings, I was given a privilege to share and to speak to my fellow youth without being judged. I learned more about HIV, adherence, and disclosure. I made friends and I heard different stories from my fellow youth. This encouraged me to continue taking my drugs at the correct time, and I grew mentally, physically, emotionally. One major thing I learned from Project TS is how good you take your medication is how good your health will be. I'm proud to say I'm a youth living happily with HIV and I'm a non-detectable youth. Thank you.
Good morning, good afternoon, everyone. My name is George Msonda, a former youth peer mentor for Project Yes, and I'm going to share my life story living with HIV. It all started in 2011 in Lusaka. At that time, when I was told the outcome of the results, I was okay. However, when I got home, I started having feelings of self-stigma and suicidal thoughts. Despite my family being supportive by always encouraging me to adhere to my drugs, eat healthy, and most of all, they used to tell me never devalue or deprive myself rights to live. My viral load went from good to bad, all because I stopped taking my drugs most of the time. And if I did, I would take my drugs with alcohol. I later moved from Lusaka to Kalushi. There, my life became a mess in the sense that I defaulted taking my drugs and concentrated more on abusing alcohol and drugs. I lived this dangerous lifestyle with the thought that anytime I would die because I'm having HIV. Sadly, the bad choices that I made really put my life at risk. My body started swelling, my legs stopped functioning, and I was bedridden for almost a year. Not until my auntie from Ndola took me in and I was able to restart my ART. Later that same year in 2017, I was introduced to Project Yes by the in-charge at Lobuto Clinic. When I attended my mentorship training, one particular youth caught my attention. The way she looked so healthy that no one could tell that she's living with HIV. And upon seeing that, that really changed my mind to work on myself. The training really motivated and helped me understand my situation. After the 2 weeks of intense training, we had one-on-one meetings with other adolescents in preparation for their main study. Finally, we were assigned to work in our various facilities. I did not only help adolescents and young adults improve their viral load, fight off their self-stigma and fears that they had. They too helped me. During our one-on-one meetings, one of my clients shared how he fight off self-stigma, and upon listening to his story, my mind changed. Ladies and gentlemen, fellow youths, adolescents, and young adults, this is one example of the many stories that has improved and helped HIV outcomes to those young people who are struggling with the challenges that we once did. One thing is for sure, we came out of what we once felt was a helpless situation. Now we are full of hope, and we want to give that same hope to our fellow young people living with HIV. At this point in time, I'll allow my colleagues to conclude. Thank you.
Good afternoon, everyone. My name is Elijah Sinkala, a former youth peer mentor. And with regards to what my fellow colleagues have shared, these are our next steps. With the support from our stakeholders, we want to scale up Project Yes, Youth Engaging for Success, so that more youth can have access. We would like to start that scale up process in Ndola. And we want to scale up this module that we have tested and researched for 15 to 24 years olds. We also want to include children as young as 10 and youth that are learning their HIV statuses or have recently started ARTs. From Project Yes, we know that youths that parentally contracted HIV learned their HIV statuses before the ages of 12. Reaching more young people with Project Yes, they will acquire knowledge of HIV to prevent transmission through adherence and disclosure, and there will be no time for self-stigma through experience sharing in the group. It will help them to break out from the shame that they feel about themselves and understand that they are not alone. Why should you invest in this project? Because we as youth will take the lead. And there are things you should know about us. Firstly, we are game changers. Youth living with HIV often lead a life of fear and shame. We, as peer mentors, change that through Project Yes. As we helped youth see themselves positively and how taking their drug is important and helps them to be free. Youth need Project Yes more than ever if we hope to make things better for youth living with HIV. Secondly, no one is more committed than us. There is no solution for us young people without us, the young people, at the center. Investing in this project places youths at the center to address challenges affecting young people with HIV. Thirdly, we have a clear plan. With youth at the center, we are ready to begin training other adolescents and young people living with HIV to become mentors. We have training materials and monitoring and evaluation materials. That's why we would need the support of all the stakeholders to take part so that more youth out there will be able to benefit from this program. Thank you. I'll now pass it on to the healthcare provider.
Good afternoon, everyone. My names are Evelyn Munjisi Mbulo. My names are Evelyn Munjisi Mbulo, working as a nurse from RAHi Clinic at Adolescent Children's Hospital. I am one of the health care providers who worked with the adolescents and the peer mentors when the project test came in process. Like this. I am one of the healthcare providers who worked with the adolescents and peer mentors when Project Test came in board. Indeed, when Project Test came, we had challenges in most of our adolescents who had problems with adherence, stigma, psychological problems, and defaulting from RAHi clinics and clinical appointments. Many other times they responded when talking to them about the importance of adherence. They would come out like, "Sister, you don't know how it feels to be HIV positive and to be taking ARVs every day. And again, going for reviews every time and then." Little did we know that support from fellow adolescents and peer mentors could help them to achieve their goals. That's why the projectors decided to involve the adolescents and the peer mentors who had the same health condition so that they can be helped. From that time when the projectors started, we discovered that all those who were part of the project had benefited a lot and their viral loads were able to be suppressed and their stigma gone, and they could help us with the disclosure from the adolescents who had difficulties in accepting their status. So for the stakeholders, we are asking if this could be extended to other clinics, even hospitals, so that adolescents can be helped, those who are facing challenges to accept their status. Thank you.
Thank you so much for those touching stories. At this point, I'll call Dr. Miti back to the stage or to the front just to give a few remarks.
Thank you very much. Mine essentially is just to say that we are grateful to, thank you. Mine is just to say that we are grateful to the people that made this work possible, the Minister of Health, our USAID through Project SOAR, who supported this study and intervention. Also CDC as the people that have adopted this evidence at an international platform, locally generated evidence being implemented. And also the Minister of Health that has considered this Project Yes evidence to be part of the DSD models for Zambia, and we hope that it will go further. Also, our partners and collaborators in Johns Hopkins University that have been working with us even as we work around generating evidence. By and large, I would like to say thank you to the team from Arthur Davison and the many other youth that they represent but may not have been here to support or to be in this particular platform. We bring our love And also, we just want to say Zambia and the Copper Belt are essentially Zambia. Thank you.
Thank you so much, Dr. Miti.
Thank you so much. Let's give a round of applause to our panelists.
I
We
think
can
a
do better
kilo
than that.
also. Can we give them a kilo?
Yeah.
What kilo? I'm touched. I'm touched kilo, right? Okay. I'm touched kilo. Nakabili. A round of applause.
Thank you so much. So we'll just engage with our online audience. Pamela Isaac says, in line with this year's Indaba of closing the tap, though new HIV infection has used, let's be a voice to the voiceless and the drive for others. Chimwemwe Happiness Munga says, great examples. You are to the nation's friends. We have your backs. And Masako Mbua says, you're a strong woman, an example to other youths. And Esa the Elephant just says, wow, 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 wow. Indeed, we'll close the tap. Thank you so much for amazing online audience.
She's in the house. No, thank you so much for the support. So at this point, we'll be getting into our next session. These will be breakout sessions. So we have 3, I believe. We'll have a session on evolution of HIV response.
And one we'll have with civic leaders and what the role of government towards the fight. And so that session will be here. And the third one is?
This will be the role of peer educators in HIV programming. So,
You can just go through them again so that people know. Yeah.
So the first session will be, let me just go as they have been labeled. So we'll have the role of peer educators in HIV programming, and our panel will consist of young people from 5 provinces. And then our second session will be on the AYP HIV situation and response. This will be with our civic leaders. And the third session is evolution of the HIV response. And we're going to have NZP Plus, MOH, NAC possibly on the panel. So just as Zumani said, we're going to have the session for civic leaders in here and the other 2 sessions just right outside. So before we do that, Zumani, would you like to give a reminder of the services that are being offered here?
Yes. So remember, the Indaba is not just happening here. So when we get some recess, remember to access the facilities that have been provided for us by various partners outside, and also take time to visit the exhibition booths. When you just walk straight, you go straight right, and you'll find various organizations exhibiting there. And as we are getting ready to split into the breakout rooms, the youths from Northern Province said Bakopala have shined a lot. They also want to secede and become a country. So we have a poem from some young people from Northern Province. Let's give them a round of applause.
A big round of applause, guys. Whatever youth. Let's encourage them as they come to the stage. Another round of applause.
How's it? Guys, how's it? All right. We are closing the tap of new HIV infections through meaningful youth engagement, innovation, and leadership.
Drowning through the phase of HIV and AIDS, the thought of taking ARVs at an early age makes me cry in anguish and agonizing pain. Is this life I was supposed to live wasted in vain? Yes, I'm the same child who was supposed to become an engineer. Today my breath is on the peak because death is so near. I tried to smile, but I can't. I'm mentally disturbed, wishing I stayed in the way I was raised to behave. And now I take liquor and smoke dagga, thinking that this pain will go away. Is this the end? I question myself because I don't see any other way. And now the vessel of your image is now broken, shattered in pieces because the heart is already written. Is this the end? Well, goodbye, world. Goodbye, future president. Goodbye, future doctor. I guess we won't be having any other future leaders if not closing the tap of HIV infection. Well,
You made me a baby mama at 16.
Well, I ran down in the confines of my bedroom. My eyes are wet, but I can't cry. I can't give life a second try because you made me a baby mama at 16. You gave me a baby doll before I could learn how to walk. Motherhood. The game I have to learn now that I have my very own daughter. The pain of trying to figure out who's gonna take care of my own daughter while figuring out who's gonna take care of me as well. Well, I guess I have no future.
You bring me up just to put me down. I'm not just the same when you're around. You made me addicted, yearning for more. A curve so powerful, impossible to ignore. My family and friends see the difference in me, and they say I'm not the way that I used to be. I'm angry. I still lie because without you, I just can't get by. My dream seems so far. No hope for a job because you've made me feel like a lazy slob. I'm done with you. It's time for you to depart. I want a drag-free life, a fresh new start.
Capability, because where there's probability, we expect to have possibility and have an opportunity to meet our majesty. Here we go again. Just like the rest of the days, you're telling me everything will be okay. You tell me I was raised to leave a legacy of greatness, an ocean of great achieved goals that won't run dry like the Gariba Dam. But time keeps ticking. It's freaking disturbing, and so I lock myself in my room and yell silently. And when I come out in the open because of responsibility, I'm forced to keep smiling. If only you knew the kind of pain I'm facing. See, rejection is not a new word to me. Being forsaken by the people I called my own, deprived of my own kingdom, being treated like a dog in my own kingdom. I've been there before, broken into pieces that can never be put together again. So there were days when I would isolate myself from the crowd just to have some space and release my pain in tears. I would smile just for formalities, check by check. I know to you it seems small, but even if you can't fit, for a second, try to put yourself in my shoes. All my life fighting with the notion a guy should be strong. But he keeps checkmating me. Maybe happiness is not free. Just tell me how much is the fee, because I'm exhausted. Or maybe my prayers were taught that the sky is the limit, and so they do not reach the heavens for them to be heard. I just wish you had a slight idea of my pain. Truth speaking, if I wasn't a believer, I would have sold my liver. You are what you say you are. Been positive and calm for ages, hoping for better days to come and change my story one day. And here is my tongue that only has power when I say negative things, the pain it brings, the ringtones of tears it rings. Tell me how can I cope with such pain?
Just because you cannot visibly see it doesn't mean it's not there. We are a depressed generation, a mad generation. It's utter ridiculous, emotionally disastrous. I didn't want to hurt anyone, so I did what I do best. Drink till my brain couldn't take it anymore. Smoke till my hands cramps up. I thought I was dreaming my life in slow motion, where no one could stop me. Little did I know, I did myself more harm. In my dreams, I loudly scream. A bad scheme, a ridiculous theme tries to take down my esteem. I've been running so fast, and I need to slow down before my whole world comes crashing down. I've already hit the ground, but I got back up. I'm ready to go another round. Found out today is a miracle I'm here. Everything I couldn't see seems so clear. I couldn't have asked for better family and friends. Life just sometimes silly fair. This is a cry of the youth. Keeping up appearances, broke no lunkumbwa. Work, hustle is the way.
I believe.
I believe we can cause it.
Okay, a round of applause again. Thank you so much. Okay, so at this point, we are going to, as I mentioned earlier, we'll get to our breakout sessions. So please, earlier I had mentioned 3 sessions, but I omitted one, so there's a bit of a change. We're going to have another a session that is addressing infections in higher learning institutions, and the panel will consist of university students. And okay, so for civic leaders, I did mention that we're going to remain here, so please remain seated. Everyone who's interested in just getting information around the adolescents, young people HIV situation and response with civic leaders, please remain here. And for those that would want to get a lot more information around addressing infections in higher learning institutions, we have Annie. Annie, are you leading the team for higher learning institutions? Peer educators. Okay, so we have Annie who's going to lead everyone who's interested in just getting information around the role of peer educators in HIV programming. Please follow Annie. Annie, maybe you can be there so that when we say all of us go to our breakout sessions, peer educators, everyone interested in that, please follow Annie. Okay, so after this, Annie is going to speak to the panelists for the peer educators. And then for addressing infections in higher learning institutions, all students, please follow Iga, the gentleman in the jacket there waving his hand. All individuals from higher learning institutions, please follow him. We can start moving actually. So higher learning institutions, please follow Iga. Annie will speak to the panelists for the peer educators.
Okay, for the peer educators, can I have Elijah Sinkala from Copper Belt? And then can I also have Joyce Manda from Eastern Province? And then Lusaka, can I have Harrison? Zimbabwe, can I have Talent? They should follow me outside. All peer educators, if you know you're a peer educator where you're coming from, please follow me.
Thank you so much, Annie. So for the Okay, so the adolescent and young people HIV situation and response, this will be made with evolution of the HIV response. So remaining back in here, we're going to have civic leaders and we'll have our Parker from Lusaka province. And we're going to have Madame Estella from the Network of Zambian People Living with HIV, who are going to be on the panelists for discussions. So just to repeat, we have 3 sessions. The first one is the role of peer educators in HIV programming. And these are the young people from 5 provinces. Please follow Annie. She was giving out names just here. And then the second session we have addressing infections in higher learning institutions. Please follow Iga, the gentleman who was wearing a jacket by the door. And then in here, we're going to have the AYP HIV situation and response with our civic leaders. Okay, so I believe people are still moving, so we just want everyone to settle down and then we'll call upon our moderators and our panelists to the front. And our session should take 45 minutes. Please be back to the room in 45 minutes. Moderators, please take note of time. And for those that have remained or who are going to remain with us in this specific room, I see we have some who are way behind. If you could kindly just come to the front so that we just occupy the spaces in the front. For all those that are sitting way in the back, please come forward so that we can begin.
Thank you so much, Natasha. We will be beginning our session shortly. So for all the colleagues that are seated in the back, please just move closer so that we have an intimate discussion. Please just move close, close, close so that we have a very fruitful conversation. Those that are leaving, please leave quickly so that we can begin our session. Those that are staying back for this session, please just move close and close and close. Are we good to go? Okay, great. So thank you very much, Natasha. I will begin by calling upon the first panelist, His Worship, the Mayor of Mansa District in Luapula Province. Thank you very much, sir, for joining us. You may go to the high table. I will then call upon the councillor from Chainda. Sir, we are privileged to have you in our midst. You may go to the high table. Thank you so much. I will then call upon the provincial AIDS coordinator for Lusaka province. Ma'am, please, we are privileged to have you. You can go to the front. Yes. And then I also call upon Ma'am Estella Mamboy from NZP Plus. She is the monitoring and evaluation manager. We are privileged to have you as well. So this is how we'll proceed for our session. I will begin by asking pre-planned questions to the panelists, and then after they respond to all the questions, I will open it up for a quick Q&A, and then when our other colleagues come back, we'll have a report back session. So I will be moderating this conversation, and my name is Lubombe Jeremiah Mulanda, one of the co-chairs for this lovely Indaba. So first things first, I know introductions are very, very important. So I will begin with the mayor. Sir, please just kindly tell us your names and where you are coming from. Thank you.
Thank you so much. Would you like me to be upstanding?
Would you like the mayor to be upstanding? Okay, brilliant.
I don't want people to go back home and say, Mayor Ali Ifinya. He acts as if he's not a youth. But thank you so much, Director of Ceremony, or the moderator. My name is Njiko Msuku, Mayor of Mansa, coming from the beautiful province, which is Luapula. I'm privileged to be here, and I'd like to say thank you to ZYP for extending the invitation to me. I'm representing the youths, the civic leaders from the local government. Others have seen me. I'll give a brief background of my leadership. I started my leadership at St. Clement Secondary School, where I served as preventive maintenance captain in 2011. 2013, I went to the Copperbelt University, where I pursued a Bachelor of Science in Urban and Regional Planning. In 2017, I was privileged to be the Kobusu president. That's the Copperbelt University Students' Union president. In 2019, after completing my school, I went back home. I was privileged to be elected as councillor for Chiliapa Ward. In 2021, I was privileged, to lead the good people of Mansa as mayor. And I'm grateful for the support because majority of the voters were the youths, and they definitely played their roles. And I'm grateful to the youths. Thank you so, so much. Today, I would like us to be very open and have a discussion that will be productive, a discussion that will help us be informed and make well-informed decisions, a discussion that will help us formulate policy, a discussion that will drive the agenda of the young people in Zambia. Thank you so much.
Thank you so much, His Worship. Please introduce yourself.
Your Worship, the Mayor, our mother seated here in front, the organizers, the Zambian Youth Platform, distinguished ladies and gentlemen. My name is Nsama Patrick Mpundu. I currently am the area councillor for Chainda Ward 33. I'm a card-carrying member of the United Party for National Development, also an executive member of the National Youth Wing, as well as the current speaker of the third SADC Youth Parliament. It's an honor and privilege to be before you today. I consider this most cherished opportunity to speak before all of you, to have a discussion, to learn from you, and also share parts of my journey, parts of our stories, and see how we can finally, close in that tap on, the new HIV infections. My leadership journey did not begin as far back as 2011, because I don't think I was old enough for anything at the time. My leadership journey really began while still in high school, of course, but began to really mature when I was at the University of Lusaka. In my first year of study at the University of Lusaka, I was privileged to be elected Debate Society president in the year 2018. At the time, I was about 18 years old. Don't start calculating my age. And then in 2019, we had student union elections, and I was elected student union president at the age of 19. Thereafter, I served for about 1 year. And in the year 2020, I made a decisive decision to join national politics and be a part of our story in 2021. And through the grace and mercy of our Lord Jesus Christ, I joined the UPND and eventually was elected area councillor for Chainda. And I've been serving faithfully in that role for about 2 years now. 2 years in August, Your Worship. It's been that long already. And just last month in May, I got the news that I've been appointed as the Speaker of the SADC Youth Parliament. And I think it's something to be very excited about for all of us, something that we need to do. And I think my call, even before we get into our discussions, is it's a lonely road for His Worship and myself. We need more of you young people to join us in the struggle, to join us at the decision-making tables, because one thing I can assure you is that Zambian people are the most hospitable people. Africans are the most hospitable people, and they will welcome you with open arms as long as you are serious, consistent, and you know what you're doing. Thank you.
Thank you so much. Mom, you can introduce yourself.
Yeah, good afternoon. His Worship, the Mayor of Mansa, the area councillor for Chainda, Ward 33. Our visitors from Zimbabwe, from Botswana, from Kenya, and all the adolescents present here, and also the government officials and those coming from the CSOs and from the faith-based organization. My name is Eunice Massey. I'm the Provincial HIV AIDS Coordination Advisor for Lusaka Province. And I know that His Worship the Mayor has given us his CV. I'm just going to talk a little bit about my journey in the HIV. And so I started this journey in 2004, and we were the first UNVs, the United Nations volunteers, to work in Zambia, volunteering on the issues of HIV and AIDS. And at that time, I was in Chipata. After that, we devolved. We became what they call DACAs, and that is the District HIV Coordination Advisors. And I was the first advisor for Chipata District in Eastern Province. I also moved to Lusaka somewhere around 2009, and I was the DACA for Kafue. And then I have progressed to being a provincial HIV/AIDS coordinating advisor, and that was in about 2012. So issues to do with HIV and AIDS have been around. I've seen when people were paying for treatment, and when people started accessing free ARVs. And so I've seen so much progress. And I think we give credit to the Zambian government for making ARVs free. I think we have seen from the examples and the testimonies, and we have also heard from the presentations from those that presented in the morning. And so I just want to take the opportunity and thank you that you have given me a chance to stand here and be with our civic leaders and of course NZP Plus. Thank you so much.
Thank you so much for that introduction. Mama Stella, please introduce yourself.
Good afternoon. Good afternoon. Machoma Bueno. Okay, thank you so much. So, Your Worship, the Mayor for Mansa, I just want to say thank you for being part of this meeting. The area councillor for Chainda, we are also privileged to be part of the panel with you. And also Mrs. Mercy, I know we've been part of the team for quite a long time. So my name is Estella Mbewe. And coming from the network of Zambian people living with HIV and AIDS. So in short, it's called NZP Plus. So of course, when people talk about their CVs, of course, for me, I think the greatest CV is my life. And that's the way I look at it. The passion, the contribution towards HIV work is what culminates into my CV. Of course, I started being part of CARA. You remember the time when HIV was starting. I was part of a volunteer council at CARA. Then from there, I moved to NZP Plus. From NZP Plus, there was a project that was called the Human Rights Referral Center, which was looking at violations. I moved to YWCA. So I was part of the YWCA team for 3 years. Then I moved back to NZP Plus. So I've been part of NZP Plus since 2008, and I've moved from ranks, being a program officer, being now an M&D manager. So for now, I think I've been part of the team for HIV, and for me, it's the passion and the drive that we can be able to make. Thank you.
Thank you so much for those introductions. The beauty about these introductions is that they have answered some of my questions already, which is very lovely. I will begin with His Worship. You are coming from a local government system, and in the political structure of local government, you are the head of that structure. In your own understanding, what is the role of local government in the prevention of HIV?
Thank you so much. Government is in the process of decentralizing policies, and we have made progress. Decentralization is taking authority to the local level in a simpler term. So what's currently happening is that all DACAs, who they call the district AIDS coordinators, are now sitting with the local authorities. So these people are tasked with the responsibility to work hand in hand with the Ministry of Health in HIV prevention. And I'm happy to announce that as a local authority back in Mansa, we are doing our level best in addressing problems to do with HIV and AIDS. One of the things that the youths must know is that every project under CDF or any construction project that is done at local level, there's a component of HIV and AIDS of not more than 5%. It depends with the kind of project that is being done. So there's a component that is always allocated towards the prevention of HIV and AIDS. Now, most of us do not know about it. So it becomes a challenge for people to hold our leaders accountable. In this case, we are now investing in education as a local authority, because the Ministry of Education now, the Ministry of Education sits under the local authority because of the devolution. Now, in this case, we are talking about people who are well informed, people who have the access to the right information. So if people are not educated, it becomes difficult for us to effectively communicate. And that's the reason why the free education policy has really helped us transform lives, because at least people have access to education. Going back to Mansa, our infection levels of people, let me say people who have been put on ART are closely around 17,000, and on average every 3 months, we have at least 500 people who are put on ART. Now, Mansa, the way it's positioned, it's a border town. I can say it's a border town where people coming from the Copper Belt have to pass through into Mansa. Thereafter, they proceed to Tanzania through the Luingu Road. So as a local authority, some of the things that we're doing is that we have a responsibility of distributing condoms year in, year out. And also the other thing that we're doing is enforcing laws, because majority of the things that we've spotted as a local authority, it's the underage drinking and also alcohol abuse. So it has now become a hotspot area where truck drivers are taking advantage of the young ones. So as a local authority, there's a lot that we're doing, and it's up to us, the young ones, to partner with the leaders who have the political will to drive the agenda of the young ones.
Beautiful. I like what you've mentioned, your worship. Did you guys know that there's a 5% allocation in the budget at local government level just dedicated to HIV prevention? Did we know that?
Yes, from capital projects.
From did we know that? I personally didn't know that. Now that's very interesting to note. I'll come to you, Patrick. What available resources exist at local government level in the prevention of HIV? And are those funds available for use as we aim to close the tap on new HIV infections?
Thank you so very much for that question, Jeremiah. I think one thing that's very, very important to know, ladies and gentlemen, is what drives demand, or what drives supply is the demand. When it comes to government resources, the particular supply or allocation of any of these resources is backed by the demand for that particular thing. So it's meetings, conferences, and indabas such as this which really spark up the demand for us to do more in terms of prevention of HIV/AIDS, in terms of us to do more in closing off all new infections. So when we begin to speak out as young people and we begin to sensitize governments, local authorities, and any level of leadership, we are then building up something called demand. And then we see that when we propel all of this, by the time we're getting to the 2024 budget, 2025 budget, we'll see even more allocations other than the 5%. We want to see specific allocations from the Ministry of Health budget, from the budget of the Republic of Zambia, specifically going to tackling this, because we're talking about a big goal. We're talking about having no new infections by 2030. It sounds very difficult, but it's not entirely impossible. The question is, us as leaders, we are responsive to the demands of our people. How much are we speaking about this? Is this going to be an annual topic? We talk about it once a year when we meet here, or is this something that we're going to voice out in every way that we can? Because remember that we're saying that young people are not the leaders of tomorrow, that the leaders of today. Now, leadership does not begin when you're in an elected position, but leadership actually begins when you start to make use of what you have, when you start to demand for your rights, when you start to demand for what you believe should be done in your particular community and what you believe should be done in your nation. So I think at the end of the day, we do have resources available. We do have the Constituency Development Fund. We've seen consistently from 2022 to 2023, there's been consistent increases. It was 1.6 in the beginning. All of us have heard about that. It was 25.7 in 2022, and it's now 28.3 as of 2023. That's a lot of money. But the way it might look like it's a lot of money, there's also a lot of other demands. There's demands in the education sector, infrastructure development. But what is going to make that money and even other budgetary allocations from government and even from donors and the international community be used for the prevention of HIV and AIDS is the commitments and resolutions we make in this meeting. So I don't know how many young people in this room are ready to make commitments and resolutions, demands to our governments, to international partners that enough is enough. We're tired of the rhetoric, we're tired of the talk. We want to now see action and resources being placed in the prevention of HIV and AIDS. Thank you.
Beautiful, great stuff. I like what you have mentioned, most especially when it comes to supply. Supply is always backed by demand. So if there's no demand, ladies and gentlemen, there will be no supply. And also the fact that this is not a conversation to have once a year. And I think even us from the Zambian Youth Platform, we have taken that to heart. This is a conversation to normalize. It shouldn't be that one thing that we look forward to, but rather something that we do more often. Now, Your Worship, I'll come to you again. The councillor just touched a bit on the hot issue of CDF, and I know that my colleagues in the audience are also itching to ask this question. Are these funds available for investment? I'll call it an investment because I believe health is an investment. Are these funds available to be invested in the prevention or treatment of HIV? These community constituency development funds.
Thank you so much. I think I can say yes. I can also say no. Reason being, if you look at prevention of HIV and AIDS, it also matters with where you place your activity. Yes. So if it is a project that will benefit like the entire community, then it can be classified under community projects. But again, if it's something to do with investments where you need to generate revenue out of it or profit, then to be classified under empowerment. So as government, the policy or the legal framework around constituency development fund, like what Madam Eunice said, we are trying by all means to have a component of prevention in every project. That's a capital project. So CDF is there to address the problems of the people. And something that we're also focusing on. You see, when there's poverty, you find that when there's poverty, there's also a high level of infections. So something that CDF is trying to address is poverty. And that's the reason why we are encouraging youth to, to be innovative and be like the theme for this year, where we're talking about leadership engagement and innovation. So it's something that we keep encouraging our youth to do. So out of their innovations, they can apply for something that will address the problems to do with HIV and AIDS.
I like that so much. The yes or no makes so much sense because I also believe that these projects, especially at local government level, need to be designed in a specific manner if they are going to attract any resource from government. I'll come to you, Mrs. Massey. You have been working in this field for a very long time. Attention has shifted towards prevention rather than treatment. So why do you think it's important to begin to shift our attention from investing more in prevention rather than treatment?
So there's a saying that prevention is better than cure. And when you look at even the budget, so it's so much on treatment. But we are saying if we prevent those infections, those new infections, then we don't have to spend so much money on treatment because there will be very few people crossing over to being infected for them to be on a lifelong treatment. So it's very important to make sure that you are taking care of yourselves and making sure that you are preventing yourselves from getting infected. And when we talk about prevention, we have what we call combination prevention, because most people will say, oh, if I abstain, then I will not use the other methods. So there are some people who are able to abstain, but there are some people who are not able to abstain. So what do we do with those people or those young people or adolescents that are not able to abstain? So for those that are not able to abstain, we are saying they need to use other preventive measures such as condoms, proper use of consistent and correct use of condoms. So there are some of those who say we are promoting adolescents or young people to be promiscuous. But we are saying it's very important because we have different type of people who want to use different types of prevention. And for those that are maybe using the condoms, we are saying we also have priority groups like, of course, in the morning, I think there was a presentation and we were saying the key populations. We are saying let's use all the line of prevention that are available to us. There's VMMC, there, and I know I've heard that, no, I was circumcised, but I now have converted. The problem is that when we are circumcised, it doesn't mean that it's 100%. We have heard that the protection is 60%. So what then do you need to use? It means that you need to combine the prevention. And so, and also we have PrEP. And for PrEP, it's not for everyone because some people that think that everyone is eligible. No, it's for those that are high risk, that are at substantial risk of acquiring HIV. So it's not for everyone. So prevention is far much cheaper than cure.
I like that so much. And the emphasis being on prevention being much cheaper than treatment and prevention being the key. Because if we are able to prevent, there's no need to treat. I'll come to you, Madam Estella, but before I even come to you, the people in the audience, you can start preparing your questions because I'll be opening it up shortly for a Q&A. So please just write down your questions so that you don't forget. But I'll come to you, Madam Estella. This year's theme for the RAHi is closing the tap on new HIV infections through meaningful youth engagement, leadership, and innovation. What is the role of the young people in ensuring that we prevent HIV in particular?
Thank you so much, moderator. I think youths have a key role in terms of making sure that we participate in closing the gap. One, if I'm a youth, what responsibility am I taking in order to ensure that I'm not getting infected? And if I'm infected, what responsibility am I taking to be able to make sure that I'm not infecting another person? Am I on treatment? Am I adhering to my treatment? So this is the responsibility that is there. And it's not just for one person, it's making sure that we are all involved in it. And at the end of the day, we look at even the different interventions. Youths have a key role. You remember the time when we started with HIV, there was a lot of despair. And with interventions that were coming in, I think it was like one size fits all. But now we are looking at ending AIDS by 2030. We need to make sure that the interventions that we are looking at, they are population-based, they are specific. So it's a challenge to us as youths. What works for you? You remember in the olden days, we felt because there was no treatment and support groups were very key. But now, if we are going to look at support groups that are going to help a person living with HIV, how then should our support group look like? So in closing the gap, we need to ensure that are we providing adequate information? You remember before, because by then there was a lot of stigma, discrimination, we had a lot of community interventions. And because now there's reduced funding and we are not seeing a lot more of community interventions, we would want to see more from the youths because now we've gone digital. We are no longer basing where we go in the community, doing the drama. Are we able to make use of the platforms that are available to be able to make sure that our youths are aware? because now you look at the issues that are coming now. Before, we used to depend on CD4. And once your CD4 is down, that's when one is put on treatment. But now it's test and treat. So if you are talking about test and treat, do our youths have information? Because now we need to deal with issues of, am I able to accept my status? How am I going to deal with issues of relationships? So there are all these things that are surrounding youths that we really need to do. And then the other thing that we also need to do is, are we being engaged? And for me, it's meaningful engagement. Before, it was tokenistic. If Estella, I come here, I give my personal experience, then at the end of the day, I'm given 100 kwacha, it ends there. But now it's different. We always talk about nothing about me without involving me. So it's now the youth. Whatever interventions the government is going to say, you need to say, this is what we want. Because then we are going to close the gap, and we'll be able to say that whatever interventions are going to come through, they'll be able to work for us, and we'll be able to make sure that the gap is being closed.
Beautiful. I like that so much. Thank you. Thank you so much. To our colleagues who have joined us on Facebook, you can send us your questions, your comments, or your contribution. We are live on the Zambian Youth Platform Facebook page, and I will ask the questions to our panelists. Thank you so much to all who have joined us. Thank you so much for those questions. I will open up for a quick Q&A so that the people in the audience can also ask the questions. Do we have questions from the audience? I can see 1, 2. I will start with the gentleman right here. So please just say your names and where you're coming from and your question. Just one question.
My name is Micho Zulu, coming from Njonjolo, Western Province. I have a question to your worship, the mayor. We heard of the 5%, which is supposed to be channeled to the HIV program. So those of you that are in the DATIF or the DACA can agree with me the struggles we find whilst making preparations for World AIDS Day and other HIV and AIDS related program. Yet we have this 5%. So my question is, who is responsible? Who is supposed to do the checks and balances? Is that money only meant for the council? And when we're making those programs, it is not supposed to be channeled to that. Because truly in our districts, if we have that 5% and we have a lot of construction happening, we are not supposed to be begging the way we are begging in these committees of DATIF. So I seek your clarification, your worship. Thank you.
Thank you so much for that question. I will ask for another question, and I love the hands, but I will give my colleague here.
My name is Mavuto Sakala. I have a question to your worship, the mayor. Just like he said, my question is about the 5% that you've mentioned, that the CDF is 5% for HIV programs. Now, for us, the deaf, you know, we still face a lot of challenges to look for example, maybe a deaf person, if a deaf person is aware that the CDF budget 5%, you find that they can be included, but you find that deaf people are not included, for example, the WDC, or they're not even aware that there are these opportunities that they can apply, or even the other empowerment of opportunities under CDA, a project, HIV related project. You find that they are not aware. So now my question is, when you are making announcements or you are raising awareness in the community, you only focus on hearing people, but not the deaf are not included. So, and then there's a saying that there's a special percentage for special people, you know, a category, but that is not happening. So why is that? So my point is that deaf people were being discriminated, were being left out, because when you are saying, according to the CDF laws, there is 5% reserved for HIV. Now, deaf people are not included in the ward development committees or in CDF committees. They are not involved anywhere, especially when it comes to issues of HIV or GBV and other challenges. So they are not involved, they don't know, they're not aware, they cannot even participate. But the other people are able to participate because they have the information. So where is the political will?
Thank you so much for that question. I will ask for one more question and then we can open it up to the panel. I can see. Okay, yeah.
Good afternoon, everyone. My name's Ziambo Mundani. So my question goes to the civic leaders. As civic leaders and lawmakers, what interventions have you put in place for with regards to SRHR information dissemination? I've seen in instances, mission schools, they do not allow peer educators or other NGOs to go there and talk about sexual reproductive health and rights services, or to provide services there, because they feel you are promoting promiscuous amongst the students or pupils in school. So as civic leaders, what interventions have you put in place to talk to those people and allow NGOs or other stakeholders to take such information to those students? Because as peers, pupils, if they don't get the right information, they will get it from their peers, which might be wrong information. So I want to find out the intervention you've put in place or you have plans.
Thank you so much. Your worship and the panel, would you like to respond to those questions? Then I can open it up to another round of questions.
Thank you so much, moderator. I'll begin by responding to my colleague who spoke about the DAIF. Just to clarify, it's 5% from the capital projects, and then under CDF, I'll speak about empowerment. So
Sorry, your worship, maybe just to clarify, what are capital projects? I think that is
Okay.
where the problem is. So it's 5% on capital projects. So your worship, what are capital projects?
Okay, so capital projects, these are projects that are undertaken in a particular area that involve huge sums of money. Like it has to be a big project, like a construction of maybe a road, construction of a big bridge, not only crossing point. It has to be a big project, a big project. So if you find there's a construction happening around, there should be a component of a big capital project. There must be a component of HIV prevention. Yes, and then talking about empowerment, the motive behind empowerment is that it should empower someone. Of course, prevention is some form of empowerment, but us, we are looking at profit. So prevention, in our efforts in trying to bring in the prevention aspect, we are not gaining out revenue. So empowerment is there to empower you economically to have a source of income as an individual. So I'll refer you back to Mansa, where if we are empowering 100 cooperatives, 10 must be persons with disabilities. And that we have evidence in Mansa district as proof. I want to also mention that the legal framework that governs CDF does not select people. It's open. So it depends also with the place where you stay in. Because us as leaders, we need to have the political will to govern people without choosing the kind of abilities. So in this case, persons with disabilities are always included in decision making. In the Ward Development Committee, the structure of the Ward Development Committee, there should be a representative from the persons with disability or any organization that represents their interest. So even at CDF, Constituency Development Fund Committee, it depends with the formulation in that particular area. But for us as Mansa, we have engaged persons with disabilities, and I'm happy to announce that we are working hand in hand with persons with disabilities. I do not want to specify about the deaf, but The assurance that we have is that so long as we're engaged and there is need, we always respond. And lastly, my dear colleague spoke about who are we going to hold accountable for the 5%. You can hold accountable the town clerk, because the town clerk is the administrator of any municipal council. Ours is just to ensure that whatever policy that is formulated is implemented. So in terms of funds, the town clerk's office is readily available, is always open. You can always engage the town clerk, because these are the people that work hand in hand with the DACAs. Ours is to ensure that whatever decision is made at the council, it's well implemented. And then I'll also allow my colleague to respond to the interventions in sexual reproductive health, and then also Madam Eunice to also respond and add on to the capital component. Thank you.
Thank you so very much. So I'll be responding to the question that was asked by a gentleman querying on the issue of, certain organizations, civil society, non-governmental, having attempts to take sexual reproductive health education to schools and them facing a bit of resistance and challenges. Now, you must remember that Zambia is a country with an identity. One of those identities that we are African, the other identity is that we're a Christian nation, as so declared by the late former president, Dr. Frederick Jacob Titus Chiluba. And what that simply we've already decided, and it's been there for quite a number of years, that sexual reproductive health is involved. But unfortunately, when you do see resistance like that, it's also a twofold issue. There's now the issue of, okay, are some institutions being a little bit rigid? But also there's a part of what exactly are you trying to bring to the schools? Because we're trying to teach prevention, and I think we agree with that, but we're not trying to promote a sexual culture. We're also not trying to promote any LGBT agenda, because that's not part of our identity. So I think organizations, if they want to have easier times accessing our communities and being able to give this information to our communities, they must also clearly state their agendas so that we fix a bridge. Because at the end of the day, I believe that abstinence is liche. And I think abstinence is the most effective way of really dealing with this. Look, ladies and gentlemen, if we're believers, we must understand that our bodies are temples of the living God and we should keep them as such. And this is what we should be teaching to our kids. Obviously, now as a child grows, there are sexual desires and there's issues of preventive maintenance in terms of condomization and all sorts of things that they can take to protect themselves. But I think, in my personal opinion, and speaking on behalf of the people of China, condomization should be the last resort. If people can stick to one sexual partner and wait until marriage, then we'll be helping so many of us. But I think in terms of information being given to the kids, we already have that. Even as young as grade 3 and grade 4, they are being taught about their sexuality and how things go about in terms of that. Thank you.
Beautiful. Before Mrs.
Yes. I just wanted to add on to what my colleague has said. This is an interactive forum, and we wouldn't like to just respond to questions. We'd also like to learn. If there are any interventions that my dear colleague who asked the question of what interventions were putting in to allow NGOs to enter into schools. The first thing that I would like to also learn from my colleague is what kind of challenges have you faced? And then what do you propose that as civic leaders we can do within our means? That's the question I'm posing to my colleague who asked us. Thank you.
Thank you so much. Question to question. I hope you got that. But even before we go to your response and another set of questions, there's a question from Facebook. This one goes to the Parker. So it says, kindly clarify on the age of consent to be redefined to the age of access. The 13 to 15 who requires a parent to have access to health services are the most at risk. What is your ministry doing to separate the age of consent to the age of access?
First, maybe before I answer the age of consent, I just want to speak to the issue to do with the 5% and the capital project, just to add to what the mayor was talking about. So there's a process to the 5%. It starts with the environmental impact assessment. And during the environmental impact assessment, I think the community is invited to take part and talk about what are the issues that impact them, especially in relation to HIV and AIDS. And from there, then they go to the council when now the contractor is supposed to start work. And they work with the planning unit at the council. And so it is at that time when I know that most of you participate in the district AIDS committees, and it is at that time where you have these projects coming in, and you need to look at the budgets and how much they are offering as a 5%. And it is at that level where the DAC with the district planning office actually now will work with the contractor to see and shortlist who they are going to give to provide the services. And I think you have seen in your communities that when there's a big project that comes to the community, a lot of things happen. You know, people leave their families, they come to where the project is, meaning that they will now start going out with those people that are living in the surrounding area. I'll give you an example. The road construction, we had a project in Eastern Province where they were constructing a road, and it was actually given to our colleagues, the Chinese. So when we went to inspect, we found that there was a young girl who had twins. So what is that what does that mean? It's evidence. if that's very good. It's development, right? Development brings its own challenges. And so we understand that there was evidence that something happened. So, you know, we know that where there's a child born, it's evidence of not having used the protection. And that means that that person is at risk. And so how many people are at risk in that community? Many of them. And so that's why us as young people, it's important that we pay attention to what development is coming in our area and how you participate. You have many forums. You have the district AIDS committee. You have at community level, we have what we call the ward development committees. And so it's your time. It's your time to participate and make sure that you know what's going on in your community. And so it's not as easy as just a 5%, and we as a committee of DAC, we want it. You have to follow the processes. There are guidelines to that effect. National AIDS Council has developed a guideline on how to go about the processes of actually getting the 5%.
Yeah.
So you have, and the National AIDS Council is the first to decentralize. And we know that now the DACAs are in the councils, and they are the ones coordinating the HIV programs. So we have made a lot of headway. So it is your time to find out what the DACA and the Ward Development Committee and the district planner are doing in the issues to do with the capital projects.
Thank you so much, Mrs. Mercy.
Yes.
Because of time, I can notice that our colleagues are coming back. I would just ask that His Worship, so there's a holistic approach in this room. So she has decided to help her colleague in her colleague in answering the question. So I'll just give her a quick opportunity to just answer, respond to your question. Thank you.
Okay, there's somebody.
Okay, thank you very much. So maybe the we can be helped by the worship and the civil society in ensuring that there's harmony in preaching to the schools so that they are aware that we want to take up this step. Of course, we can't be going in schools preaching about condomizing because there are different people in there and different age bands. So of course, as we are giving IEC, we can look at giving tailored information. This is why you just don't focus on condomizing. Instead, you give information generally where everyone can benefit and can see the use and the need of preventing themselves from HIV. Thank you.
Thank you so much. Now, I'm in the mood of giving gifts and blessing someone. So, in the spirit of giving gifts, because sharing is caring, I will ask a question to the audience, and I have a couple of stuff here to give away. I know people like T-shirts, others would like a pen, and others would like a cup. What is the role of local government in HIV prevention? Quick one. First come, first serve. First come, first serve. What is the role of local government in HIV prevention? That was the first hand. You get it wrong, we don't give you anything.
Is the law of the local government. Otherwise, my name is Inoki Karimbwe from Senanga. So I was rushing for the gift without even letting people know who they are speaking to. So the role of the local government in addressing issues to do with the HIV is to create the enabling environment and also providing the resources to the vibing or indeed very viable projects that are going to address the issues to do with the HIV in the communities where these local authorities are coming from.
Thank you so much. What gift should we give him? The T-shirt, the cup, or the pen? The pen. What do you want, my brother? Thank you so much. You are very lucky. What is the percentage that should be given to HIV prevention in capital projects? What was that answer? What was that answer? Okay, there's a hand here. What is the percentage?
5%.
Excellent. What do you want? A T-shirt? I don't have a T-shirt. I have a pen and a cup. Thank you so much. The last question. This one is a very special gift. What is the name of the mayor of Mansa district? What is the name of the mayor of Mansa district? Once you get that one correct, you stand a chance, a photo with the mayor, his worship, and many more prizes to come that I will be giving. What is the name of the mayor of Mansa district? What is the name? Manja, I want to see hands, not the ones I know. You don't know him? I put back the gifts. You don't know him. Okay, no, there's a hand there. The hand looks pretty new. Sorry. I will come here. Your worship, please see the person you take a picture with. What's his name?
Njiko Msuku.
Say that a bit louder.
Njeko Msuku.
Yeah. Your worship, we have found a lucky winner. What's your name?
Kimberly Falanga.
Kimberly will take a picture with his worship, the mayor of Mansa district. Oh, he has another name. What is the other name?
Mosoko.
Yeah. No, you also deserve a little something. The last question. What is one of our hashtags for this event? What is one of our hashtags for this event? I have a nice paper bag to give away. What is one of our hashtags? I want new hands, especially those in the backbenchers now are here. What is okay. Before you answer, tell us your name and where you're coming from.
My name is Mwimba Namenga from Levi Mwanawasa Medical University.
So what is one of the hashtags for this event?
Hashtag closing the tap.
Exactly. Thank you so much. I have another question, probably the last one. What is Mrs. Massey's position? What is Mrs. Massey's position? You don't even know who Mrs. Massey is. Yay, mwe. What is Mrs. Mercy's position? What is Mrs. Mercy's position? I want to see hands. Okay. Okay, let me come here. She's been thirsting for a response.
She's a Parker.
What does Parker stand for?
I just don't know the. No, she's a person advisor.
So she's given a half answer. Who's going to finish for her? She started Parker. What does Parker mean? Okay, yeah, no, you've been yes.
PACA means the Provincial HIV/AIDS Coordinating Advisor.
Wow, wow. Yeah, Mrs. Mercy has confirmed. So now I don't know how they will share the bag. You probably need to relocate. Yes. He's a gentleman. He said the lady can have the bag. Thank you so much for that.
You can actually give them both. Both should benefit.
Oh, both should benefit.
Yes.
I know his worship has said both should benefit. The gentleman deserves a bag.
Yes.
The last question. The last question is very important. So as the Zambian Youth Platform, we have a show. Now, this is a 2-in-1 question. Whoever gets this question correct will get a bag. Do we have a cape there, Natasha? Do we have a cape? So whoever gets this question correct will get a bag, a pen, a cup, whatever that thing is called, and 100 kwacha worth of talk time. So now listen to the question and pay attention. So this question is actually a 3-in-1. Now I've changed my mind. 3-in-1 question. The first question is, what is the name of the show that is hosted every Friday on the Zambian Youth Platform page? What is the name of the show that is hosted every Friday on the Zambian Youth Platform page? That's the first question. 9. The second question, are we together? The second question is, who rather was the first host this year of that particular show? That's the second question. The third question is, what was the last recent topic that was discussed? So 3 questions. Now one person needs to answer these 3 questions. So you get a bag, you get a whistle, you get a pen, you get a cap, and 100 kwacha worth talk time of your choice. Who wants to attempt that? I want new hands, not you people who've come on the show before. Where's the hand? Oh, there's, okay. No, let's try, let's start from here. Okay, so just tell us your name, sir, and where you're coming from, and then you respond.
My name is Meshek Piri from Unilas. The show that comes every Friday is called Real Talk. The first host is Jeremiah himself.
What was the last recent show?
Isn't it menstrual hygiene something?
Okay, so Meshek has answered 2 of the questions. Who wants to help Meshek so that they share the money? Who wants to answer the rest of the question? Okay, I will give an opportunity here.
The show is called Real Talk, and the first person, I think it's Jeremiah, and the last topic they discussed was on mental health.
She has answered the question. What is remaining? Oh, so the topic was challenges. So who are we going to give it to? I can ask the high table to be seated now. Thank you so much for the panel discussion. We can give them a round of applause.
Thank you so much.
So who are we giving the prize to? All of them? They will share. Uria 10 kwacha bada 8. O kuria muri bakopa beauty mwete? No wonder. Okay, so what we are going to do is we will leave it up to Meshek and Walusungu to share the prizes. Please see me immediately. I leave the stage so that I give you your prizes. Thank you so much to the panel discussion. I will be handing it back to our co-chairs for the day so that we can begin to end our conversation. Natasha and Zumani, It's back to you. Thank you. Tamanto tereko ine. Ngeyo behavior. Awe mpereni kiro. Mpereni kiro nga nifyo nshareke okulanda.
Parliament kilo.
Which kilo do you want to give me? No. I want the Kopala kilo. There's that dance that they were doing. That's the kilo I want. Do you know how to do it? Yes. Can we energize a bit, please? Let's be upstanding. Where are the Kopala people who led us into that dance? Nabaya, you can do it. Who wants to lead that dance for us? Hurry up, we do an energizer, please. Let's be upstanding. Before we continue, let's be upstanding. At title ya wimbo Shani. At Shani. At Baba. Who said at Baba? Huh?
One of the guys is from Kenya said he would like to allow the music just a few seconds from Kenya.
Okay, so while we are getting ready for the energizer, can we have the three chairpersons that were leading the sessions to come up front for a quick debrief of about 5 minutes each before we call it 2 minutes each before we call it a day for today?
Hello. So we are doing an energizing. Are we together? Not this one. So the idea is we are doing an energizer, and because we are all young people in this room, we'll all be dancing. Feel free to do a freestyle. Are we together? Let's go.
Putting the mayor and the councillor. Stop on the mayor! The people of Shaima and Mansa, where would you take it?
more than an energizer. It was more than an energizer. Thank you so much. You're a lovely
Thank you so much. You are such a lovely audience, and we can tell that the people of Mansa and Chahinda Ward 33 are well represented. So we have about 8 minutes before we wrap up. So I'm kindly asking if we can all be seated and be quiet and for us to have one meeting. Thank you so much.
Okay, thank you so much. My name is Iga Kapambwe, and I was moderating, co-moderating with Ngandwe actually. We were co-moderating a session that was addressing infections in higher learning institutions, and quite a number of institutions participated. The University of Lusaka participated. Evelyn Horn did participate. We also had Cavendish University, the University of Zambia, and Levi Mwanawasa Medical University. So these are some of the issues that were discussed as issues that are leading to very high HIV infections in these higher learning institutions. And also some of these have been identified as stumbling blocks while young people are trying to access sexual reproductive health services within their institutions. Number one, for those institutions that have clinics provided, it has been noted that there is a lot of stigma while young people access these services from the healthcare workers. Also, it has also been identified that in some healthcare institutions that are dedicated to providing these sexual reproductive health services to young people, there is lack of awareness and information being spread about these services that are offered. For example, PrEP and PEP, there's certain young people that probably could not be aware of what is happening. And also, a few recommendations came up, but before I go there, another important factor that came up is lack of commodities, such as condoms, and this was actually a concern for all the learning institutions that were participating in the panel discussions. A number of recommendations came up, and one of them is that these higher learning institutions are ready or could be able to collaborate with organizations that are dedicated towards these sexual reproductive health rights and services to be able to raise awareness in the various institutions concerning these commodities, as well as curbing the stigma that is experienced by young people in these institutions. Also, easy distribution of all of these commodities that have been talked about could make it so much easier. And lastly, there was another recommendation that came from young people that just to be able to keep the stigma, maybe there could be an SHR dedicated hospital or clinic from within the institutions so that people feel free to walk to where they can access services and information. This, ladies and gentlemen, is what was discussed by the young people. Trust me, there was so much said, Zumani, I can tell you this, but from what has been discussed, this is what we came up as a summary. Thank you so much, and a big hand for the young people.
Jeremiah?
So, RAHi. RAHi. Okay, so I was co-moderating with Titi. I'm sure you all know Titi, the one who was from Zimbabwe. So, yes, my name is Nsambu Ani from Zambian Youth Platform, and I was co-moderating with Titi. So our question was the role of peer educators in HIV programming. And I must say, or admit to say, I had a very, very active group of peer educators from all the 10 provinces, as well as from the region. So one of the things or recommendations that came up was that peer educators, partners, I know you're here, and some of you have trained these peer educators,
But their concern was that you've trained them and you've abandoned them at the same time. Like they still have the old information, especially on HIV programming. They don't have so much information about it. And you've also neglected people with special disability, people with disabilities as well. You haven't trained them in any way. Most of them have been left out. So there's still a gap in HIV programming. And also, there are also other interventions that they feel to say can work in order to increase HIV prevention. And they said on internet, or rather the platforms, the social media platforms, there's so much information that is going on and misconception is right there. So they are asking if they can create a website that can be recommended to all the peer educators in Zambia, in the region, to say, if you go on this website, you're going to find the right information. And then some of them have a challenge. They will actually going to create a TikTok video that is going to talk about some of the messages that they want to be seen on these platforms, because they feel like the messages that you're putting on your platforms, they're too boring. And most of you partners and young people are not using TikTok in any way. Or if at all you're using it, it's not visible enough. So they're going to show us on how TikTok or how videos on TikTok should be done. Thank you.
Viva Youth Viva. Viva Youth Viva. Viva Youth Viva. Do we have young people in here? RAHi? RAHi? I was moderating the session to do with the civic leaders, and to the moderators and co-chairs who are not here, I'm happy to report that we had a very, very fruitful interaction. First of all, one key outcome from the conversation was that under the local government, on any project that is being undertaken, there's a 5% under capital projects that is dedicated to HIV prevention. So after doing an environmental assessment on any capital project that is happening, it is a must that 5% should go towards HIV prevention. Now the core is for us as young people, when we go back to our various homes, to go and hold our duty bearers accountable, because did we know that fact? Me, I didn't know. So I think when I just settle back home, I'm going to the mayor of the great city of Lusaka to go and ask what's happening with that 5%. Secondly, the most important thing was that supply is driven by demand. Did we get that? Can we say that together? Supply is driven by demand. So if there's no demand, there will be no supply. So the core is for us as young people to be able to drive the demand. Let us be able to demand for services. Let us be able to demand for information. Then our civic leaders will fall in place. The other important thing that I noticed from the conversation is that the government and the civil society, the private sector are doing a lot. Are we together? Are we together? The other important thing I noted was that it's very important for the civil society and the government to work together, and the office of the mayor of Mansa in particular, and all the other local councils. I know that their offices are open to the young people. Go and make your recommendations. Go and make your submissions. The other problem that we make is that when there's a call, for example, to be part of a district working group, a development committee, and we shun away from those opportunities. Now that is where decisions are made at the local council level. So the mayor was encouraging that we need to be able to begin to make submissions as young people, because as the local government, they are the facilitators of development and we are the implementers of development. So those were some of the few remarks, or few pointers that I noted. I will hand over back to the chairs. Not if you're mreto tansha fyumfwe. Ntoteren kilo. Ntoteren kilo. Igwe kilo. Who's going to lead into the Igwe kilo? Myself. Nemwinende editingira kilo.
Okay, I'll lead for you.
Excellent, Natasha.
Igwe kilo. Thank you so much, Jeremiah and Annie and Iga, for that recap on how the sessions went.
Thank you, Natasha. I guess we're about to call it a day now. It's been amazing. Where are the guys from Zim? Are the people from Zim still here?
Are people still in here? Or people are sleeping?
Okay.
Okay, let's see who's, because I see the back, it's empty, so it seems some people have left. So let's do a roll call. Let's do a roll call. So when I say a province or a country, just make some noise for me, okay? Do we have some people from Lusaka? Okay. Some people from Luapula? From Northwestern? From Western? Eastern Province? Northern? Did I say Northwestern?
Muchinga? Is Muchinga?
Muchinga? Anyone from Muchinga here? Central Province? Zimbabwe? Okay, I love that. I love that. Botswana? Zambia. I'm seeing some Zambians in there. Uganda? Ala, sorry. Atina tulabako ba Southern. Southern? Vakopalalaka.
You shouldn't have caught them.
I shouldn't have called our Vakopa. Now I'm still dominates. All right, lovely, lovely, lovely. It's good to see that everyone is here. Have I left out any province? Kenya. Some people from Kenya. Anyone from Kenya? Amazing, 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 amazing. All right. Okay, so we've come to the end of today's program. You guys have been amazing. Day 2, day 1 was lovely. Day 2 was over the top. Tomorrow is day 3, the last day, and we expect to see everyone. Everyone should be here tomorrow. We'll be giving out a position paper, and a lot more will be happening, a lot more giveaways. So to wrap up today's event, Zumani, would you like to say something?
Something.
Something, anything.
Okay. I think it's been an amazing day. Yesterday was the first day. It's like when you're building a house. So we laid down the foundation, and then we had a full pact today. And then we've learnt a lot. So we sort of built the entire house. And tomorrow we're going to paint it and wrap it up. I think I've got one question for you before we close the day. Are you smarter now when you first walked in yesterday and today? Of course. Okay, thank you. And also, I think let's give a round of applause and shout out to our ever-present online audience. They could not make it, but they've been very engaging, and they've kept the day going. And on that note, I've been your host for today, and I respond to the name Dabwitso Zumanipiri, and this has been my co-host,
Natasha Mwila. And just a last reminder, please make sure that you're here tomorrow very early. By 7:30, please be here so that we can start with registration and we can start the program on time so that we finish the day early so that we don't get into the afternoon session. DJ, Ichirwimbwachan. Mr. DJ, what song would you like? What song would you like to escort us out? Your Maps. Any song by Your Maps? Try again. And moderators or chairs, please stay back for a debrief. Moderators, chairs, please stay back for a little debrief. DJ, drop it. DJ, you're disappointing the people. Thank you, everyone. You've been lovely. How about DJ? Okay, someone has misplaced their diary. It's a black diary. If anyone sees a black diary, please bring it to the front. For your friends, they've lost a black diary. If you see a black diary, please bring it to the front. And for those that participated earlier in the dancing competition, please see us for your prizes.